Hello. Hello. Am I audible? Good morning. So we start with the oral paper presentation. Welcome you all to the Monsoon Conference of Pediatric Intensive Care Kolkata. We are so honored to have our esteemed judges here. We have Dr. Bijay Kumar Meher sir, who is in charge of the Pediatric Emergency and Intensive Care, PG Department of Pediatrics, SCB Medical College, SCBP, PGIP, Cuttack. He has more than 30 publications in national and international index journals in the field of pediatric intensive care, developmental pediatrics, allergy and asthma. Thank you, sir, for joining us here. We have Dr. Mukesh Kumar Jain, the Associate Professor, Department of Pediatrics, Kalinga Institute of Medical Sciences, Bhubaneswar, Odisha. He has more than 30 national and international publications, and he has been working as a pediatric intensivist in the biggest PICU of the state, accredited teacher of PICU, Secretary Intensive Care Chapter, Odisha State Branch. We are honored to have you, sir. We have Dr. Bipul Kumar Das, Assistant Professor, AIIMS Guwahati. He has more than 30 publications. He is a monitoring instructor, IIP ALS, BLS, and advanced NRP instructor. And we have our very own Dr. Kaustubh Choudhury. He is a consultant, Pediatric Intensive Care Unit, Apollo Multispeciality Hospital, Kolkata. He has several indexed international and national publications, and he is an accredited DNB examiner, DNB inspector, DNB pediatric exam coordinator, the zonal coordinator, IIP ALS, BLS, is zone. Now, I would like to request our first speaker, Dr. Shagata Karan. She will be presenting on point of care lung ultrasound in pediatrics, bronchiolitis illness, a prospective observational study at a tertiary care center in eastern India. So, we have 6 minutes for her to present, followed by 3 minutes discussion, the questions from the judges. And for these 6 minutes, we have a bell, warning bell at 5 minutes. Okay, there will be a short bell, and at 6 minutes, there is a long bell, that is your time up. Okay, anything else you want to ask for all the presenters? Okay, over to you, and all the best.
Good morning, respected judges, teachers, and my colleagues. Today I will be presenting my study on point of care lung ultrasound in pediatric bronchiolitis illness, a prospective observational study at a tertiary care center in eastern India. As we all know, bronchiolitis is leading cause of lower respiratory tract infection and hospitalization in infant and young children, and diagnosis relies on clinical finding and chest radiography, which has limitations in sensitivity, specificity, and exposes the children to ionizing radiation. Point of care lung ultrasound has emerged as a non-invasive and radiation-free diagnostic tool with potential application in pediatric respiratory illness. Our study was aimed to evaluate the utility of POCUS in assessing the disease severity and progression in pediatric bronchiolitis. Primary objective of our study was to characterize and describe the lung ultrasound finding in children less than 2 years with diagnosis of bronchiolitis, and secondary objective was to correlate the lung ultrasound finding with disease severity and outcome in terms of PICU requirement of respiratory support, length of PICU or hospital stay, and final outcome of the patient, and to correlate the lung ultrasound findings with modified bronchiolitis severity scoring. This was a pilot prospective observational study which was performed at Department of Pediatrics and Institute of Child Health with a dedicated pediatric emergency inpatient unit and PICU. We enrolled total 30 children ages 0 to 24 months presented with clinical features suggestive of bronchiolitis as per WHO or AAP guideline. And we excluded the children with known congenital heart disease, pre-existing chronic lung disease, and immunodeficiency disorder. In our bronchiolitis ultrasound scoring, we scanned total 6 areas, left and right, anterior, lateral and posterior, and scored each areas as follows. Presence of A line or less than equal to 3 B line as 0, more than 3 B line as 1, confluent B lines or waterfall sign as 2, and complete whiteout lung with loss of all A lines as 3. Also, we considered lung consolidation as an independent risk factor associated with bronchiolitis. So, we scored that as subpleural lung consolidation as 1 and solid lobar consolidation as 2, and total score varied between 0 to 18. And we compared this bronchiolitis ultrasound scoring with modified bronchiolitis severity score, which took into account oxygen saturation, respiratory rate, work of breathing, breath sound and mental status at the time of admission, and the total score varied between 0 to 15. We have reviewed some literature, and Supino et al. Conducted a prospective observational study named Point of Care Lung Ultrasound in Infant with Bronchiolitis in Pediatric Emergency Department, and they found a significant correlation between lung ultrasound scores and the need for respiratory support, suggesting that lung ultrasound can complement clinical assessment and improve prognostication. Oskaya et al. Evaluated lung ultrasound finding in bronchiolitis and showed strong correlation with clinical severity. We enrolled total 30 children, out of which 63% were male and 36% were female, and most of the children were between 1 to 6 months of age. The predominance of patients in the 1 to 6 months of age group suggests that early infancy is associated with more severe bronchiolitis requiring hospital admission. We have done BOS grade distribution across lung zone and showed that BOS grade 0 and 1 finding predominated all across the lung zone, with severe involvement was uncommon, and grade 3 changes observed only in the left posterior zone. The most of the children had mild bronchiolitis related lung ultrasound only. This is the heat map of lung zone distribution, which showed posterior lung zone demonstrated higher ultrasound involvement compared to anterior zone, suggesting its dependent pathology. Subpleural consolidation was also noted in the posterior lung zone commonly. For predicting the PICU admission, the mean total BOS was significantly higher among children requiring PICU admission compared with those who did not require PICU admission. This is the ROC curve of BOS predicting the PICU admission with area under curve of 0.87. Showed that BOS scored more than equal to 7 predicted PICU admission with 63% sensitivity and 100% specificity, supporting its utility as an early bedside prognostic marker in bronchiolitis. For respiratory support requirement, most of the patient required HFNC followed by nasal cannula, and around 16.7% required advanced ventilation. This is the BOS versus respiratory support requirement curve, which showed that mean rank of BOS increased progressively with increasing respiratory support intensity. We have also documented serial changes in mean BOS score over time. At admission it was 6.9, at 12 hours it was 6.73, and at 24 hours it was 6.57, demonstrating that POCUS dynamically reflects clinical improvement of the patients. This is the BOS score versus hospital stay curve, which showed that higher BOS score were associated with longer hospital stay, supporting BOS as a prognostic bedside marker in bronchiolitis. Out of total 30 children, 28 were discharged and 2 was expired, and both they occurred in BOS more than 10 group, showing a strong severity gradient. Children who had expired had substantially higher BOS scores than those who discharged. This is the finally this is the correlation of BOS score with clinical severity score in terms of MBS score, and which showed a significant positive correlation was observed between baseline BOS score and MBBS, and indicating that higher lung ultrasound scores were associated with greater respiratory distress severity. So as a conclusion, we can say that lung ultrasound abnormality predominantly involved the posterior lung zone. BOS strongly correlated with clinical severity, and higher BOS predicted PICU admission, greater respiratory support and longer hospital stay. POCUS is a useful radiation-free bedside tool for severity stratification in bronchiolitis. Our studies have some limitation. Small sample size limits its statistical power and generalizability. It was a single standard study which may not represent the broader population of children with bronchiolitis. Potential operator dependency, which we considered as a potential source of bias, but we tried to reduce it by doing lung POCUS by any one of the consultant most of the time. Limited etiological evaluation, short-term follow-up only during hospitalization, and post-discharge recovery was not assessed. Thank you.
Okay, Dr. Swagatha, it's a very good study. But how did you calculate the sample size for this study? How did you decide that 30 patients to be taken for this study?
So, this was a pilot prospective observational study, and local data regarding the bronchiolitis ultrasound scoring in bronchiolitis was not available. So, we took total duration of our study was 1 year, and we took all the children diagnosed with bronchiolitis in the meantime.
But there have been so many statistical analysis has been done. Does they hold good if you do not calculate a proper sample size?
We have targeted a sample size of around 35 in 1 year, and we achieved we took total 30 children in 1 year.
And who was doing the ultrasound?
By trained PICU consultant who was trained in doing point of care lung ultrasound. And we have tried to minimize the operator dependency by doing lung ultrasound by any one of the consultant most of the time.
And one more thing, you have taken score of 1, score of 2.
Yes, sir. Yes, sir.
And how did you decide that this will be score 1, this will be score 2?
Based on the previous studies, we have done various review of literature and shown that bronchiolitis ultrasound scoring was based on the presence of A lines and B lines. Much more B line was indicative of the more severe bronchiolitis, and then progressively waterfall sign, and then whiteout lung denotes the most severe bronchiolitis, and that's why we do the scoring like this.
What is new in your study?
Sir, this correlated the bronchiolitis ultrasound scoring with modified bronchiolitis severity scoring, which is a clinical scoring, and by doing this we can do the early risk stratification of this patient, and we can identify high risk groups earlier and intervene those patients early, do the early PICU referral for those patients, and improve the outcome.
What is your take home message from your studies?
That in any bronchiolitis patient we have to do, as it is a radiation free diagnostic tool and we can monitor the patient with repeated bronchiolitis, the disease progression, we should do a baseline BUA scoring at the time of admission and repeat it based on clinical needs, and monitor the disease progression and upgrade our respiratory support as per need.
So, like, you have done X-ray in these children or not?
We have not done X-rays. Those except in severe bronchiolitis cases or complicated bronchiolitis cases, we have done only with bronchiolitis ultrasound scoring only.
So without X-ray, you have done the studies?
Other than complicated bronchiolitis cases, we have done only POCUS.
Okay, thank you.
Thank you, sir.
Can I ask one question? Your finding was showing that posterior lower lobe was involvement in the left side was there. So is there any reason for that? So, or did you only one side? So left side.
So for dependent pathology, dependent atelectasis of bronchiolitis cases and accumulation of secretion mainly in the posterior zones. So that was posterior zone was mostly involved, but right side was also involved.
So well presented. So my query is that when you did that ultrasound on day of illness, as per the day of illness, or you just randomly did that ultrasound?
No, sir. We have done at the time of admission to show the to see the baseline scoring, and we repeat it at 12 hours and 24 hours, and again repeat it based on the clinical needs of the patient.
Okay, so there is another confounding factor. What I found is that there is a variation of the management, like support, respiratory support in the form of NIV, then your high flow nasal cannula, and then mechanical ventilation also. So do you think that actually acts as a confounding factor in your identification of ultrasound finding?
No, sir. Based on the, we have correlated the bronchiolitis ultrasound scoring with need of respiratory support, and we have seen that higher BUA score was associated with higher need of respiratory support, and that we correlated. We have not done we have not seen retrospectively that if it was associated with more increased BUA scoring or not.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Swagata. Our next speaker is Dr. Ananya Dev from RG Kar Medical College and Hospital. Her paper is on clinical outcomes linked with radiological patterns in adenovirus.
Good morning everyone. I am Dr. Ananya Dev from Department of Pediatrics, Arjikor Medical College and Hospital. Today I will present on our study evaluating the clinical outcomes linked with radiological patterns in case of adenoviral pneumonia. Adenoviral pneumonia is one of the important cause of severe lower respiratory tract infection. The incidence is about 5 to 10% worldwide. It is substantially associated with approximately 40 to 50% PICU admission and 8 to 22% of mortality in Indian settings. As illustrated in this slide, adenoviral pneumonia can cause various radiological findings ranging from A, patchy opacities, B, interstitial infiltrate, C, diffuse airspace consolidation, and D, lobar consolidation. The objective of our study is to find out the clinical presentation of adenoviral pneumonia and to determine whether radiological findings are associated with outcomes or not. The materials and method include: we have conducted a single-centered hospital-based prospective observational study with 53 RT-PCR tested cases for adenoviral pneumonia over a duration of 12 months between age group of 2 months to 12 years with children admitted through PICU, OPD or IPD of our department of Arjikor Medical College and Hospital. The study workflow we followed were children admitted in IPD or PICU with respiratory complaints or suggestive systemic viral complaints had undergone RT-PCR testing for nasopharyngeal or oropharyngeal swab on day 2 or day 3, and the adenovirus positive patients were included in our study based on the following inclusion criteria that were written informed consent from the parents, children with age group of 2 months to 12 years, and clinical radiologically diagnosed pneumonia. And on the other hand, the exclusion criteria were child with asthma or suspected in foreign body obstruction or tuberculosis or sepsis or with immunodeficiency disorder or confirmed bacteriological pneumonia. These are the following study variables as shown in the slide. Then the confirmed cases of adenoviral pneumonia were followed up over a period of 12 months for evaluation of outcome on the basis of discharge, death, and residual lung damage. We have found in our study that adenoviral pneumonia mostly affect children less than 12 years of age with slight male preponderance, and the duration of fever and respiratory distress were the common clinical presentation. In the outcome, we have seen that more than 60% of patients required PICU admission, and among them approximately 1/3 of patients required ventilator support, and in both of them duration of hospital stay and PICU stay was more than 7 days, with approximately 11% had disseminated infection. From the statistical analysis, it was found that radiological findings were significantly associated with outcome with a p-value of 0.027. And among them interstitial pattern and diffuse airspace consolidation has strong association with poor outcome in the form of death and residual lung damage. Odds ratio analysis also depicts the same result, that is interstitial and diffuse airspace consolidation has strong association with poor outcomes. So in the discussion, adenoviral pneumonia predominantly affects infants and young children between 2 months to 2 years of age with slight male preponderance, and the clinical presentation include fever, respiratory distress, conjunctivitis and the severity of disease is characterized by respiratory failure requiring PICU admission. In conclusion, adenoviral pneumonia is one of the important cause of lower respiratory tract infection, and radiological patterns has strong association with outcomes, and among them interstitial and diffuse consolidation is the early predictors of poorer outcome. So although our study is clinically relevant, but the generalizability is limited by single center study design and lack of adenoviral serotyping. I sincerely acknowledge the guidance and support of my colleague and teachers. These are the key references I have used. So thank you.
So in your study, when you have done this chest X-ray? At one point of time or at different times?
At different times, sir. In case of children required PICU, at first we have done in day 1, and in case the child required PICU admission, then we did on day 7 also.
And which chest X-ray findings you have taken into consideration while deciding the outcome?
Sorry, sir.
Which one you have taken, the day 1 or day 7 chest X-ray?
Both of them.
If both are different, then how you have decided? Are they same? Day 1 chest X-ray and day 7 chest X-ray?
Sir, in patient who have not undergone PICU admission, we have taken day 1, and in patients who have undergone PICU admission, we have taken day 7 chest X-ray.
And how could you say that your conclusion is overstated? You are telling the mortality and relating with it the chest X-ray, but there are so many confounding factors are there for the mortality. How could you say that the chest X-ray is the only factor which is responsible for death? You can say this is association.
Sir, we have studied the association of to determine the early prediction so that we can shift the child early to PICU. It is one of the factor, not the one and only factor.
But your conclusion clearly says that chest X-ray is the most important predictors, because there are so many confounding factors are there. How could you strongly say that this is the factors unless you do the multiple regression analysis? What are the factors associated with the outcome of the patients? And for that reason you have to do also sample size estimation, proper sample size estimation. Then can only we can say clearly. This can be an observational study which will show that these are the patterns of radiological involvement in case of adenoviral disease. It should not be a case of outcome analysis in adenoviral infection in relation to the radiological findings. Okay.
Oh, it is a very good study actually. So I have a question for you. So how this adenovirus pneumonia is different from other viral pneumonia?
So this adenoviral pneumonia is different in the form that it can mimic bacterial infection like lobar consolidation in chest X-ray findings, like gastroenteritis, conjunctivitis, in the form of severe pneumonia.
So if you do a CRP in such patient adenovirus pneumonia, what is the expectation? How the CRP behaves?
If we do CRP will be raised.
Like bacterial pneumonia, right? And what is the problem in PCR? RT-PCR you have done. So what is the problem in RT-PCR?
Sir, serotyping could not be done with RT-PCR.
And many times like multiple viruses are positive, na? So it's very you have excluded that, right? Okay, okay, thank you.
Dr. Ananda, one question regarding, you have said that adenoviral infection. Do you think this is only solely adenoviral infection, or you got some mixed infection also? Because in the age group what you have shown as from 0 to 12 years, in the older age group it is mostly the mixed infection, and it's a prolonged infection with adeno. So did you get any associated bacterial infection afterwards? And if those are there, then how you can say, how you can continue with that, or whether you excluded those things or not? And second, in your exclusion criteria, you mentioned about sepsis, and how you are removing your patients who is having sepsis. Even viral infection can produce sepsis, but you have given a bar of sepsis and nosocomial infection. I mean, you mean to say possibly the nosocomial infection rather than the sepsis?
Sir, sir, those patients who are positive for blood culture, we have excluded them in terms of sepsis.
Did you get any mixed infection, like any other bacterial infection associated with that adeno?
Yes, sir, we have got, but those are confirmed bacterial pneumonia cases. We have excluded them.
So, congratulations. And so, in all cases, less than 2 years of age, bronchiolitis is very common conditions. So, how did you select the cases where to send RT-PCR, or in all cases of respiratory distress, according to the workflow you have shown, all cases you have sent RT-PCR. Is it available inside, or you have to send outside adenoviral infection?
Sir, no, it is available in our department, in our Arjikar Medical College.
Okay. So, means how many cases you took, and out of how many cases you did adenoviral chem positive? And there are variable chest X-ray presentations are there.
Yes, sir.
So, is out of how many cases 53 you got positive?
Sir, out of approximately 400 patients, 53 was positive.
In 400 patients you sent the RT-PCR?
Sir, over a duration of 1 year, we have sent.
Okay. So, was it the follow-up, any difficulty in follow-up of these cases, because you have followed up for 3 months? So,
yes, sir.
if a child is cured from the disease, so it is very difficult to get, in follow-up studies we have seen, it is very difficult to get the children. So, how did you follow up? Was there any many missed cases?
We have called them on OPD basis after discharge, and we have followed for the severe cases. We have done repeat chest X-ray to look for chest X-ray, and HRCT to look for bronchiectasis.
No, I am not. My question is different. So, out of 53 cases, how many missed out in follow-up? So, or you could follow up all those 53 cases?
No, sir, we couldn't follow up all the patients because they have not appeared for OPD visit. The patients who have appeared for OPD visit, we have done the repeat chest X-ray or.
So, did you mention in your presentation like that how many missed to follow up, and how did you find out the outcome of those cases?
Sir, no, I have not mentioned.
Okay, thank you.
Thank you, Ananya. Our next speaker, Dr. Sheikh Nijamuddin Haq from Arjikar Medical College, and he is going to present his paper on psychological assessment of children aged 7 to 12 years in post-recovery phase following PICU management in a tertiary care hospital of Eastern India.
Morning to the respected judge and my fellow colleague. I am Dr. Sheikh Nijamuddin Haq. I am a pediatrics postgraduate trainee from Arjikar Medical College and Hospital. Today I am going to present my study, which is Hidden Burden of Critical Illness, Psychological Outcomes Following PICU Discharge. Though advances in PICU care have improved survival significantly, but a fair number of children may experience the psychological outcomes following PICU discharge. Particularly school-aged children like 7 to 12 years are vulnerable, and there are limited study on these post-PICU psychological outcomes. Therefore, the objectives of my study is to assess the psychological outcomes in children after PICU discharge, to determine the prevalence of anxiety, depression and stress post-PICU discharge, and to identify any PICU related factor which is associated with these adverse outcomes. This was a observational prospective study, and it is conducted at PICU of Arjikar Medical College and Hospital, and over a duration of 12 months. I have taken 7 to 12 years age group children who are stayed at PICU for more than 3 days, and the children with prior psychological or behavioral disorder, prior PICU admission, and neurological impairment are excluded at my study. And the sample size based on previous study, it was 48, but for better accuracy we take 100 sample size. Data collected for study variables like demographic and clinical profile of age, sex, primary system involved, duration of PICU stay, and invasive procedure or intubation. And psychological assessment was assessed on the basis of DSS-Y score. DSS-Y score after validation or after translating into vernacular language for forward and backward translation, the raw score was calculated from this DSS-Y score and then categorized the severity on mild, moderate, severe, and extremely severe. This is DSS-Y score. It's a questionnaire on the 3 domain of anxiety, depression, and stress, and each domain the score was calculated and then categorized mild, moderate, and severe categorization. I found at my study, we found at our study that 58% children are 7 to 9 years age group, and there nearly balanced gender representation, and respiratory system were primarily involved, followed by CNS condition. And most of the children stayed at PICU for more than 7 days, and 29% children undergone intubation, and 56% children undergone invasive procedures. The significant result I found at my study is that when you correlate the DSS-Y score of depression at day 1 and day 14 at 6 months of PICU discharge, there is significant result I found when the child is stayed at PICU for more than 7 days. Similarly, anxiety score was also significant when we calculate it at day 1 and day 14 and 6 months of age. Similarly, stress score is also significant, significantly correlated with PICU stay of more than 7 days. And when we correlate the DSS-Y score versus intubation, that we saw that intubated children consistently exhibit higher depression, anxiety, and stress score. Similarly, the child undergo invasive procedures showing significant higher DSS-Y score. So in discussion, anxiety was the most common psychological problem after PICU discharge, and depression, anxiety, and stress decreased, though it is decreased over time, but persisted in a substantial number of children at 6 months of age. And PICU stay of more than 7 days is significantly associated with DSS-Y score, and intubation and invasive procedures are linked to greater psychological distress during follow-up. In conclusion, psychological problems are common after PICU discharge, particularly if a child stayed longer at PICU, and early psychological screening and structured follow-up is necessary for this PICU survivor. There are certain limitations of my study, that it was a single center study, and I have taken a small sample size, and self-reported response of this questionnaire type may introduce bias, and follow-up is only limited for 6 months. Thank you.
Thank you, Dr. Nijamuddin, for this study. Actually, this is a very good study, and but what I find is, do you have any previous study which will show that the psychological causes like depression, anxiety, and this psychological problems are more common with prolonged ICU stay and with intubation? Any literature you have seen?
Literature I reviewed some literature.
What is the percentage?
All studies are available in abroad. In India, there is limited study available for this.
No, what is the prevalence? What is the prevalence of the psychological? After PICU discharge, what is the prevalence, and what is the prevalence when the duration of ventilation is more than 7 days?
I don't.
But what I find is a very good study. You have rightly taken a PICU population. And what time you have done this?
I have
After
done
discharge?
this at, after discharge at day 1, during discharge, day 1 and day 14 and at 6 months during follow-up.
And all your data are related to day 1 or day 14 or 6 months? Which one? All the calculations what you have done and the percentage what you have calculated?
Sir, I calculated each section. At day
Day
1
one, day
result and
14.
day 14 result and 6 months result. Each section I correlate with p-value.
Okay. Okay.
So you have presented well, and before that you have taken many cases. And if a child comes to emergency with who needs intubation right at that moment, so did you exclude those cases, or you took the history for any psychological previous problem in that child? It was history based.
I have excluded.
Only history based, or was there any? How could you exclude those cases?
Sir, I have excluded on the basis of if the child is have prior psychological problem like ADHD or that type of issues, I have excluded in my study, and any terminal illness or neurological problem I have excluded for better result.
If a child comes with seizure and suppose this child has come with pneumonia and required intubation, that child, did you exclude those children? On suppose well controlled seizure is there.
If the child is fast episode of seizure, then I included in at my study.
So that is
but if a child is prior neurological problem, developmental delay or something, then.
So you have mentioned about intubation and procedures. So what measures you followed in your ICUs, or like what your study will recommend for future decreasing this anxiety and psychological issues? So will you give any recommendations or any suggestions from your study?
Proper pre-medication, proper sedation is necessary for this psychological, to reduce the psychological outcome.
Okay.
So you mentioned about in your study that inclusion criteria is more than 3 days of PICU stay. How you calculated that 3 days, or is it from the any other previous study?
Sir, I have taken more than 3 days because if less than 3 days is, then it is not significant. Proper exposure to PICU is not getting, the child is not getting proper exposure if I taken less than 3 days. So I taken more than 3 days. At that time, proper PICU exposure, the child is getting proper PICU exposure. And
so it is your assumption to stay more than 3 days will cause psychological issues in children in PICU?
No, sir, assumption, but.
So, how many samples you have taken?
I have taken, sir, 100 samples.
And you have followed all the 100 children at 6 months of follow-up?
Yes, sir.
Huh?
Yes.
Really? This is a difficult thing, why I am asking, because every child discharged from hospital, 100 children have taken, and at follow-up at 6 months is quite difficult thing.
Actually, sir, I did this study with my seniors.
So how did you follow up? It is over phone or it is directly that physical follow-up was there?
Over phone, or if the child is came to OPD, then we.
So that should be mentioned in your methodology or your presentation. It is not mentioned like how.
What I found is always these follow-up studies are very difficult.
Yes.
And second thing, have you involved any psychologist or psychiatry people in this study?
Yes, sir, I involved.
You have mentioned?
No, sir, I didn't mention that long list.
And who has answered all these questions you have put? Who has answered these questions? So 60% children are 7 to 9 years in your study. Are they able to answer all these questions? Depression, anxiety and all these things?
On the help of the parents and.
Okay. Okay.
Sir, this is not validated at all now. Various studies going on to validate this score. I have converted it to vernacular language and forward and backward translate it, and then did a pilot study, and after this I taken some. Yes, from ethical clear. Scientific committee. No, sir, for adults there is a DSS 21 or 42 score. there, but this is for particularly youth, DSSY youth score. Thank you.
Our next speaker, Dr. Shishmita Dutta from SSKM Hospital, and she is going to present her paper on functional status trajectories in pediatric survivors of intensive care, a prospective observational study in a tertiary care of Eastern India. And I would request our esteemed judges to kindly maintain a time of 3 minutes for questions. Thank you.
Good morning, judges and everyone present here. I am presenting my study titled Functional Status Trajectories in Pediatric Survivors of Intensive Care, a prospective observational study in a tertiary care center of Eastern India. With advances in pediatric intensive care, we have significantly improved survival rates, but the survivors often experience new and worsening physical, cognitive, emotional, and social impairments. Thus, assessing functional outcomes post-PICU admission is essential to understand the long-term morbidity and the need for rehabilitation strategies. Our primary objective was to assess the functional status at baseline, at PICU admission, at discharge, 3 months and 6 months after discharge. We further evaluated the associations between illness severity, length of PICU stay, duration of mechanical ventilation, and functional status at 3 and 6 months. We also assessed the functional outcome across different diagnostic categories. Materials and methods. The study period was 12 months. The study population, children fulfilling inclusion criteria who were admitted in PICU of our institution. The study design was single-centered prospective observational study. The sample size was 180 patients. We included them by consecutive sampling method. Inclusion criteria, children aged 1 month to 12 years admitted to PICU. It had to be first admission in PICU. The caregiver or the parent were available for 6-month follow-up. The exclusion criteria were children under legal custody, death within 24 hours of PICU admission, and children with pre-existing severe baseline disability with FSS score more than 16 at baseline. After obtaining an ethical clearance from institution, the baseline demographic data were collected. PRISM 3 score was done at PICU admission. The functional status score was done at baseline state, FSS score at PICU admission, at PICU discharge, at 3-month and 6-month follow-up were calculated and analyzed with the baseline. Coming to definitions, the baseline functional status score was the FSS score at just prior to the PICU admission. The baseline FSS score was collected retrospectively through a questionnaire from the parent. New morbidity was the change in FSS score of more than equal to 2 from baseline. This was the FSS chart that we used during our study. The study tree, 180 patients were eligible. 28 patients had expired during PICU stay. We had 152 patients at discharge. With loss to follow-up and death during follow-up, we had 140 patients at 3 months and 128 patients at 6-month follow-up. Coming to results, the baseline characteristic of our study participants, the mean age was 4.49 years with a male is to female ratio 1.4 is to 1. 21.11% had chronic illness. The PRISM 3 score mean was 11.78 with the incidence of new morbidity at discharge 3 month, 6 month were 27%, 8.3% and 4.4%. Coming to the distribution across diagnostic categories, the most common patients were from respiratory pathology. Thereafter, there were CNS and CVS pathologies. The trend of overall functional status score across the study timeline, we see the functional impairment was peak at PICU admission with progressive improvement at follow-up and near complete recovery at 6 months. This is the comparison of different domains of functional status score. All the 6 functional status domains were severely affected at PICU admission, with feeding and respiratory function being the most worst affected at admission, while we see the mental status and the motor function being the worst affected throughout follow-up. Functional status score across diagnostic categories. The CNS pathology followed by oncological pathology were the worst affected. Here we see the trajectory of CNS pathology being the worst affected, indicating their highest risk for long-term morbidity. This was the functional status score according to the PRISM 3 category. PRISM 3 category had, with higher PRISM 3 category, had higher FSS at admission. With this moderately severe affected, had persistent residual morbidity even at 6 months. The functional status score with length of stay, longer length of stay, had higher FSS score with near complete recovery at 6 months across the 2 groups. The functional status score in ventilated and non-ventilated patients, we see the ventilated patients had worse functional impairment at admission, and also the ventilated patients had persistent residual morbidity even at 6 months. The more the number of ventilator days, the more was the FSS score at admission with recovery at 6 months. Now, incidence of new morbidity had declined from 27% to 4.4% at 6 months in our study, with worst affected FSS at baseline, from baseline at admission, with neurological category being the worst outcome, and the domain with worst outcome were motor and mental status. This was inconsistent with the following previous studies. Thus, the functional status score at admission statistically significant difference from baseline, with respiratory function being affected most during PICU stay, higher PRISM 3 score, longer PICU stay, and longer ventilator support had worse functional impairment, with CNS pathology showed poor recovery. Limitations of our study: this was a single center study with limited generalizability. Loss to follow-up during longitudinal assessment led to attrition bias. So the functional status score represents a paradigm shift from survival focused critical care to outcome focused critical care, ensuring that the success of PICU treatment is measured not only by lives saved but also by lives restored. Thank you.
Okay. Thank you, Dr. Suchesmita, for this study. It's a very nice study. One of my concern is that you have a lot of patients who are having a low functional score at discharge, and you are following them up to 3 months and 6 months. But are they receiving the same care? Those who are having a poor functional score and those who are receiving a normal or better functional score.
So during follow-up?
During follow-up. They are simply observed, or they are being given different type of care?
They are being observed, as well as they are followed up if they need any psychological support post PICU discharge. And but usually the patients with poor functional status score at discharge are they were followed up, and they were given help through physiotherapy, occupational therapy, neurodevelopmental clinic, neuro.
No.
Yes, sir.
Prior to this study, is this a routine thing of doing a functional score for your PICU patients who are getting discharged?
No, sir.
For this study, this has
For
been done.
this study, we had done.
So once during the course of the study, suppose you have seen a functional score is very bad at the time of discharge, are you advising the parents to go for some different type of intervention, or they are receiving the same care as everybody is getting? Or do you have any special program for that?
We have the neurodevelopmental
Early
clinic.
rehabilitation or early intervention for those babies who are having a
Yes,
poor.
sir. We have the
functional score.
neurodevelopmental clinic where we, from the discharge, we refer the patients and they are being followed up and they get the support.
Because if they are not getting the same care, then it will be difficult to interpret that this category of patients are poor outcome and they are recovering and they are
So
not
we are
recovering.
assessing the functional status and then we, if they have any
But
impairment.
Interventions is the co-founder, no?
Yes, sir.
You mentioned about some chronic conditions associated with this. So, do you calculate FSS on those chronic conditions? What are those chronic conditions? And then, if that in those conditions where the FSS score is high, or whether it's just like your initial for other patients also?
The FSS score are high for these patients, but we are comparing this with the baseline for individual patients. Baseline is the prior to the acute illness they have been admitted in our PICU. So we are comparing with the baseline of individual patients, whether it was chronic illness or acute illness.
My only concern is follow-up.
Yes, sir.
Have you genuinely follow up this all the 180 children for 6 months?
Sir, 180 children,
I seriously doubt on this thing only. That is the only concern I have.
Sir, there are lots to follow up. In my case, there were lots to follow up around 38 patients. There were lots to follow up, and
Okay, thank you.
yes. Okay.
Last, so was there any psychologist involved in this case, child psychologist or psychiatrist in your study, mental status follow-up? Because neurological conditions, prolonged ventilations and CNS involvement, so these are known cause which will have a permanent or longer duration of problem functional status. So for any psychologists involved in your study?
No specific psychologists were involved, but we referred the patient to our psychological department.
Thank you. Our next speaker, Dr. Sakshi Singh from Medical College, Kolkata. And she is going to present a paper on NT-proBNP as a surrogate marker of disease severity and treatment response to IVIG in pediatric viral myocarditis, a preliminary observational study. And once again, I'll request judges to please stick to time.
A very good morning to one and all present here. I am Dr. Sakshi Singh from Medical College, Kolkata, and I will be presenting my paper on NT-proBNP as a surrogate marker of disease severity and treatment response to intravenous immunoglobulin in pediatric viral myocarditis. Viral myocarditis is an inflammatory disease of myocardium triggered most commonly by viral pathogens. Annual incidence is around 1 to 2 per 1 lakh children. It accounts for 20% of unexplained dilated cardiomyopathy. Clinical spectrum ranges from subclinical diseases to fulminant cardiogenic shock or sudden cardiac death. NT-proBNP, the biomarker we have used, is released by ventricular cardiomyocytes in response to stress. Elevated NT-proBNP levels correlate with degree of ventricular dysfunction, half-life of 60 to 120 minutes, and it being more stable than BNP was preferred criteria for using NT-proBNP as a biomarker for evaluation. As per previous studies, levels more than 2738 indicate severe myocardial compromise in pediatric population. Some of the literature previously available, but the literature gap is that there is no pediatric study which has used serial NT-proBNP as a primary surrogate to assess myocardial dysfunction and quantify IVIG response in a PICU or NICU cohort. Our primary objective was to evaluate treatment response to IVIG using serial NT-proBNP measurements in children with viral myocarditis in our PICU and NICU setting. Secondary objectives were to identify NT-proBNP and left ventricle ejection fraction thresholds discriminating IVIG responders versus non-responders, and to compare heart rate and EF before and after IVIG administration in responders versus non-responders. It was a retrospective observational study done over a period of 6 months. The population was children admitted with viral myocarditis receiving IVIG at the rate of 1 gram per kg per day for 2 consecutive days, sample size of 20 with age range between 1 month to 9.5 years, and left ventricular ejection fraction calculation was done by linear method Tichols formula. Inclusion criteria included 1 month to 12 years of age group children admitted at our PICU and ICU with the preceding viral illness. The viral etiology was confirmed by real-time PCR, persistent unexplained tachycardia with cardiorespiratory distress, a raised NT-proBNP more than 2738, and 2D echo showing depressed ejection fraction, having received IVIG therapy. Exclusion criteria included any other known cause of myocarditis or cardiomyopathy, sepsis, chronic kidney or liver disease, previous IVIG within 6 weeks, or incomplete data. So our patient profile, we had 20 children, 15 survived and 5 had poor outcome, age range between 1 month to 9.5 years. Here we see the NT-proBNP variation before and after giving IVIG in survivors versus non-survivors. The NT-proBNP fall in survivors before and after IVIG was from 12,200 to 1,900, whereas in non-survivors also we have witnessed a very steep fall from 19,000 to 1,200. So this shows that it was not an outcome discriminator. Again, heart rate variation has been quite similar between survivors and non-survivors before and after giving IVIG. In survivors, heart rate fell from 162 to 112 and non-survivors 160 to 122. So tachycardia resolution reflects a hemodynamic recovery, however, it was not an outcome discriminator. Coming to ejection fraction recovery before and after IVIG, we witnessed that in survivors, the ejection fraction recovered from 47 to 66%, while in non-survivors, it plateaued at 28 to 36%. LV ejection fraction recovery is the true discriminator of survival in our study. Comparing the parameters between survivors and non-survivors, NT-proBNP fall was 89% in survivors compared to 72% in non-survivors, and thus p-value was not significant. However, the ejection fraction improvement was 48 to 66 in survivors and 32 to 43 in non-survivors with a significant p-value. So NT-proBNP percentage fall was similar in survivors and non-survivors, but LV ejection fraction pre-IVIG less than 40% was a stronger predictor of death. The ROC curve shows that LV ejection fraction area under the curve was 0.987 with a sensitivity and specificity of 100 and 93% respectively. So ejection fraction being the true marker of IVIG response and true discriminator of the outcome and not NT-proBNP alone. We also witnessed the data of older children having higher mortality. However, the sample size is too small to definitively comment on it. So our study, the key finding was ejection fraction less than equal to 40% pre-IVIG contributed to poor outcomes. And it is the dominant predictor of non-survival. The limitations of the study was a small sample size, retrospective design, a single center study, NT-proBNP was measured at a single point post-IVIG administration, and ejection fraction calculation is operator dependent, and there was no long-term follow-up. In conclusion, NT-proBNP fell dramatically in all 20 patients, including non-survivors, so BNP fall alone should not be used as a sole IVIG response markers. Ejection fraction pre-IVIG less than 40% was identified in all 5 deaths with area under the curve of 0.987, so that was a dominant predictor of non-survival. And ejection fraction non-recovery post-IVIG defines the non-survival phenotype. Serial NT-proBNP plus LV ejection fraction should be incorporated into monitoring protocols for pediatric viral myocarditis. The future of our study is, this was used as a hypothesis generation and we would want to follow it up with prospective RCT, confirming the diagnosis by virological PCR and continue to do a 6-month follow-up at a multi-center PICO network. Thank you.
So how many cases of Parvo V19 you got in your series?
So in this sample size, we did not have Parvo. We mostly had adenovirus and enterovirus associated with myocarditis.
And what is the half-life of anti-proBNP?
60 to 120 minutes. 60 to 120 minutes.
Half life?
Yes, sir.
60 to 1?
20 minutes.
20 minutes.
Yes, sir.
Okay. So, and you have done it after 48 hours?
Sir, first was within 24 hours of admission after getting the first high NT-proBNP value, and the second was at 48 hours after giving IVIG.
After giving IVIG. Okay.
All 20 are positive for virus?
Yes, sir. We had confirmed by real-time PCR.
Okay.
Thank you, sir.
Our last presenter, Dr. Minal Desai from Narayana Super Specialty Hospital, and she's going to present a paper on the use of Kaizen by nurses for preparing airway trolley in Pediatric Cardiac Intensive Care Unit.
Good morning, everyone. My topic for today is the use of Kaizen by nurses for preparing airway trolley in a pediatric cardiac intensive care unit. So we all have come across a situation in a cardiac ICU where a child suddenly deteriorates and requires emergency airway management. So in such a scenario, it is a high stress zone and we expect 0 errors, and every minute is important. However, we often see that there is a lot of variation in the airway trolley preparation by our staff, which leads to delayed responses, increased errors, and increased wastage. Hence, I wanted to explore the idea of the Kaizen philosophy and how it has transformed our airway readiness, nurse confidence, and patient safety. So what exactly is Kaizen? It is a Japanese philosophy whose core is that you don't try to bring a major system overhaul. Instead, you focus on small, continuous changes which are driven by our frontline workers so that we are more prepared with our airway trolleys. This philosophy has also been extensively used by companies such as Toyota. Hence, we hypothesize that Kaizen-based standardization will reduce airway trolley preparation time and errors in our PICU. And the objective of this study was to evaluate the impact of these principles on airway trolley preparation in our 10-bedded PCICU. So this was a 12-month prospective study between January to December 2024, and we divided it into pre and post Kaizen. The first 6 months were pre-Kaizen and the next were post-Kaizen. We had 18 participants who were our nurses, and we essentially first mapped out our workflow, which was our existing workflow. Then we identified what all waste was occurring in terms of unnecessary movement, search time, redundant items, and lack of standardization. We then went on to standardize the entire process of airway trolley preparation. We organized the equipment, we verified the functionality, we labeled them according to different colors, and we labeled specific drawers also. We defined the quantities, and we also ensured that there were visual cues in forms of posters, checklists, and worksheets. This helped our nurses to feel more prepared during emergencies, and we ensured that there were enough emergency drill audits. So in terms of the parameters measured, we measured our efficiency in terms of the time spent on the airway trolley preparation. Our safety was measured in terms of frequency of errors in preparation. Thirdly, we measured the response time during emergencies, our waste reduction, and finally our nursing satisfaction with a Cronbach alpha of 0.86, which shows excellent internal reliability. And we collated all this data using Metcalc 20, and we compared it with paired t-tests. Our significant value was less than 0.05. So our results were quite dramatic. In the pre and post Kaizen months, we saw that our response time decreased by 55%, our prep time reduced by 42%, and errors reduced significantly by 74%. And of course, we know that in a cardiac ICU, minutes and seconds matter. The most important thing here was that our nursing satisfaction also improved dramatically. Their confidence increased, their stress decreased, and this translated to better teamwork, and they could redirect all of that time, which was wasted in the finding of things, and it translated into better patient outcomes as well. So this was the nursing survey, which we were regularly carrying out with our nurses to measure the stress levels in our nurses. So discussion and conclusion is that in a PICU, we often don't need an expensive procedure or an invasive monitoring device to improve patient management and outcome. Sometimes something simple can also improve patient outcome and management, and especially such lean studies have been performed globally as well. For example, at Keynote et al. And Koike et al. And the efficiency gains in our study were substantial, which enabled our nurses to redirect their time, as I said, to direct patient care. Most importantly, this standardization is also scalable, it is low cost, and it can be easily applied to other fields also, such as the OR, the transport, the ECMO, and the crash carts. A few limitations of this study were that it is a single center study, the sample size is a little small, and it is a short 6 months period, and there can also be possible Hawthorne effect. So with Kaizen, we wanted to work smarter, faster, and safer, but not harder. And this paper has also been published in the SAGE journals. Thank you.
Okay, so this is a QI study.
Sorry,
quality.
sir?
This is a QI study, quality improvement.
Yes, it's a quality improvement study.
So how practically you have measured that time spent for airway preparation?
So, sir, we were actually a team of 3 people. We had a quality person involved in this from the management side, our ICU consultant, and our registrars. So, whenever we were planning a drill or there was an emergency situation, we ensured that we are calculating the response time.
So they are not the part of the treating. Those people, those who are evaluating, they are not the part of the treating.
So, sir, apart from the ICU consultant, sir, no, they are not part of the treating team. The treating team is the nurses and the ICU consultant and the registrars.
And the pre-Kaizen period, how much period you have taken for
So,
pre-Kaizen?
6 months.
6 months.
Yes, sir.
So during that time, we were just simply observing.
Observed, yes, sir.
And the team are also not aware of that. The ICU
No,
team
sir,
are
no,
aware
sir.
of-
In
not
the
aware of that?
pre-Kaizen period, they are not aware about it.
Okay. And in
So
post-
we wanted to minimize as much bias as we can. Of course, if you are being observed, every nurse and every doctor will behave differently. So we tried to minimize that bias, and that's how we proceeded with the study.
But the parameters what is to be measured is likely to be problematic. It's difficult. It's a difficult task to-
Yes, I
What is the
mean-
wastage? What is the error? What is the time spent? All these things are very difficult thing to measure.
Yes, sir, which
practically.
is
So
why we
the
have already
measurement bias
measured
is
it, and
always-
we would want to standardize it. Since we saw that our results were astounding, we would now, move on to translating it into patient care and standardizing our other trolleys and airways also.
Okay. Thank you. Thank you.
Dr. Meenal, in your presentation, you talked about your principles, how you use the Kaizen. So you are not talking about when there is an error. What are the debriefing or feedback to the person who has done this error? So is there any provision for that one?
Yes, sir. In our last step, we do have Kaizen huddles where we discuss with the nurses, especially in the pre-Kaizen zone, that what caused them stress, why was there wastage, and why was there they were not prompt enough to deal with the emergency. So that is how we moved forward into the post-Kaizen zone. So that is initially we mapped out all the items which were wasted or the errors which occurred, and then we devised a plan or a trolley in such a way that all these errors and time lost can be reduced.
Thank you. Just related to this study, so what is fishbone analysis in quality improvement initiatives studies?
So fishbone analysis, it is another lean method of study where we try to be more efficient by, I think, reducing the wastage and involving more of our frontline workers.
No, finding out the factors which can affect the outcome. Means suppose if in you are wasting more time in arranging the trolley.
Mm-hmm.
Suppose what are the factors that are leading to that finding out the factors. So you'll have to analyze those factors. Basically, that is the mainly fishbone.
Okay, sir. Thank you, sir.
Thank you, Dr. Meenal. With that, we conclude our oral paper presentations for today. We now move on to our next sessions. The next couple of lectures will be focusing on the respiratory system. Our first session will be chaired by Dr. Subhashish Bhattacharya sir, who is HOD and Professor, Department of Pediatrics, Chittaranjan Shishu Sadan, Kolkata. I request sir to kindly take his place on the dais. Our first speaker for this session is Dr. Muhammad Ali, who is a visiting consultant PICU at Medical College, Kolkata, and he will be speaking on prawn without tubes, awake prawning in children.
Okay, Dr. Ali, you can start.
Thank you. So the chairpersons, the faculties, the delegates, and the organizing committee. So it's very good morning to all of you. This is the first presentations for the today. So I will be talking about the prawn without tube, egg pruning in children. So egg pruning in children is relatively new. If you go to the history in the literatures, it is relatively last 5 to 6 years. But prone position of ventilation is not new. It is around 50 years since its inception to the standard of care. So simply, if you lie down from the standing to supine positions, then our FRC reduced by 20 to 30%, our compliance, lung compliance reduces, and the VQ mismatch, particularly the shunting effect in the dorsal or the lower zone is increased. So if you just simply turn the patients from the supine to prone positions, you will have lots of this lung mechanics benefit and will have better oxygenations and ventilations. So this is not a new concept. So prone positions on mechanically ventilated patients, it is more or less the standard of care. The recent PALIC 2 guidelines also suggest that we can use this prone position of ventilations if in the moderate to severe ARDS, if the patient is having refractory hypoxia with our conventional mode of ventilations. So if you want to have this benefit, you have to start it early in the 48 to 72 hours. It has to be prolonged 12 to 16 hours, and it has to be with the other lung protective mode of ventilations. So it took around 12 years, like 2001 to 2013, till the procedure trials, how we have to use the prone positions to have most benefit. So how this prone actually increase our ventilations and the gas exchange mechanisms. So as I have already told you, like if we intubate and use the anesthetic medicines, then our most of the alveoli will stay here or here. So normally in supine upright positions, most of the ventilations occur here. So if you intubate the patients, the most of the alveoli will be here, like it will increase the west zone 3, or it will go to here, it is the west zone 1. So here we are increasing the dead space ventilations, and here we are increasing the shunting. So overall, our VQ mismatch is worsening and there is hypoxia. So as per the baby lung concept, if most of the lung alveoli get collapsed, so the stress and the strain or the remaining alveoli will be high, so it will cause more VLI and ventilator-associated lung injury. So if you just simply turn the patient from the supine to prone positions, you will have all these factors that will be reversed back and will have better ventilations and the oxygenations simply by increasing our FRC and the VQ mismatch. So I have already said that it will also reduce the ventilator-associated lung injury. So this prone positions, it is beneficial. It is not a new concept. So first, the prone concept was like imbibed by these two persons, there is the Allisons and this Brian. So they are both the anesthetists, and they found that in the supine positions under the anesthesia, there is uneven ventilation, particularly the dorsal lung get collapsed. So if the prone the patients, there is more uniform diaphragmatic movement and better dorsal lung ventilation in the VQ mismatch. And their hypothesis was tested by these two studies. So ultimately, it became more or less like in practice from the 19 and 1907, but there was no significant like homogeneity or the consciousness on that. So now the recent concept is, if you do the same thing in the AVAC patient who is not ventilated, so whether we will get the similar benefit. So if I summarize, we will get the benefit, particularly in terms of the oxygenation improvement and to some extent, like it decrease the work of breathing and so on. So this is the timeline of our this prone positions ventilation concept. So AVAC proning started here around in 2020, particularly during the COVID time, most well studied in adult with COVID. But in pediatrics, the most significant study is this study that was done with only 14 children with bronchiolitis, and that shows there is significant decreased work of breathing and the oxygenation parameters. So in adult versus pediatric AVAC pruning, if you go to the literatures, so there are lots of literatures in the adult, but in pediatrics the literature is very limited. And in pediatrics the benefit is it reduces the work of breathing, and in adult, but there is a tendency to reduce the need for intubations. So this is the number of study. In adult you will have more than 300 publications, but in pediatrics only 15 to 30 publications. And RCT will have around 17 to 18 RCTs in adult, but in pediatrics, one RCT that is very like a small study with 14 sample only. So these are the all studies and evidences on adult, in pediatrics with AVAC prone ventilations. And if you go to the the evidence in this all the studies, it shows there is improvement in the oxygenations and the ventilations, but the mortality, ICU stay and the ventilation stay, there is limited data and we need more study. So this is the key study in AVAC pruning in pediatrics. So it was a prospective randomized crossover trial, and it would include 14 infants with severe bronchiolitis. And key findings were it reduces the inspiratory efforts, neural drive, improve the diaphragmatic efficiency, and better clinical like work of breathing score. So their conclusion was strong physiological support for AVAC prone in severe bronchiolitis infant. So in evidence, so improved dorsal recruitment and reduce the work of breathing, excellent safety profile, low cost, and there is strong adult supporting data. But the problem is there is lack of large multicentric RCTs, and there is heterogeneity, and these studies include only short duration of prone positioning, and there may be potential bias. And in children, another problem is there is a need of cooperation with the AVAC patients, particularly the toddler, and there will be some difference in the your developmental problem. So we can't like make all children to prone. So we should have like hypoxic respiratory failure. Child should cooperate and tolerate, and he has to be hemodynamically stable and able to protect the airway. Otherwise, it cannot be done. So this is the protocol that we use in intubated patients that can be also done for the non-intubated patients. So most important thing is we should have a trained team. We have to explain the parents and the children. We should take baseline vitals, oxygenation status, hemodynamics, secure the all lines tube, and at least stop enteral feeding for 30 minutes. So we have two positions in the prone positions. So we should keep as long as possible 2 to 4 hours per session. But if we keep more like durations, then the benefit will be much better, and we have to monitor the patient continuously. So if there is a problem like vomiting or low oxygenations or any displacements of the lines, then we have to turn the patients in the supine position. So it is generally well tolerated, and major problem is sometimes maybe the pressure injury in 5% of the patients. So if I summarize, there is more evidence, particularly the ventilated patients, and less evidence in the AOC patients and more evidence and solid evidence in the adult patient in AOC prone ventilations rather than in the pediatric patients. So it is physiologically promising and safe, and it should be considered as a selective adjunct in a suitable PUC patient, but should not be a standard of care as of now, and we need high quality RCT for these answers. Thank you all.
Thank you, Dr. Ali, for mentioning briefly the benefit of proning, both in ventilated and non-ventilated. Can we take 1 or 2 minutes for any question from the house organizer?
2 minutes, sir.
Why did you say that you cannot do enteral feeding? What about the orogastric tubes?
So in the protocol, if you prone them and immediately after the feeding, there may be compression in the stomach. So still in orogastric tube, you can prevent the aspiration risks. Like in orogastric tube per se will impact the lower esophageal function per se. So there may be chance of aspirations. So in all protocol usually is like delayed. We can give continuous feeding probably. Yes.
I have a question. You told that the proning is beneficial in bronchiolitis.
Yes, sir.
So small baby less than 6 months or less than 1 year with a bronchiolitis, there is another risk factor for continuous proning, that is SIDS, sudden infant death syndrome. Is there any association, or it should be monitored, because that is a
monitoring
risk point
will be in the PICU. So it is a continuous monitoring like heart rate, respiratory rate, saturation. It is a continuous monitoring. And sir, we need this answer. Like it is a 14 sample, like 14 infants. So we need more study to answer this question, whether it is beneficial or it will have some more negative effect. So that we have to see, sir. Yes.
Okay, thank you.
Yes, we need some sedations, and most important thing to be successful is cooperation of the child. So cooperation is most important. So this is the one drawback of adult pruning. Yes. Thank you. Thank you.
Thank you.
Thank you, Dr. Ali. Our next speaker is Dr. Agnishekhar Shah, who is a consultant pediatric intensivist at Apollo Multi-Specialty Hospital and Institute of Child Health, Kolkata. He'll be speaking on driving pressure in Willy. Are we ventilating safely?
So thank you, Dr. Shah. This is another very important topic. Please, it's now your time.
Hi, good morning, everybody. So that's the topic, driving pressure. Yeah. What we will talk about, why driving pressure, this one, and it has made quite a lot of buzz, why this driving pressure, what is the evidence, and as of now, what can we learn from this evidence and what we can apply in our practice. Let's try that. This is the GOAT, the all-time great study. As long as ARDS is concerned, 26-year-old now, the ARDS net study, which has changed our practice, and all it said is, number one, your tidal volume should be related to your body weight, so that you should give 6 ml per kilo of body weight, okay? And then it also says if your peak pressure is more than 30, then you can come even lower than that. That's the key message, okay? 26 years ago. And now we are still trying to figure out what is the next breakthrough. What can be better than this? So that's the perspective, okay? What can be better than ARDS net? We know this already 26 years ago. So what is driving pressure? It's the P flat minus PIP, okay? Now for the juniors here, I think this P flat causes a lot of confusion, and for taking with a little bit of chance of error, let's say this P flat is equal to PIP, especially if you are doing pressure control. You are not too wrong, you are more or less right, especially if you are doing pressure control. So P flat more or less equal to PIP, okay? So we know compliance is equal to delta V by delta P, and you just rearrange that, and then it becomes, oh dear, what has happened? It's all sort of jumbled up. So sorry about that. So if you just rearrange this, then your delta P becomes your delta V by compliance, okay, or tidal volume by compliance. So your driving pressure is nothing but your tidal volume by the compliance of your respiratory system. Okay. So if we are in ARDS net, what we have done, we have normalized our tidal volume by the body weight. And in driving pressure directed ventilation, we are normalizing our tidal volume as per the compliance. Why so? The ARDS net study says that if you are weighing more, your lung is bigger. So your tidal volume should also be bigger. Okay, and that's true. That's possibly not that true when you are dealing with ARDS. And that's the basic concept of, baby lung. That you may have a 60-year-old, 60 kilo old adult, but when he has got a bad ARDS, his lung may be like that of a 20-year-old. That's the baby lung concept, okay? So in that case, just targeting a TB by body weight may not be that physiological, especially if your ARDS is bad, and compliance is something which actually tracks the severity of your illness. The higher, the worse your ARDS, the lower will be your compliance. So if you target that, then as the ARDS becomes more severe, your tidal volume goes down. As the compliance goes up, your tidal volume goes up. So that is a better target for ventilation. That's the concept. So physiologically, it definitely makes sense. How much time do I have? Yeah, a little bit. Okay. So that's the key study. Okay, that's the key study. Everything is dependent on this study done by Amato. And this one is also almost 15 years old. But in medicine, 15-year-old is pretty new. So that's the key study. What is it? It is an amalgamation of 9 different sub-studies. All are adult studies, all post-ARDS net studies. So they are all treated by the lung protective ventilation. About more than 3,500. And what he has done, he has just rearranged these 3,500 patients into different groups to figure out the effect of delta P. And this is what he has found. And this is, very famous graph here. Do I have a pointer? Yeah, right. So in this group, what you see, that all of them has the same PEP. So PEP is same, okay? But their PIP is progressively higher because their driving pressure is progressively higher. Okay, PIP is same, driving pressure goes up, so the PIP also goes up, or P plat also goes up. And as the driving pressure or P plat goes up, the mortality, relative risk of mortality goes up. That's one way of looking at it. Then the other way of looking at it is, what he has done is he has grouped the patients having similar driving pressure. Pressure was around 17, 18, okay? So all these groups of patients have the same driving pressure, but the PEEP has progressively increased. As the PEEP increased, so the P plat also increased. So here also my P plat is increasing, but my driving pressure is equal. My PWP is also increasing. What happened here? Mortality, no difference. So progressive driving pressure, mortality worse, driving pressure same, no mortality change. Third group, here my P plat is same, okay, but my driving pressure is progressively down. As my driving pressure is progressively down, if my P plat has to be remain okay, then my PEEP has to go up. So my PEEP has progressively go up. But and here also mortality has gone down. So as my driving pressure progressively reduced, my mortality reduced. As my driving pressure increased, my mortality increased. As my driving pressure remains constant, my mortality is constant. Okay? So that's the logic. And other way, if you say if you have higher P plat, then you are more likely to die. It looks like that, but in this group, my P plat is higher, my mortality is same. Or if you say higher PIP is good, it looks like higher PIP is good here. As my PIP goes up, my mortality goes down. But here, as my PIP goes up, there is no definition, no benefit. So that's the key. Oh dear, 2 minutes. So that's the key thing. And then, why is it not? Yeah. Here also, he has said that, you look at your delta P, when it is like 15, 16, 17, that is when your mortality is low. Once it is more than 15, 17, your mortality goes up. These are all patients who are not breathing on their own. They are all sort of paralyzed, okay? Then we have got this 2025 study, same hypothesis, but these are patients who are breathing. So it is also true for both spontaneously breathing and non-breathing patients. So does that mean that we should practice this? Not at all. Why? Because both these are observational studies. They have only shown an association. None of them have shown any causation. For that, we need an RCT. Unfortunately, in the last 15 years, we do not have any RCT whatsoever. The only thing we have is a pilot. This is a pilot study recently published, relatively recently published, only 31 patients. They did not found any difference, and the study was not designed to find any difference. Okay? So as of now, we do not have enough evidence to practice this. We do not have this. Okay? Another study giving some insight is, this is a study where they have done a delta V directed therapy in some patients and measured the power of ventilation, what difference it makes when you change same patient, initially ventilated by DS-net protocol and then change to a driving pressure directed protocol. And as you do that, the power of ventilation goes down. And we all know that power of ventilation is bad. If your power is high, your mortality is high. So maybe delta VP directed thing is good. And why it has become lower? Why it has become lower is, yes, it wanted a delta P of something like 12 to 14. As the patients were ventilated from 6 ml per kilo, and then they have just, about 70% of kids were not needing that much of delta P. They are not needing that much of delta P. So as they are changed to delta P driven, their tidal volume increased. As their tidal volume increased, so their rate went down. And as their rate went down, as you all know, power is also dependent on your rate. So that is why the power has gone down. I don't have time for this, but just look at this one, that the power of a ventilation. If we just focus on this one, VT, tidal volume, respiratory rate, and then this is your driving pressure. So the power of ventilation is definitely a function of driving pressure. So there is some reason that delta P will be a decider. And as your rate goes down, so what do I learn from this? From all of this? Number one, delta TV of 6 ml per kilo is not set in stone. Neither the ADS-net study also said it is not set in stone. So you can go lower or higher depending on the patient. Possibly as of now, a delta P of around 15 looks to be where the sweet spot is. So try to keep your delta P somewhere around 15, but again, is it backed by a lot of evidence? No. And the other thing, for me, the key thing is, if your delta P is less than 15 and you are achieving a tidal volume more than 6, then go to more than 6. That's fine, even if it is ARDS. If a ARDS patient is not needing that much of driving pressure, you can give higher volume. And then you will be able to reduce your rate, and possibly that is a better way of ventilating. For me, that is possibly the key information. Thank you.
Thank you, Dr. Ognishekar. If there is one or two question, please.
Any question? No. I've been very clear. Thank you.
Thank you.
you, sir. We'll now move on. So I'll request you to please remain on the dais for this session as well. Our first panel discussion today will be on PICU liberation. It will be moderated by Dr. Kaushik Malik, who is a consultant pediatric intensivist at Apollo Multi-Specialty Hospitals, Kolkata, and he's an assistant professor of PICU at Institute of Child Health, Kolkata. The panelists for this session are Dr. Kaustubh Chaudhary, Dr. Vijay Kumar Meher, Dr. Shayantan Bhaumik, and Dr. Ratan Kumar.
So very warm welcome and good morning to everyone. So the first panel discussion of the day. So this will be on PICU liberation. So as we know that every storm leaves behind its residues and damages, and it takes a long time to again recreate what has been devastated by the storm. But if we are cautious during the storm, then it might be possible to reduce those damages and to make the village or city recover early. So with this, we can start the discussion. So now our SCCM, Society of Critical Care Medicine, started focusing on something called ICU liberation. That is how to liberate a patient or a child or adult from the ICU successfully. Liberate here means that to reduce the damages caused by all the intensive care related illnesses and interventions, and to rehabilitate them, and also to prevent as far as possible those injuries. So warm welcome to all my esteemed panelists. So what is PICU liberation? So in a single sentence it can be explained as optimizing children's recovery for better outcomes after critical illness, right? And we know that this, if we have to be successful in this, we have to adhere to a bundle of interventions. So as we have discussed yesterday also in workshop, today also we'll discuss what is a bundle. Bundle is a set of interventions. So if we do not adhere to the set of interventions fully, then we will not be entirely successful in our goal, right? So my first question to Dr. Kaustubh Chaudhary, why implementing ICU liberation principles are so important? Sir.
So what is our goal when I put a child in PICU for critical illness? So my goal is to early discharge, and also goal is to stay, limited stay, as well as cost effective treatment in the PICU. So when we just go through that liberation bundle, and we found that there is an evidence to suggest that with that ICU liberation protocol or bundles, actually you can reduce the total number of duration of PICU stay, Obviously, it's from the most of them from the adults one, but 72% decrease in that total next day mechanical ventilation. So reduction in hospital deaths by 68%, and then there is a decrease in the reduction in next day use of physical restraints, and obviously there is decrease in the ICU readmissions, and apart from that, obviously long-term outcome in the form of mental and mental agonies or later on readmission in the nursing home or in the rehabilitation facilities is much more less if you start on early liberation plans or at the onset of admission in your PICU.
Right. So a lot of benefits, as we can see. So now, if there are so many benefits, naturally we'd want to know what are those interventions, right? So, so my next question to Dr. Bijay Kumar Meher sir. So what are the components of the ICU liberation bundle as we discussed?
Thank you, sir. So as per the Society of Critical Care Medicines, this ICU liberations campaign, as per the ICU liberation campaign, this should start from the day the patient has been admitted to the ICU. Just like as we are discussing ICU liberation on the morning sessions, so this should start from the beginning, from the time the patient has been admitted, and it should throughout the course of the ICU stay. And these are, to remember all these things, there are 6 A, B, C, D, E, F. For easy remembrance this has been done. So it is very easy to remember, because A for analgesia, that means we have to assess that whether the child is having pain, and we have to manage the pain, use of different analgesics, different sedatives for management of the pain. Pseudoanalgesia is another important things. Then B for breathing, spontaneous awakening, spontaneous breathing trial to be given every day to a child, and we should reduce the amount of sedation, amount of awakening we should allow the patient to have. Choice of sedation is coming in a bigger way with the evidences, and we should go away from the benzodiazepine. Rather, we should use some other drugs which help us for the prevention of the next part, that is the delirium, which is a neglected one. We should start using different tools to identify delirium, and that is delirium monitoring and management of the delirium should be important. Early mobility is coming in a bigger way, because you should not forget that ICU patients are always bedridden. We should start mobilizing depending upon the conditions prevailing. And another important aspect is the family engagement and family empowerment. This is very important. So A, B, C, D, E, F are the 6 important pillars on which these ICU liberations are made up, and that will strengthen our ICU liberation principles.
So thank you, sir. So it's easy to remember as a mnemonic, but during our management of any child in the ICU, this is what we practically do. But yes, we need to focus on it appropriately. So now we come to a phenomenon known as the post-intensive care syndrome. So what happens when any patient, kid, adult, whosoever is in the intensive care unit, so all the stress of the procedures, the environment, the anxiety related to the illness leads to a kind of post-traumatic stress, it is called, and that reflects in multiple things like the sleep, the behavior, the cognitive outcomes, the physical strength, and different kinds of psychological morbidities, which starts when we have withdrawn sedation, they become obvious, and then gradually they persist. And even at the time of discharge, many of them, these features persist. So when we are talking about PICU liberation, one of the essential components is how to reduce the incidence of and severity of this post-intensive care syndrome, which is a kind of post-traumatic stress. So for this, there have been studies on these interventions also, and it has been seen that critically ill patients who are managed with awakening and breathing coordination, appropriate and early management of delirium, appropriate exercise, mobility, involvement of the family. So they experienced more days of breathing without assistance, they experienced less delirium, and were more likely to be mobilized during ICU stay, and also there have been early discharge from the ICU and reduced duration of mechanical ventilation. So in critical ill children, not adults, what are the extra challenges we face? My question to Dr. Shayantan.
Sure. Yeah, thank you. So definitely all the studies, what we have been reading about ICU liberation, they are all mostly based on adults, but children are children and they are very tricky to manage. So definitely heterogeneity of the age, and then different children have got the different developmental milestones, so you have to consider all of these factors. Communication is a very big issue. We don't really understand what children want to tell us, so that is one important thing. And then obviously, similarly, the dangers of those important life-saving lines and tubes that you have, and then the fear of removing, or fear of getting those removals is another important barriers in regards to managing children from that perspective.
So the heterogeneous age and development, their understanding as to what has happened to them, that is often not there. So when we are awakening them, we are in a constant fear. The tube may get removed, they may move, they may pull out tube, they may pull out line, this kind of situation. So that itself is a barrier to their early mobility in many situations. And they are also unable to express what problem they are having. So as a result, what happens is that the assessment of their level of sedation, the assessment of their pain, their scores and scales are different from adults. So we cannot assess children's sedation and pain by same scores as that of adults. So there are the unique challenges which we face in the PICU per se. So Dr. Ratan Kumar, sir, what do you feel that there are the limitations in our current practices regarding the bundle interventions which we are following in the PICU currently in general?
So good morning, thank you for the question. So as already explained by Kaushik sir, children do not cooperate up to the extent an adult can, and they may not follow the commands, may not communicate. So we have to restrain them, which may be in form of chemical or physical restraint. And in challenge is that we in chemical restraint we always over-sedate the child, or we do the physical restraint not according to the guidelines. And then the choice of sedation and analgesia as per the Pandem guidelines is not uniformly followed in most of the PICUs. And nowadays there is, the guideline says to shift from benzodiazepines to alpha 2 agonists like dexmedetomidine and then clonidine. In mechanically ventilated children, particularly in cases of like cardiac cases, tachyarrhythmias, post-cardiac surgery cases, and all these are not uniformly followed in most of the PICUs. And delirium is one important thing, plus sedation, withdrawal of sedation, everything has to be monitored as per protocol. Sedation, if you are giving benzodiazepines, opioid, you have to do pain scoring in form of FLAC or FACES, sedation scoring in form of Comfort B, or assessment of delirium, so that we can diagnose it earlier, we can prevent it from happening. And these are the main challenges that we face in most of the cases.
Thank you. So now sleep disturbance in the PICU, very, very important. So as we see that even if we don't get good sleep for a night or two, we have trouble in focusing, our concentration is haywire. So again, children in the PICU, so children sleep is very important for their developing brain also, especially small babies. And so there are many things like medications being given, painful interventions being done, noise, light, monitor sound, some conversations going on, immobility, restraint, care, intervention, stress. So all these things contribute to poor quality sleep. And sleep is one of the most important things that are required for the well-being and the quick recovery. So as a result, what happens is that as sleep is affected, so the recovery also gets delayed. And it has been seen that, so if sleep is not good, so what happens? So patient enters into a vicious circle of sedation and delirium. So Dr. Kaustav, if you can just elaborate a bit on it.
I think one of the important aspects when we are talking about PICU is that there is a divide of sunlight or daylight and night differentiation in the ICU. Most of the ICUs don't have sunlight, which is really a problem. And when you are talking about sedation and having delirium, delirium is very much under noticed by even the ICU specialist. And as you know, that delirium has got different types like hyperactive and mixed type. Most of the time in hyperactive state, we usually get to notice that they are hyperactive, so we can identify that. But if it is hyperactive, most of the time it is unnoticed. And in hyperactive, what you will do, you will just increase the sedation. So this vicious cycle keeps on going, and you increase the sedation, obviously there will be upregulation, and you don't have that sedation effect which was from the previous sedation you have given with midazolam or say for fentanyl kind of thing. So in those conditions, going for something like this liberation bundle in the form of sedation holiday, possibly of lots of importance. And if you go through that, even that ventilator associated events which we have discussed yesterday in the workshop, that has also got immense importance of this sedation holidays. So obviously that is of prime importance for me.
So you see that not sleeping, given more sedation, suppose benzodiazepines, sedation needs escalate, then some sleep is there. Then again what happens is that tolerance develops, sleep quality worsens. So we again escalate the dose. So ultimately what happens is that we are on a very high dose of a particular agent, especially benzodiazepines are quite notorious for it, and then we are not achieving the desired effect. So for that we follow often some strategies. One is sedation cycling, where we change the sedation that we are giving after a period of maybe 3 to 4 days so that tolerance does not develop. And also, so what Sir told about is the spontaneous awakening trial that has a different purpose, that every day we stop the sedation for a certain period of time and wake up the patient for spontaneous breathing, use of the diaphragm, and also a bit of coughing, secretion clearance, and also to assess how the patient is breathing on the pressure support mode. So we have to stop this vicious circle. And also, so very important is how much are we aware. So when the patient enters the PICU, the kid, so we are busy with all the invasive interventions, shock, hemodynamic monitoring, bolus, intubation, all these things. But this part, like how much are we aware actually for the need of sedation, sleep promotion and delirium prevention. So Dr. Bijay sir.
Yes, definitely PICU is a very highly functioning environment, and we are also busy with all those things, monitoring the patients, hemodynamic monitoring and all the procedures and all these things. And this is some things a bit neglected one, like sedation, appropriate sedation of the patients, making the sedation holiday, promoting the sleep. We cannot promote the natural sleep, but how far we can promote sleep in the patients so that we can prevent delirium. So these are the very important aspects. And as evidences are coming that we are, these are all linked to the outcome of the patient, final outcome of the patients. So this, since the evidences, these evidences, what is the previous slides?
Yes.
The evidences. So this is a very old one, 2014. And this study shows that 341 pediatric intensivists were asked for, and less than 15%, less than 15% are aware that this effort to optimize the sleep in critically ill children, so that they are not aware of all these things. And some non-pharmacological measures, simple non-pharmacological measures like noise reduction, change of lighting, and earplug, use of earplug, these are also very important aspects which are neglected in the pediatric.
Thank you. We'll come to that. Again, so the multidisciplinary approach is very important. So for want of time, I'll just speeding up a bit because there are lots to discuss. So patient and the family both, and along with that nurses, physicians, respiratory care, pharmacists, physiotherapy, occupational therapy, dietitian, all the teams combined need to work together for an effective PICU liberation. So briefly about how to monitor sedation and pain in the PICU. So we need objective monitoring, right? So otherwise it will be very subjective. I may feel patient is sedated, another person may feel no, not sedated. So what are the scores that we use usually for pain and sedation monitoring?
Unfortunately, this awareness of monitoring sleep with the scale is not much there in our intensive care. But obvious reason, as we all come across with this bundle of liberation, this is of flagship importance. So going by the Richmond agitation sedation scale and identifying what is the level of the sedation, and particularly keeping a variation of diurnal variation, if possible, will be of paramount importance. Along with that, obviously in the flash cell also, that will give an idea about even for the pain, we have that pain scoring every day in our PICU, so we always check with the phase study or then identifying what is the pain score, and accordingly also taking care of the analgesia will be of paramount importance in long-term outcomes.
Okay, thank you. So we have to monitor this course for objective identification. It's true that subjective assessment often helps, but if we can monitor this course, it is good. We try to keep light to moderate sedation, not like unarousable or very deep sedation, except in certain scenarios where deep sedation might be needed. So, Bijay sir, what is the sedation practice which you follow in your PICU usually?
So, sedation practice, sedation is a very important aspect of any ICU patient. So in a mechanically ventilated patients, we use basically one of other sedation is very definitely we use that, and midazolam is very commonly used, but recently we are being shifting to most of the patients are being put on dexmedetomidine rather than midazolam. And for non-ventilated patients, we use other agents like triclofos we are using. And sedation, analgesia is also very important, so we use paracetamol very often, and in sometimes we use ketamine as an intermittent, and in some patients like bronchiolitis, if we need a bronchospasm is a problem, then we use also ketamine.
Correct. So our purpose should be to limit benzodiazepine use. For that, if we can use other pharmacologic agents like our triclofos, our antihistaminics, so that may bring down our use of benzodiazepines. Also, we should try to limit our opioid use. All these things are to prevent withdrawal of sedation in the future. Okay. So again, for analgesics, so if we can use other pharmacologic groups like our paracetamol, so that will be good. So again, we have to monitor the sedation. Other sedation scores also are there, like our comfort behavioral scale, comfort scale. So, and based on that, we usually tend to monitor the sedation depth and titrate our sedation. Our usual comfort B score range is between 12 to 17, and there are guidelines according to which we should titrate our sedation, so that according to RASS scales also we achieve a light to moderate sedation. So now coming to dexmedetomidine, Dr. Ratan Kumar sir, so there has been a shift in the choice of sedation, and often dexmedetomidine is being preferred as the first line also. So what will be your take on
So
that?
actually dexmedetomidine and clonidine are centrally acting alpha-2 agonists, and they also act on both central and peripheral nerves endings, sympathetic nervous system release of reducing the release of noradrenaline. And in this way, they have a different mechanism other than like benzodiazepines act on GABA receptors, which is inhibitory. So these do not have, number one, the good thing is that they induce a sleep, which is by EEG you can see it is close to natural sleep. And then the withdrawal and incidence of delirium is also much less with alpha-2 agonists as compared to the benzodiazepine and opioids. So these are now being preferred agent for sedation.
Okay, so preferentially to use dexmedetomidine and or clonidine, so as the one of the first line agents, limit the benzodiazepine use as much as possible. It's not like that benzodiazepine should not be used. No one should go away from here taking that message, but as short duration as possible, maybe 48 hours, 72 hours, so that you can prevent the tolerance, sedation, withdrawal and delirium. We'll come to it.
Even I think this dexmedetomidine also acts in that opioid withdrawal as well. So if you have a prolonged opioid, if you want to substitute with something, possibly dexmedetomidine or clonidine is one of the drug of choice.
Correct. Okay, so now the analgesia and the neuromuscular blockade, we know. So opioids are used as the primary agent, but we'll try to limit as much as possible. If required, we'll add other pharmacologic groups. We will regularly monitor the pain scales, and neuromuscular blockade to be used only if it is necessary and in the lowest possible dose. And we must ensure adequate sedation before we go ahead with the neuromuscular blockade. So delirium, now for a long time we are hearing about the term delirium. So what is delirium actually? So you told about the hyperactive and hypoactive, but what does delirium mean actually?
From the baseline, if there is a disturbance in attention or awareness, and obviously there should not be any underlying neurological abnormalities which can be pre-existing elements. So with such changes, if there is something like sudden onset behavior in a short span, you can talk like hyperactivity, or become suddenly hypoactive, then possibly you should think of as delirium as a possibility. And if you go through that point prevalence study, more the days passes by in PICU, there is a more chances of delirium. And as this study is already showing that beyond 4 days, the delirium chances are much more. And apart from that, what we usually go for like sedation, opioid, and as well as restraint, that actually increases the chances of delirium in PICU as well as adult ICUs.
Right, important risk factor, physical restraint, prolonged use of narcotics and prolonged use of benzodiazepines. So just have a brief look at this video. So patient on prolonged ventilation, ARDS, received lots of sedation, and then the kid was extubated and then shifted to ward gradually. So having this continuous tremulous movements, intermittently stopping and then again starting, fluctuating throughout the day, impaired cognition, sometimes responding, sometimes not responding. So this is the typical delirium situation. So we had encountered recently in one of our patients. So this thing needs to be picked up early, and to do that we need to monitor certain scores. Delirium scores are there, so we will come to that. So again, so sleep deprivation is a very important risk factor for delirium and poor quality sleep. So that's why it is important to ensure optimum and good quality sleep in the PICU. And if we come to one single most important risk factor is the prolonged benzodiazepine use for delirium in the PICU. So we should try to limit the use of the duration of these benzodiazepines, preferably for a short duration and at a lower dose. So now what can be the other sleep promotion interventions, Dr. Shayantan, in the PICU?
Yes.
Apart from drugs. So we have been discussing about drugs for a long time.
To remember, you can divide it like a nighttime interventions, like daytime interventions. So nighttime interventions, what we have to do is basically reduce the number of stimulants that we give to the children. So you can use some earplugs, you can use some eye mask if possible, then you can give some soothing music. Most importantly, you have to manage the lighting in the PIs. You have to go for dim lights, and you have to try to reduce the interventions that you do so that children can sleep properly. In the daytime, you have to again use bright lights in the PICU. You can sort of manage the medications in such a way that they don't get the sleeping medications during the day, and they rather should get the medications properly in the night. You again, we talked about delirium management, so you again minimize the number of drugs that you are giving, which enhances the delirium. So, yeah.
Thank you so much. So there are other interventions which are equally important. So we should not rely only on drugs. So regarding the withdrawal and delirium, so it's very important to monitor for the features of withdrawal, including the withdrawal assessment tool. It is one of the scales. I'm just speeding a bit because time is short. And also there is something called the delirium scores, like our CAPD, Cornell Assessment of Pediatric Delirium Score. So we need to monitor that too, so that we can pick up delirium early and intervene accordingly. So on the way to liberation, so we discussed about sedation, delirium. So there are other important components including early mobilization, family involvement, and the spontaneous awakening and spontaneous breathing trials. So, and the PANDEM guidelines are the SSCM very important guidelines on the management of pain, agitation, neuromuscular blockade, PAN, DEM, delirium, and early mobilization in the pediatric patients, which we need to go through so that we can implement all of this. So, Dr. Kaustubh, sir, what are the benefits of early mobilization in brief?
So, immobilization causes lots of issues in the PICU in the form of, we got cases like GB syndrome, and recently we have that immobilization issues. Like one of the commonest thing happened is that bone mass loss, then they can have hypercalcemia, they can have myositis ossificans also. And apart from that, with the decrease in the muscle mass, because of the either critical care neuropathy or critical care myopathy that can appear, then they have edema, dependent edema causing bed sores. Then there is some cardiovascular issues because of that dependent edema also. And then obviously reason, if you go through the respiratory, there is a dependent edema that can lead to more days of ventilation. So going for early mobilization and early physiotherapy will be of paramount importance, because lots of different organ is getting benefit from early mobilization. It is not only that, but also the psychological issues, as we have already discussed, like depression, anxiety, or delirium is much more prevented when you go for early mobilization. So that's the way.
So as we see, Vijay sir, these elements of early mobilization. So what are the different components? Like normalization of sleep-wake cycle. Then we can turn the patient if the patient is able to some ROM exercises, splinting, sitting position, then sit with the edge of the bed with the legs dangling, then to ambulate to a chair, and then finally the ambulation, walking. So assistance regularly, assessment, so what the patient can do, and then doing it. So it's very important for maintaining the strength of the bone and also to train the muscles, which will gradually become atrophied with prolonged intensive care. So what are the barriers to early mobilization in our PICU? So like children, no? So they are different. So what are the barriers? Why we can't mobilize them early?
So the important is safety. So in safety you have to think of whether they can remove the lines, or those lines are really important, whether they can remove the lines and tubes. Fall risk, if your PICU census is high, the nurse to patient ratio is less, and then definitely again, safety is a big paramount which has to be considered. And then awareness among doctors and nurses. This is something that we need to build up as a PICU intensivist, intensive care consultant. And we, in our day-to-day ward round, we should incorporate these things, that PICU liberation is very important, and we teach our juniors to do the same thing. So yeah, and safety and awareness, I think these are two most important parameters for barriers.
Yes, and mobilization also sometimes helps to get them some light. Like in some PICUs are there where the lighting and sunlight doesn't enter, we can take on a wheelchair and just take a bit in the outside where some sunlight exposure. That is extremely mood elevating. So that's very important. And if they don't get it, then naturally they have depression. So an early psychiatry referral to pick up depression and to assist them, counsel them is also extremely important as a part of this.
And
care.
I think also involving the family early in their care,
yes,
which
yes.
is also
very important. So this is like a video on mobilization. One of our patients was on prolonged ventilation, around 60 days on mechanical ventilation. Before discharge actually, so just some assisted mobilization. You see that there has been a lot of power loss in the lower limbs, but yes, she was gradually able to regain it, and she is gradually walking, and so it was a very pleasant sight to see and very helpful for the kid. So why family involvement is so important? So I remember that so if I ask the audience, like how many of you are involving family directly in the care of the patient? So there are many issues in that, but there are many benefits with that also. Like when I was training during my MD in PGI, I had seen that at the bedside there were big chairs, and in those chairs there was one usually attender sitting. Sardarji or his wife like that would be sitting, and they were always involved in the care, like the compassionate care, gentle care, then some this thing. So like so that the patient feels good. But then gradually I saw that in some other areas are there where the only visiting hours are there. The family enters and then meets briefly and goes. Like, what is your take, Dr. Kaustav, sir?
I think it's quite clear by this time that the best care given to a child, and as because the child is not a mini adult, is given by the parents, particularly the mother. We found a lot of time when parents are around, possibly this is the best way to reduce the psychological burden as well as well-being of that particular child and get early recovery. What is our goal in liberation from PICU? So possibly early involvement and every time involving the parents will be of paramount importance, so that the psychological aspect also can be taken care of, which always we tend to ignore in the initial part when you are managing the difficult part of that particular some vital changes in the body to maintain the hemostasis. But obviously family involvement is much more important, as well as from the doctor's point of view, the communication is much more easy when you are actually involving the family. Even if they are not educated enough, they can understand the compassionate care of your own efforts. So that also helps in later on for the treatment purpose as well.
So again, as my senior mentors, Dr. Mahadevan sir in JIPMAR used to say, that the family doesn't care how much we know, they want to know how much we care. So that's very, very important. So the family, if involved, provides comfort to the child, and parents are there, so it decreases their level of stress and anxiety also, and increases the level of satisfaction, because they are able to see what we are doing, rather than us telling once in a day, we have done this, we have done that, and the response is not good or good, like that. So they are able to directly see. So quality of evidence is low, because this study, if you have to do in this aspect, it will be a qualitative study, and it's very difficult to objectively get the benefit. So it's not easy. So that's why the evidence is low. But if we can objectively do trials on this, I'm pretty sure that the level of evidence would come up. So SAT and SBT, last 10 seconds. This is the last slide also, practically. So Dr. Ratan Kumar sir, briefly.
Pandem does not recommend daily sedation interruption in all the cases, as this implementation is not shown to improve the outcomes. But once the cause for which we have intubated has been resolved, spontaneous awakening and spontaneous breathing trials should be given to allow early liberation and reducing the complications.
Thank you so much. So thank you for the excellent participation. So my take-home points would be, so we should cluster the interventions in the PICU so that repeatedly we don't disturb the patient. Then minimize use of benzodiazepines as much as possible, not eliminate but minimize, and other deliriogenic drugs. So try to use alpha-2 agonists mainly. Focus on non-pharmacologic therapy, very important, that often gets ignored. Ensure early mobilization, involve the family, and always keep them in the loop. And if possible, try to monitor one score for sedation and analgesia. Often it is difficult in a busy ICU, but if it is done, it has shown to have benefits. So in the end, let's remember the bundle, A, B, C, D, E, F, okay, so that we can liberate successfully. Thank you for your patient hearing. Any questions? Brief questions.
Thank you, moderator and panelists, for highlighting all these things. I have one question. That sleep-awake cycle is heavily disturbed inside the PICU, because there is no sunlight and no even all the time there is artificial light. So it's kind of jet lag-like situation. So can you use the upfront melatonin in this condition for prevention of, because now the jet lag and this kind of sleep cycle disturbance, melatonin is being used. And another question, another point to note, that I have not seen even in our PIC also, there is no proper counseling, because there is a high possibility of post-traumatic stress disorder. So forget about the psychiatric visiting PICU, but there is no counselor who actually we should visit in the PICU, talk to the parents and also with the older children and also the children who can understand. So is that these are the being addressed in any of your center where you are working.
Thank you, sir. I request the chairperson, the moderator and panelists to kindly collect the memento from the memento one.
So brief response to the question, can you, this,
So we can have the questions after we are running short of time, please.
I know, just maybe
Yes,
20
I think,
seconds.
from the chairperson point of view, the points are well taken, and it's evidence-based that for this diurnal variation of sleep, we use melatonin to produce sleep in the night time, so that variation should be maintained, and it's evidence-based. Yes, we use. Second, regarding your question regarding post-traumatic stress disorder, yes, we need to be much more aware and make them aware that that can happen. But usually in these children are much more compliant. So they are, their neuroplasticity is such a way that they behave later on quite nicely and changes quite fast rather than the adults. So possibly as a pediatrician, we do that part of psychiatrist possibly, and then when they are coming for the follow-up, we usually interact and try to understand what is the state of their level. Most of them are doing well.
Thank you. Thank you so much.
Thank you, sir. Thank you. Moving from the respiratory system to CVS hemodynamics and PICU quality. For the next session, I would like to invite Dr. Shushmita Banerjee to chair the session. She is the consultant at CMRI Hospital. And the speaker for the session is Dr. Somnath Gorai. He is the pediatric consultant, intensivist at Neotia, Bhagirathi Neotia, Women and Childcare, Newtown. And sir is going to speak on balanced salt solution. Where do we stand now?
Welcome, Somnath, and a very big congratulations to the whole pediatric intensive care team of the state. Very young, very dynamic members. The conference itself, it really shows the topics, how dynamic and how relevant the team is. I think Dr. Somnath will talk about something that is very relevant to all pediatricians, that of the balanced salt solutions. Where do we stand?
Thank you,
Please go
ma'am,
ahead.
and very good morning. So today our topic is balanced salt solution, a bit controversial and newer topic. So to start with, I want to start my talk by quoting Albert Einstein. The important thing is not to stop questioning. So we have to question our traditional things. So if you go through the historical perspective of fluid management in children, 0.9% saline is the first introduced in around 18th century. Then later on, Lingus lactate, Hartmann solution and other solution come. So why balanced solution required? So we want to give a fluid which is almost equivalent to plasma. So electrolyte composition of balanced solution is approximates plasma. They have lower chloride concentration, contains buffer like lactate, acetate or gluconate, and goal is to maintain acid-base balance properly and reduce hyperchloremia. So we can see the composition. So we can see that plasma light and Ringer's lactate, they have almost equivalent plasma concentration of, along with that strong ion difference is almost equal with plasma light, and osmolarity almost equal. So we are closer to plasma than this normal saline. And also not only osmolarity but tonicity also is equal because they don't have any dextrose containing solution. So we all know that Stewart approach, that strong ion difference for normal saline is 0. So chances of hyperchloremic metabolic acidosis is quite high when we start giving normal saline. But in balanced solution, that SID is closer to plasma as I show, and acid-base balance homeostasis is comparatively easy to manage with plasma-like solution, theoretically at least. So why we are concerning about hyperchloremia? So why it matters? So it causes renal vasoconstriction, reduce renal cortical perfusion, and ultimately reduce GFR also. Can reduce GFR also. Chances of metabolic acidosis, as we all know that hyperchloremic acidosis is common. and possible inflammatory effects is also there. So potential advantage of using balanced solution is less hyperchloremia, metabolic acidosis is less, reduced need of bicarbonate therapy because already we are using buffer, potential kidney protection in long term, and more physiological component, at least theoretically. But so theoretically we know that balanced solution is better than normal saline. But the battle between tradition and physiology, evidence plays the referee. So we have to establish our thought process with the evidence. So what are the adult evidences present? So two landmark trials, SMART and SALTED trial from adult population. So this SALTED trial was done among non-critically ill adults, but they show there is no difference in hospital free days between treatment with balanced solution and treatment with saline. So non-critically ill adults, there is no benefit. But in this solution, this study, that is a pragmatic cluster randomized multi-crossover trial that includes critically ill adults, and they found among critically ill adults the use of balanced crystalloids for intravenous fluid administration resulted in lower rate of there is lower rate of composite outcome of death from any cause. New renal replacement requirement is also less, and persistent renal dysfunction is lesser than the saline. So in adult study, we have some positive things using balanced salt solution. What are the pediatric evidence? We cannot just extrapolate data from adult, and we have some studies. So there are few studies in last few years. In 2022, this study was published. There is SALT-P trial, and they showed among critically ill children requiring intravenous fluid therapy, balanced solution reduces incidence of rise of plasma chloride compared to saline, but no significant benefit from AKI or mortality benefit. So again, though we are biochemically improving, but there is no mortality or AKI benefit from using this thing. And in 2024, another study came. This is a fluid resuscitation in children with severe infection and septic shock, a systemic review and meta-analysis. In 219 citation retrieved and 12 trials included. Almost 3,526 children were included. So what is their conclusion? This current meta-analysis found no significant difference in the mortality. Again, there is no mortality benefit, but there is significant decrease in the rise of AKI was found in the balanced solution group. So depending on ongoing trial and all this, that surviving sepsis campaign came, and what they quoted, they quote that for children with septic shock requiring treatment with fluid boluses, we suggest resuscitation with balanced solution or buffered crystalloid solution over 0.9% saline. But this point is important. This is a conditional recommendation, very low certainty of evidence. And for some children with electrolyte abnormalities like hyponatremia or chances of raised intracranial pressure, we should always use 0.9% saline. Now this big study came on, this is published in April 24, 2026 in NEGM. This is a prompt bolus trial. It's a big trial. So what does it say? It's a landmark trial. This is a massive scale, multi-center pragmatic RCT across 47 international pediatric emergency department, and they compare plasma-light or RL versus 0.9% saline in again 2 months to 18 years old children, and within 48 hours of emergency admission. So what they compare this the major adverse kidney reaction within 30 days along with death or requirement of newer RRT or any persistent kidney injury is there or not. So what they conclude? This is very important because there is no difference in anything. No mortality benefit, no new renal replacement therapy, and no persistent kidney dysfunction was noted children given 0.9% saline. So in septic shock, again there is no benefit. So another common condition where decay, we use, sometimes you use balanced crystalloid solution, but again evidences are shows that there is no mortality benefit, though biochemical benefit is there and there is early recovery from the decay. This is another study. Again, in this study they shows that there is slight benefit from the decay resolution, but no mortality benefit. And this study is published in latest, this is from SCB Cuttack, this is March 2026, and they shows there is no significant difference in balanced solution and normal saline, even in decay resolution also. So now I thought I made you confused completely. So what is our takeaway? So now we know that balanced solution is more physiologic, there is no doubt about it, but clinical benefit again doubtful. In septic shock in children, no clear superiority. Decay, there is faster correction of the acidosis is okay, but lower chances of hyperchloremia, but neurological outcome and mortality is equal. Maintenance fluid is safe, but again there is, as it is costlier, we cannot use always in maintenance fluid. And perioperative and critically ill children, there is no mortality benefit. So normal saline is not obsolete, it remains an acceptable alternative, old is gold. So we have to use normal saline. There is chances of hyperchloremic metabolic alkalosis and severe hyponatremia and neurocritical scenarios where there is more use of normal saline has to be used. So current evidence does not support superiority of balanced solution, but is another alternative. So the good physician treat the disease, great physician treat the patient who has the disease. So fluid choice should be individualized, that is most important. You cannot just blindly give a specific fluid for a children and just protocolize it. And probably this is a good news or bad news, both. So one fluid does not fit for all, we all know. That's why we required intensivist. So our job is secured. We can say that pediatric intensivist is still irreplaceable. AI cannot replace us, so at least for till we found specific data for protocolization, we can individualize the management and we can continue as an intensivist. Thank you.
Thank you. Questions from the audience? Please, yes.
10 per kilo?
That is in this prompt bolus. They go up to 40,
bolus.
40,
How much?
40
40 ml per kilo. Okay.
Maximum 40 ml they went.
Okay. So volume was quite less. So that's why there is no significant difference. So even in prior like this study, up to 30 ml per kilo, if the patient received as a bolus, there will be no significant mortality or any major kidney events difference.
Yes, that can be a cause.
So one question is that you rightly said that your job is secure, but in many of us, when we are practicing, we do not have access or we do not need pediatric intensivists because it might not be a critically ill patient. So the run-of-the-mill patient coming in with dehydration, requiring maintenance fluids, do you foresee that the standard normal saline bolus followed by maintenance, is that going to change?
No, I think we should not change this practice because normal saline is still well-proved thing. Only in specific condition in our practice when there is unresolving metabolic acidosis, we can calculate the chloride excess, and then if it is hyperchloremia, then we can switch to plasma-lite. In our practice, usually we'll sometimes use plasma-lite in DKA patients because sometimes we get confused whether this acidosis is correcting or this hyperchloremia is playing a role. In those cases, we sometimes use plasma-lite in our practice. And again, it is a very costly thing. So I think we cannot change the our practice.
And when most of the studies are for resuscitation. When you're using for maintenance, you would also need to add glucose, right?
So maintenance, yes. Again, this mixing is another headache. So we don't have always laminar flow. So better to go for DNS and isotonic fluid. Yes.
Thank you.
Thank you, sir.
Thank you.
Our next talk for the day by none other than Dr. Shomain Muir, who is a senior consultant and pediatric intensivist at Manipal Hospital, Mukundapur. And sir is going to give a talk on pediatric septic cardiomyopathy beyond the ejection fraction.
Good morning, everybody. And my talk is on something slightly odd or unusual. So pediatric septic cardiomyopathy is something, go to the next slide. I can change? Yeah. So it's a reversible condition, and if diagnosed early and treated appropriately, the outcome is very good. There is no actual damage to heart muscle in this condition. But if you look at the incidence, it's very varied. It's 15 to 60% if you look at literature. That's possibly because earlier or mild cases are not being diagnosed because there is an issue in diagnosis, which is the main point of my discussion today. So I don't want to go into too much detail. It is primarily a cytokine-mediated injury and causes myocardial depression, myocardial dysfunction, and microvascular changes and microcirculatory changes. I'm not going to go into the pathophysiology that much today. This is something I want to come to primarily the severity grading of septic cardiomyopathy. So it's based on ejection fraction, and we use the same ejection fraction for all sorts of cardiomyopathies. Mild is 45 to 54, moderate is 30 to 40, and severe is less than 30. But ejection fraction, is that a good indicator of myocardial dysfunction in this scenario? To understand that, we must go through the PV loop of ventricular function. So we have got the volume on x-axis and pressure on y-axis. And if you look at the ventricular filling and then isovolumic contraction, then ventricular ejection, and then isovolumic relaxation, we get two lines. The blue line indicates contractility, and the gray line indicates afterload or arterial elastance. And ejection fraction is a function of primarily these two factors. So if we look at this cartoon, we'll see that when the contractility falls, our ejection fraction goes down. So contractility, if everything else is equal, fall in contractility will lead to fall in ejection fraction as well. But it is not an independent predictor of my heart function. The ejection fraction is not an independent predictor of my heart function, because as we'll see in a second, that if my contractility is low and my arterial elastance or afterload is low as well, then my ejection fraction goes up again. So even with low contractility, if we have low arterial elastance or low afterload, which would be the scenario in septic patient, most of the time they are vasoplegic, so they have got minimal afterload. So the ejection fractions can still be in normal range when there is significant myocardial dysfunction. So in septic cardiomyopathy, why do we want to know that early and ejection fraction is failing us? Because if we don't diagnose it early, the mortality goes up. So the mortality can be up to 2.3 times if we miss the diagnosis of septic cardiomyopathy timely. And there is pediatric evidence as well from India, from AIIMS Delhi. This paper is an old paper, but there is evidence in pediatrics as well that it's important that we diagnose it early. It's not just diagnostic, it is therapeutic as well. What are the options we have? We have a plethora of options of diagnosing early: biomarkers, echocardiography, cardiac MRI, gold standard, but we can't really do cardiac MRI in a septic child that easily. And there are other new tools as well. But today, primarily, I'll talk about these three things: spectral tracking echocardiography, myocardial performance index, and ventricular arterial coupling ratio. What is spectral tracking? Speckles are natural acoustic markers, or speckles on particular parts of myocardium, which are assigned different colors, and they are tracked frame by frame throughout the systole and diastole, and by that the myocardial or LV wall distortion is mapped by the software, and then from the distortion it can calculate how the LV is functioning during systole. And then it produces a number and a graph. The number we are interested in is called global longitudinal strain, or GLS. And if the global longitudinal strain is less than 18%, minus 18%, then it is myocardial dysfunction. And if it's less than minus 15, then it's significant myocardial dysfunction. And this comes as a this is a load independent marker of myocardial function. So it doesn't matter if your afterload is low, arterial resistance is low or not, it will be a true reflection of your myocardial function. So unfortunately this is slightly technical, so you need to get 3 views, apical, 2-chamber, 3-chamber and 4-chamber views, and then you get a number which is the last number at the bottom, GLS endo-peak average, it says minus 22%, which would be within the normal range. And then if you look at this picture, here the myocardium, it also looks like it not functioning very well, and the endo-peak, the GLS here is minus 11.6, which is low. So if we can do this, then we can diagnose septic cardiomyopathy early. Problem one is access to the machine, because these are usually high-end machines and not the focus machines that we usually have access to, and we would need a bit of training as well, because it's technically not challenging but will need additional training. So can we use anything else? We'll think about that. But important thing to remember is that the septic myocardiopathy patients, the myocardial dysfunction in them can be diagnosed much earlier than relying on ejection fraction with this. So next thing we can talk about, which can help us in diagnosing myocardial dysfunction earlier, is TAE index or myocardial performance index, which is the global myocardial performance indicator. So this is basically the IVCT, isovolumic contraction time plus hypovolumic reduction time divided by ejection time. And it is another load independent marker of myocardial function, and it gives myocardial assessment, and it's relatively simple and reproducible. So what you need to get is a tissue Doppler, which is available in most machines these days. You measure the mitral annulus movement in the LV free wall, and you should get this graph. And the isovolumic contraction time is the time between the end of E prime to beginning of S wave, and then your S wave duration is your ejection time, and the time for isovolumic relaxation is the time between end of S wave and the beginning of E prime wave. And then you do the calculation and you get a number. And there is evidence in pediatrics that it can detect myocardial dysfunction early, and high is bad. And there are normalized number for myocardial performance index as well from neonates to adolescents. And yeah, generally speaking, if the number is high, that means your myocardium is not functioning very well. So this is something which is doable. And the last thing I'm going to talk about is the ventricular arterial coupling. So the ventricular end systolic elastance, so that's like the myocardial performance, should match the arterial elastance. If they are matched, then your heart is in perfect order, or the heart or the cardiovascular system, whole system is in order. If they are not matched, there is certain problem. How you measure that? It's slightly complicated. You need blood pressure, you need echocardiographic measurements of your ejection fraction and stroke volume, and some time intervals, the pre-ejection period and the ejection time. This can be calculated from an apical 5-chamber view at the LVOT, and you need the pre-ejection period, which is start of QRS complex to the beginning of the ejection, and then you get the ejection time. The calculation itself is slightly tricky, but there are algorithms available online which will give you the calculation if you get all these raw numbers. And the number we are looking for is between 0.8 to 1.3, which is the normal range of the ventricular arterial coupling ratio. If it's above that, that means your afterload is not matched to the cardiac functions, your myocardium is struggling. So increased afterload or reduced contractility will give you a higher VAC ratio. So if we think about all the markers, Speckle taking echocardiography is the most sensitive and early marker. MPI is simple, reproducible, and widely applicable, and VAC ratio provides comprehensive hemodynamic insights. Integrated use of all these three would be best, but we may have to settle for one or the other for lack of access to machine or expertise. Thank you.
Thank you, Showman, for taking us through those very new innovative techniques. How close are we to actually using them in our day-to-day practice? Are you using any of these at the moment?
Speckle tracking is difficult because you wouldn't have access to the machine which has the speckle tracking technology. But the other two, myocardial performance index, is not difficult to do, and it can be done easily with the normal machines we have available. The VAC, slightly more tricky, but myocardial performance index or TEI index can be done relatively easily, and it can diagnose septic cardiomyopathy fairly early on. So yeah, that is doable.
So are you including them in your workshops?
Yeah.
They are
Yeah.
now included, right?
Our workshops were not, so we are planning to do a cardiac focus workshop very soon, and we'll include all these things there.
Okay, questions from the audiences?
Very often used, and sometimes I find very useful, SVRI. So in one of the measurements you were showing, like how to optimize your systemic vascular resistance depending on the parameters. But my question is, like, apart from the parameters that we use right now, we can measure cardiac output invasively as well as non-invasively. We can measure SVRI, we can measure CVP, and we can probably meaningfully alter or tickle the patient management. But apart from academic importance, how far are these clinically relevant for patient management so far? Because for me, my simple take is that at this point of time, they are not very clinically relevant, and it won't probably affect the final outcome of a patient.
I think that this move towards early inotrope is a reflection of that we are not diagnosing septic cardiomyopathy early by any particular number or method. That's why we're going to give inotropes early to everybody, thinking they might have septic cardiomyopathy. I'm just saying that we can diagnose it with the machines and expertise we have at hand, and then we can titrate our therapy and see if it's improving with the inotropes and restricted fluid resuscitation. I'm just trying to say that we are already doing it without knowing it, because we are all saying that don't give too much fluid, go on to early inotropes, and this is what is reflected in this technology as well. So we can look at it, quantify it, and then we can target our therapy and monitor the response as well. I'm talking particularly about septic children and children with septic shock. I'm not talking about other cardiac dysfunctions.
But at the same time, I think the message should be that not to be fixated on particular number of parameters. You have to take everything into context, put everything into context, your clinical findings, everything else, and then say that, okay, the patient is becoming cardiomyopathic.
Thank you. We have to end.
Thank you.
Big thanks to both the speakers of this session.
Thank you, sir. Showman sir, Shushmita ma'am, and Shomnath sir, kindly collect your mementos from your memento corner. For the next talks, I would like to invite Dr. Kalpana Datta ma'am, who is the professor in HOD Pediatrics in Medical College, Kolkata, to chair the session. And the next speaker is Dr. Shubhadeep Das. He's a senior consultant, pediatric and cardiac intensivist at Narayana Hospital, Howrah. And sir is going to deliver a talk on ECMO timing dilemma, too early versus too late.
At the outset, I would like to thank Society of Pediatric Intensive Care Kolkata for giving me this opportunity to speak here. And I'm here to speak on ECMO timing, what is too early versus what is too late. And at the beginning of my talk, I would like to ask you, because I know we are practicing, many of us are practicing ECMO, I would like to know from you all, you can just raise your hands, who are doing ECMO regularly, who are familiar with ECMO, or who have done in the past. Can I get a hands up? So 1, I know Kaushik is, I know Shomenda. Anybody else? Yeah, yes. So present, past and future. All right. So I mean, I would say I know at least 4 or 5 people who are regularly doing ECMO or who have probably done ECMO. And I also know a few fellows, our junior fellows who have recently completed ECMO fellowship. So it's quite promising. The picture of ECMO in Kolkata and per se West Bengal, it's quite promising. And who are familiar with this technology, all of us know that the hardest part of ECMO is not how to manage the ECMO per se, not to manage the patient or the ECMO machine per se, but even harder is the decision when to start ECMO, what is late and what is early. Because we know that ECMO is widely known as the highest form of life support. But having said that, ECMO is not without any side effects. So it has got significant side effects which we have to be cognizant of when we are initiating this technology. So this was a patient we recently, few months ago, managed in our unit, and this was a patient with acute myocarditis, quite severe. The LV ejection fraction was very low and was on multiple inotropes. Then only like 18 to 24 hours down the line, the patient significantly deteriorated, had a cardiac arrest, and then was resuscitated, put on ECMO. So this was the patient on ECMO. So I want to ask you to the house, even if you don't have any knowledge about this technology, but what do you think? When the child should have been cannulated? Was it when the child deteriorated to this extent, had a cardiac arrest then? Or when the child was having an uptrending lactate, or when the child was on 3 inotropes? I would put it like that the decision is very difficult. The decision is extremely difficult. Again, I would like to highlight about the side effects, which we would subsequently see in my talk. What are the side effects? So sometimes we know that this patient is deteriorating, still our decisions are clouded, one, by the side effects. Also, ECMO can be very heavy on your pocket. So it comes with huge cost that not everybody can afford. But if you have the option, then seriously in these days, and if the affordability is not a major hindrance, then we should actually consider. I would show you a case scenario. This is a 7-year-old girl, another viral myocarditis. So early in the morning, she presented quite tachycardic, but BP was preserved for the age. Lactate was around 3.8. She was initially put on high flow. The echo showed an ejection fraction of 35%. She was started on some inotropes, milrinone, some adrenaline. She had normal urine output, normal mentation. What happened by noon, her ejection fraction was relatively unchanged. Lactate went up a little bit to 4.5, and the junior resident, he became very dodgy at this point of time. He started to ask the consultant, you know, like the lactate is rising, should we activate ECMO? But the team decided to wait. What they did, they optimized ventilation, they put the child on NIV. We know that positive pressure ventilation is helpful for the left side of the heart. It can reduce the afterload. They started some Lasix infusion. Afterload was reduced further. The child was maintaining BP. Some sodium nitroprusside was added. So what were the findings in this patient which favored continued observation, like the ongoing support, rather than us deciding that, you know, we need to escalate supports? Here clearly, despite this myocardial dysfunction, despite the child having an ejection fraction of in the 30s, the lactate remained relatively stable. All the markers of organ perfusion were maintained. The child was having good hemodynamic markers, good CRT. The child was warm and well perfused. The child was having good mentation, good urine output. There was no escalating vasopressor requirement. There was no malignant arrhythmias which were happening. And there was no overt evidence that the child was having worsening oxygen debt. And 72 hours later, with this conservative management, what we found, ejection fraction improved, lactate normalized gradually, and the child was discharged after 5 days. So what is the take-home message? That one should earn ECMO. It's not that we know that this physiology can worsen, this child has got an ejection fraction of 30% and we just hook the patient on ECMO. It's not like that. And presence of ventricular dysfunction per se is not the indication. The indication should be failure of circulation, failure of hemodynamics despite optimization of your conventional therapy. So with that, let's look into the other scenario. This is a septic shock patient. Initial lactate in the night when the patient presented was 6.5, already on adrenaline, noradrenaline of 0.1. Initially the patient was awake, bit responsive, and was put on non-invasive ventilation. By midnight, however, the child had significantly deteriorated. Lactate was creeping up to 8, adrenaline, noradrenaline now much higher, urine output was coming down, the child was intubated. At 3 o'clock in the morning, the child was in clear refractory shock, lactate was 13, 3 inotropes now, ejection fraction was also low, creatinine was rising, and this was the first time when they had ECMO support, and this was the first time when the consultants and all the caregiver team, they started to discuss about ECMO. But the ECMO was still not initiated. By 6 a.m. the child collapsed, lactate was 13, adrenaline, noradrenaline very high, the child arrested, eCPR, cannulated to ECMO. Ultimately, the circulation was restored, but the child was not waking up properly. MRI was done, which showed severe hypoxic injury, and they decided to withdraw support after a few days. So with this scenario, what do we think? Did ECMO fail here? Did ECMO fail here? So the trigger for ECMO, again, although we have discussed about the last scenario, the trigger for ECMO should not be a cardiac arrest. We should not let the scenario deteriorate so much that the hemodynamics, that the child is on sky high inotropes, the child has got cardiac dysfunction, the child ultimately ends up having different end organ injuries and ultimately goes into cardiac arrest. We should not let the situation worsen to that extent. Yes, eCPR is a clear concept for in-house cardiac arrest. There is definite role of eCPR, but if possible, we should try and avoid CPR, we should try and avoid cardiac arrest if the patient is already in-house in the hospital. Okay. So here the critical timing could have been that period when the lactate was rising, when the child's inotropes were going high. So at that point of time, if we had initiated the discussion on ECMO, and if everybody had agreed that okay, the child is going to worsen, the child does not look all right, then we should have cannulated the child at that point of time. But they waited too late, which led to ultimately cerebral injury. Although we could perfuse the end organs, but the child sustained a brain injury and the child could not be salvaged. Again, another scenario, this child had a PF ratio of 90, was prone. This is a child with H1N1 positive severe pneumonia, ARDS, and on day 2 had a OI of 28, on day 3 OI of 42, plateau pressures were more than 30, FiO2 was 100%. Discussion on ECMO was initiated, but the dilemma here was whether we are too early versus we are already late. So there are two scenarios. In one scenario, what they do on day 3 when the oxygenation index was worsening, they deferred ECMO, but by day 4 the patient deteriorated further, pneumothorax, RV dysfunction, progressive lung injury. Finally ECMO was started, but it was already too late. In the second scenario, when the OI was already 42 and the plateau pressure was 34, ECMO was initiated. And ECMO, what it does, it gives rest to the body, it gives rest to the lungs, it gives rest to the heart. So protective ventilation strategies were initiated, RV was unloaded, lung gradually stabilized, and the patient was discharged neurologically intact. What does evidence tell us? The ELSO guidelines tells us that if oxygenation index is more than 40, we should cannulate a patient. But we should not think about oxygenation index only. If our mean airway pressure is rising, if the patient is prone, already on very high ventilator pressures, and we are not able to maintain at least saturation of more than 85%, the patient's CO2 is rising, consider ECMO. Don't remember all those numbers only. And pediatric ARDS data clearly shows that longer the duration of ventilation before you decide to cannulate an ECMO, worse is the outcome. Similar for cardiac ECMO, we should try to optimize all our conventional therapies, but if conventional therapies are clearly failing, don't just wait for the lactate to go and rise for your end organs to suffer and then cannulate, but try and cannulate early. So across different ECMO populations, delayed ECMO initiation is associated with ventilator-induced lung injury, RV dysfunction, end organ dysfunction, and even if you cannulate ECMO at this point of time, the patient may not survive. So why don't we just go ahead and cannulate everyone to ECMO earlier? We know ECMO is powerful, but as I said, ECMO has got multiple side effects. So major bleeding, neurological complications, stroke, thrombosis, infection, renal injury, all these things we have to consider. So final, we have to select a golden window. Too early,
we, at that point of time, conventional therapy might still be working and ECMO risks clearly outweighs benefits. So if the patient is stable with your conventional therapy, don't go ahead and start ECMO. The golden period is what? If you have rising lactate, if you are increasing on the vasoactives, worsening oxygenation, early end organ dysfunction, that is the golden period. And what is too late? Cardiac arrest, you already have hypoxic ischemic brain injury, advanced organ dysfunction, that is too late. So you miss the window and ECMO becomes a rescue ECMO like eCPR. But you catch the window, then ECMO becomes a recovery. Thank you.
Thank you, Shubhodhi, for a nice presentation in a short time and give a very crisp knowledge, because too early it can make them more complicated, and if too late, already irreversible brain damage will be there. So it is better to choose the patient, not the one criteria. Yes. So one criteria cannot be the initiation of ECMO, because we are treating the child, not the hyperlactemia or respiratory failure or cardiac failure. So any questions from the audience?
Sorry, that sometimes we get few patients like respiratory causes or refractory ARDS. So before considering ECMO in pediatrics, still we give a try for HFOB. Yes. Even in a severe myocarditis, we are ventilating, giving inotropes. So sometimes we are on a borderline that few of us think that this patient must be just cannulated to the ECMO. Some of us thinking, okay, we can wait. So this dilemma is always there. And yes. Another thing is that when it decided, no, this is the point that there should not be any dilemma, this patient should be cannulated to ECMO. So what do you prefer? Should we cannulate on the bedside and transport on ECMO, or these 6 kids should be transported on this nasty ambulance with these potholes and to the ECMO center? This is one of the biggest problem that I have faced.
It also depends a lot on the team, okay, and what you are expert at, what you are good at. So if we are talking about a scenario of severe ARDS, and I have got ECMO facility in my unit, but I have just started my ECMO services probably 6 months back, 8 months back, but I have been putting patients on high frequency ventilator for almost like 5 years now. So I would, if the patient is less than 10 years, I would still try high frequency ventilator before going on to the pump. But having said that, if I have got a lot of expertise on ECMO, it does not only depend on the doctor, it depends on the nurses, it depends on the perfusionist, expertise of everybody. I have been managing a lot of ECMO patients. So rather than waiting for lung to be injured more, I would rather cannulate the patient then and there, rather than waiting for a period of time on high frequency ventilator. When we are talking about transport, if the patient has got an oxygenation index like this patient of more than 40, is prone already, then transporting this patient to an ECMO center, if I don't have ECMO myself, that will be extremely risky. So I would rather choose a center where they can come in, cannulate the patient, and then take the patient to their unit. That will be safest for the patient, because transporting this patient on a ventilator will be associated with extreme risk. Patient might die, or even if the patient manages to reach there, might not reach there in a good shape. So even if we cannulate to ECMO, the outcome will not be good.
So I think whenever you are thinking that whether to cannulate this patient for ECMO or not, we should have constant touch with the ECMO team.
Yes, yes.
That now this is the status, you tell me that, so that you come and cannulate.
There are two things currently. There are two scenarios currently in Kolkata. How I feel is there are probably 1 or 2 centers. They would have the expertise. Again, not only expertise of the doctors, but also the perfusionists, also the transport ambulance. They have the expertise to come, cannulate, and take the patient. But also, I don't think that they can take the smallest patient. So for very small patients, transporting on ECMO is still a problem. So I think if you are thinking about ECMO, discuss with the other center, discuss with the referring center very early, and try to transport early before the patient deteriorates much. Because for a neonate, for example, a meconium aspiration syndrome, I don't think anybody in Kolkata can come in, cannulate, and then take your patient. So at this point of time, you still have to send the patient without ECMO.
Thank you, Shubhodhi, because lack of time we cannot discuss anymore. So if you have lots of questions, because upcoming things are gone, so you can ask of the test to the, and Shubhodhi if you'd like to answer all the questions. Thank you. So next speaker, Dr. Rohit Bhaumik, he will be talking on the fluid overload tipping point, when to pull the trigger on CRRT. So your topic, please.
Thank you, ma'am. Good morning all, and thank you the Society of Pediatric Intensive Care Kolkata to give me the opportunity to discuss this topic. Yeah. So after very fantastic talks by very experts in newer things, my thing is very simple: fluid overload and when to do CRRT. And we are lucky that we have experts from pediatric nephrology, Rajiv Sinha sir, Sushmita ma'am, and many other seniors are there. So just before going to my talk, how many of you have encountered fluid overload in PICU? Almost majority. How much percentage of patients approximately? 10, 20, 30? 50% fluid overload. Very good. Thank you. So which method do you use to detect fluid overload percentage? How you detect percentage of fluid overload? So maybe it is a point to discuss. How frequently you monitor fluid overload? Daily, hourly? Daily. But many other things we monitor hourly. So daily, hourly, 6 hourly, maybe some institute prefer 6 hourly charts, intake output. Do you practice RRT, renal replacement therapy, or kidney replacement therapy exclusively for fluid overload in PSU? So now the number is reducing. Exclusively for fluid overload, CRT or RRT. Huh? So next is which mode of kidney replacement therapy for that. So these are few discussions. We in the next few minutes we will focus more of our understanding on fluid overload. What is this? Then common causes, what we encountered, effects of fluid overload. Is this fluid overload really causes some damage to the body, or it is just mere a number? And then when to trigger the CRRT for exclusive fluid overload. This is the point of discussion today. I have some take-home points, but unfortunately, I don't have enough evidence to say this is the recommendation for CKRT for fluid overload exclusively, not with other indications like associated AKI, associated uremia. So some take-home points will be there, not clear recommendation. Next is, what is this fluid overload? So definition, obviously body in the body fluid is increasing. So there are formulas to calculate. There is some is intake output based, some is body weight based. So you can use fluid in, how much fluid out in a 24 hours, and then PQ admission weight and 100. These are percentage. So your FO is, or fluid overload is actually in percentage. You will tell 5% fluid overload, 10% fluid overload, 15% fluid overload, or there is a weight based. So if you see both the formulas, there are few challenges are there. If you really calculate only by fluid in and fluid out, your measurement of fluid in and out should be 100% precious. Otherwise, there will be error. The second one is weight based. That means you need a weight of the patient in different formula, either PICU admission or at hospital admission, and daily monitoring of weight in an ICU patient. Again, challenging. First has calculation related, second one is logistics related. So to calculate fluid overload per se is a challenge. Then for fluid overload, RRT. Next is, what are the common causes? This all of us may be aware of. Excessive fluid resuscitation. Even after patient achieved the endpoint, we are giving fluid. Fluid creep. Slowly, unnoticed fluids are accumulating and adding up to the fluid balance. Like IV fluid, not only IV fluid, some flushes, drugs, blood products. Many a time we forget to enter these things in the chart, or we forget to consider these things in the calculation. Then endothelial glycocalyx injury, capillary leak, inflammation, all this causes slow and steady creep in the fluid. AKI or AKD, if a patient may come with AKI, there are many challenges to define AKI in PICU, criteria related, creatinine related. So the patients may have AKI which may be undetected, and that is causing to fluid overload. Hypoalbuminemia due to disease process, due to nutritional issue. Fluid retention due to your drug related. Common thing, steroids. Many a time we use steroids nowadays in inflammatory storm, different mode of inflammatory storm, or purely for inflammation. So steroids used, which is also leading to sodium intake, giving hypertonic solution for some other indications. ECMO, just now sir told, ECMO related issues, and classical teaching in SIADH is a not hypervolemic, it is a normovolemic situation. But a patient on SIADH, if receives excessive fluid, soon or later they may go to fluid overload state. So these are common causes. Some are avoidable, some are treatable. Next is this fluid overload just a number or it is really causing some issues? So there are almost each and every organ may be affected, not always will be affected due to fluid overload, like CNS, worsening of cerebral edema, myocardial edema, improper function of heart, and worsening of shock due to fluid. Septic cardiomyopathy, just now sir told, so myocardial dysfunction may be associated with sepsis, which is again is getting disturbed by fluid. Lung, worsening of ARDS, GI, gut edema, intra-abdominal hypertension, hepatic congestion, dysfunction of liver, performance, abdominal wall, dehiscence, poor wound healing, renal, per se renal injury can cause fluid overload, and fluid overload also can cause renal damage by some mechanisms. So almost each and every organ is being affected by this fluid excess. Now how do you prevent? This should be the main focus. Medical management and de-resuscitation. We now know Rose concept. We now understand fluid stewardship. We now understand de-resuscitation. That means once your resuscitative phase is over, you think of removing fluids or you think of avoiding fluid overload. Then active fluid removal, when your conservative mechanism fail, you are using renal replacement or kidney replacement therapy. And for 1 and 2, both, we need a standardized monitoring. So the first is fluid restriction. Always we use not 100% maintenance for all patients. We start 2/3, 60%, 70% maintenance. Adjusting the maintenance depending upon your condition as the patient's trajectory, disease trajectory, you are adjusting the maintenance fluid. Diuretic therapy, once your hemodynamics achieved, maybe as an intermittent dose, maybe as a continuous infusion of usually furosemide, and concentrating medications like mixing of 2 medications if you feel, reducing the amount of fluid in the therapy. So avoiding fluid creep. Then different mode of RRT, obviously CKRT one of them, and monitoring, daily meticulous monitoring of fluid in, out, if daily weight if possible, may not be possible, and teach your team to calculate all small fluid if, which is going to the patient's body to find out the hidden sources. So these are common. Now the point, when to pull the trigger. Maybe, perhaps I don't have the answer. When do you have don't answer, you take us consensus, which we started. So there are consensus, there are Delphi methods where people are asking experts, which just I started at the beginning, ke bhai, when you start fluid, which percentage of fluid overload you start? So few Delphi method like that published from the Western world. Soon we may get from our Indian data, where people interested in, some people, not majority people, CKRT for fluid overload. Remember our discussion is only for fluid overload. Here is, I start CKRT after how much? 10%, 15%, 20% fluid overload? See the number, sometimes, majority are sometimes. Some people says no, never, only for fluid overload. Just highlight this point, there are multiple Delphi experiences shared by the experts. Only few people actually believe that only for fluid overload to start CKRT. So it needs real discussion, real research, and experts' opinion. So my points will be fluid overload is common. That is the take-home points. I don't have recommendations. Fluid overload has many end organ effects. It can cause worsening of the disease or prognosis. Many ways are there to prevent and manage fluid overload. CKRT obviously is an essential tool among them, different tool, but when to do, I don't have the answer. Thank you very much, and I welcome questions.
Fluid overload is not only the cosmetic problem, it has lots of the effect and the problem in the whole body. So it's a very critical point to judge when to start CRT, when to continue the medications. So now it's open for the questions. Anyone from the audience can ask 1 or 2 questions. So if there's no more questions, we can.
Thank you.
Thank you, Thank you, Dr. Rohit.
Yes, yes.
Yeah, there's one question. Yeah, from back. Please give him a mic.
So it is said that in case of giving blood transfusion to children, especially in neonates, it may cause, it often causes fluid overload. So is it compulsory? In books it has written we have to see whether there is fluid overload or not, then we'll go for diuretics or furosemide. Or can we give, just after giving mid transfusion, we can go for a diuretic dose furosemide so that we can prevent fluid overload if it.
So your question is neonatology.
Not only in neonatology, even in pediatrics also in child.
So your question is blood transfusion.
Blood transfusion related fluid overload that occurs.
So your question is specifically to fluid overload and blood transfusion, whether to give routinely mid transfusion, Lasix only, furosemide.
Yes.
So I don't have the answer. It is institute to institute practice, number 1. There are no clear-cut guideline on that. Number 2 is, the other thing you can do it, if you have a next 12 hours fluid plan, you can adjust that. You have a blood transfusion plan unless there is immediate hemorrhage like ECMO related, cannula bahar aa gaya, or CRRT blood clot ho gaya, you are removing the circuit. These are unexpected, or patient ka line nikal gaya, blood bahar aa gaya, patient fall ho gaya. Rather than that, you have a plan, I will transfuse this patient. So you can do one thing, you can adjust that volume and can reduce that as a maintenance to give the buffer for the next, not only PRVC, your blood product transfusion, which usually we do for a critically ill patient, especially if the patient is on RRT. This is number 1. Second is, routinely, if hemodynamic permits, people institute to institute prefers. There is no clear-cut guideline as per my knowledge, but again, others can share their experience, not routine practice.
Thank you, sir.
Another question.
Thank you, sir. Sir.
Use mic.
We usually use this method of this intake and output. But how
so
to
fluid in, fluid out.
Fluid in, fluid out.
That is common practice, but body weight based also many unit does.
But how to take the body weight?
Body weight, how to take. So you can.
Are you doing it?
If you have a initial body weight, so not all patients may come in very acute stage. The patient may come in from the ward where there maybe you have a admission weight in there. Number 2 is, if smaller child bed, there are many unit have beds inbuilt where daily weight can be checked, and you can take the accessories weight. So that is another method. So that is that I told you, daily weight measurement is a really challenge in ICU. So practically we do this intake and output and the baseline weight. And baseline weight can be, if you have luckily the patient is coming for ward or emergency where there may be an initial weight. So that weight can be taken. Otherwise, if nothing is there, then ideal body weight.
Any integrated weighing scale in the PSU?
Yeah, it is there. Sir. It is there, sir. We have that. I think Subhadipda also have. We have beds, integrated beds, but that accuracy wise, yeah. Beds are there, and infants that the neotech, nice neotech, in that infants you can you can zero and you can check it and you can see the accessories weight.
In newborn it is always being done.
And smaller child you can do.
They disconnect everything and they do the weight every day and they can put it again.
Bed is there, sir. I can share you the company's name.
Okay. And you can have a weighing scale, digital weighing scale with tearing system. So you can take the baby with the instruments and then just a tear.
Yes.
When you give the instrument on the weighing scale, you just tear, means they push the button, it will be again zero, and then keep the child with all the instruments and gadgets and can have.
Bed is there, sir.
It is
for
there.
ICU beds are there with weighing facility. I can share you. Yes, yes.
For us with an open chest, with the patient on ventilator, PPE in, chest tubes in, it becomes really challenging. And how would you know the accessories weight, like PD catheter weight? How would you know chest tube weight?
Difficult,
So,
difficult.
So we follow intake output,
Intake output.
hourly measure. We follow intake.
So that is why your team should be very much trained to document all the fluids. Sometimes they are reluctant, they may not document the flush, commonly flush missed. If you go and see the data, you ask, are you putting your all flushes in your nursing chart? I am sure today, tomorrow, 80% of the audience will feel no, it is not. So that much is my take home points. All fluids should be measured because you are calculating fluid in, fluid out. And if your data is wrong, how can you measure?
Sir, nice presentation, sir. You are correct. You cannot measure everything on catheters, but in the weights we have weights which can calculate the weight of that patient.
Yes,
but you can see the weight change, but that also varies. If I checked it with different persons and different times, so that weight change is also different. So if you take at different times, so it is not reliable at all.
Yeah, that is that much not reliable. Maybe if RCT, if many institutions have that bed, we can do side apart the company's
but
interest.
still we are taking that weight change also like that.
So calculate fluid percentage by this method and by bed method. So that can be done.
Okay, I think
thank you.
Further discussion can be gone beyond the that's okay. Thank you, Dr. Rohit. Now next speaker, Dr. Shatarupa Mukherjee. She will be talking on quality indicators in PICU beyond the mortality.
Good afternoon, everyone. So, first of all, thank you. When I got this topic, I was really very sad because I thought it's just the indices and the formulae and all. But then when I read through, I thought I would be let me present in a non-boring manner. So I've tried to put forward. So quality indicators in ICU are very important. Why? Because in PICU is a unique place where we deal with complex diseases involving children of different age groups and sizes. There are complex invasive and non-invasive procedures involved, continuous use of high-risk medications, and complex interaction between technology and erring humans. So it is very important that we have quality indicators or key performance indicators in the pediatric intensive care unit. So we'll start with the case. A 5-year-old girl, Sweetie, admitted with septic shock, ARDS, intubated, ventilated, central line, arterial line, urinary catheter inserted, stage 4 AKI, anuric, CRRT initiated. High frequency ventilation for the bad lungs, but not settled. Started on VV ECMO. Improved in 5 days, decannulated, extubated, but reintubated in 24 hours. PICU stay of 15 days, shifted to ward, but again readmitted to ICU on day 17. Finally discharged on day 20. The case was up on social media. Immediate shower of applause for the caregivers. The victory. But the question for the audience, was this a successful ICU admission as Sweetie got discharged? If yes, why? And if no, why? Please raise up your hands who think it's a successful ICU admission. Okay, so let's go in detail about the PICU stay. So Sweetie developed CLAPSI on day 5, that is central line associated bloodstream infection, ventilator associated pneumonia with exterior Klebsiella, catheter associated UTI with exterior Acinetobacter, accidental extubation on day 4, delirium post extubation, family is very dissatisfied with communication and readmitted to PICU. Do you still think this is a high quality care where we have kept everything safe but the treatment was effective and we had a sustainable use of resources? So no. Do you think survival is equal to quality here? So the PICU quality iceberg, what we see above the water is mortality, but what we see below are infections, functional outcome, to what extent we have sent the child back home with the functionality the child was having before, what is the family experience, did we have any readmissions, were there any safety, unsafe events, how is the delirium, like is the child delirious, and how are the staff well-being. So let's go back to the case. Sepsis recognition. The child arrives with septic shock. What are the process indicators? Time to antibiotics, time to fluid resuscitation, sepsis bundle compliance, and time to vasoactive agents. Did we start the antibiotic on time? What was our fluid resuscitation protocol? Did we give 2 months fluid boluses, or what? Did we go by the sepsis recognition bundle? And what was the time to our vasoactive agents? A PICU can have excellent mortality but poor sepsis bundle compliance. Then mechanical ventilation. The child remained ventilated, but the child had ventilator-associated pneumonia, and there were accidental extubation. So there were ventilator-associated event. What is a ventilator-associated event rate? And did we do a daily spontaneous breathing assessment? Did we adhere to a sedation protocol? And what was the ventilator-free day? Which is better, 100% survival or shorter ventilation duration with fewer complications? Unexplained extubation. The child got self-extubated. Is this merely a bad luck or a quality indicator? Unplanned extubation. What are the unplanned extubation rates at your institute? What is a sedation practice protocol? Do we follow a sedation practice protocol in the unit, or we do it arbitrarily? What are the nursing staffing? Like, do we have a 1:1 nursing staff, or we have a random nursing staff? We have too many shortage of staff, too many absentees, too many nurses leaving the unit. And what are your securement bundles? Then come to the central line infection. The child had a very bad CLABSI, develops fever, blood culture was positive. What are the quality indicators? What is your CLABSI rate in your hospital? These are the Swiss cheese model of errors. Like, if you have, there is no like a single root, when we do a root cause analysis for a particular event happening in the hospital, it is not like a single cause, but there are multiple factors associated with the event happening in the unit. And there are, what are the preventable harm? Yes, and the preventable harm matters more than the survival. This patient definitely had a delirium. The child was agitated, sleep was disturbed, there were hallucinations. What are the quality indicators? Did we have a delirium screening compliance? What is the delirium rate in the hospital? Did we do early mobilization? And finally, the family experience, which is often neglected. The mother said that nobody explained what was happening. What are the quality indicators? What is the family satisfaction score? Did we ever think of calculating it? Did we allow the family to participate in rounds? And what is the communication quality? Unexpected readmission. The child was readmitted. Do you think it is quite a normal phenomena? Yes, we might think the child is sick, then it means that your criteria for sending the child for de-escalating therapy or sending the child to the ward was not right. So your ICU readmission rate indicates a quality, that how your ICU is working. So there was unexpected readmission at 48 hours. There was respiratory distress, back to ICU, definitely that was because of a pneumonia. So unplanned PICU readmission rate. What is the unplanned PICU readmission rate in the hospital? So we have to discuss here, what are the premature discharge rates? Is there any inadequate handover? And how do we monitor the patients in the ward? Do we just send them and forget about them? Or we, from the intensive care unit, do daily rounds for the children whom we are sending back to the ward? Then finally, the discharge day. How do we send the child home? The child definitely has survived, but there is weakness. She's having swallowing difficulty, she's not able to communicate properly, she's not back to her baseline, and she's not able, even after sending home, we find that she's not able to attend school. So the quality indicators, the functional status scale, and the quality of life, and the rehabilitation. Have we done the rehabilitation referrals? So finally, the key message is that the goal is not merely survival. The goal is survival with function. So we can have a PICU dashboard where we can do a traffic light dashboard, where the green stands for family satisfaction and hand hygiene. Yellow is for ventilator-free days, orange for readmissions, and definitely red is for CLABSI and unplanned extubation. How do your dud sweetie stay here? Yes, survived, she has survived. But she had CLABSI, unplanned extubation, delirium, family satisfaction was very bad. There were unplanned readmissions, and the functional recovery is questionable. So definitely, this is not a good outcome. So the take-home message is that the best PICUs do not simply save life. They deliver safe, effective, patient-centered care that preserves long-term function and family well-being. Thank you.
Thank you, Shatarupa. The outcome is not only the survival, it is the quality of life. So survival along with the quality of life is a good predictors. So any questions for this topic from the audience?
I don't think there is.
So there's no more question.
Like once we are sending someone, like we are happy if the child survives, but to what extent?
Yes,
the
quality of life
morbidity
matters.
and like how the child is back home. Do we ever ask? Yeah, we sometimes we do ask them like, and but that is one important predictor that how we have worked.
Yeah. So any more comments from this? Okay, then we can declare the session
Thank you,
over
ma'am.
here.
And that brings
Thank
us
you,
to the
sir.
end of this session. I request our respected chairperson, ma'am, as well as all the three speakers of this session to kindly move to the felicitation station. We now move on to our next session, which is a panel discussion. Dr., who is a professor of pediatrics at KPC Medical College. So I request to kindly take your place on the dais. The session will be moderated by Dr. Prabhas Prashangiri, who is a consultant pediatrician and pediatric intensivist at Institute of Child Health, Kolkata. Panelists for this session include Dr. Devdatta Mukhopadhyay, who is an associate professor at Dr. B.C. Roy PG Institute of Pediatric Sciences, Dr. Rupa Bishwash, who is an associate professor at CNMC, Dr. Shananda Mukherjee, who is a consultant pediatric intensivist at PLS Barashat, and Dr. Shayantika Saha, who is a junior consultant at the Pediatric Cardiac Intensive Care Unit, BM Birla Heart Research Institute.
Next, হয়ে গেল এটা সবার নামে দাও আপু very good morning all. Without any delay, let us start with the discussions about survival sepsis campaign, the updates of 2026. So this is the recent article that has been published in PCCM about the survival sepsis campaign, international guideline for the management of sepsis and septic shock in children 2026. So this article usually reviewed in every 4 to 6 years, and our discussion will be based on this article only. So on this article they have recommended many things. On many standards of recommendations are there, like strong recommendations, conditional recommendations, good practice statement, in our practice statement, like that. So strong recommendations meaning that most children should receive that. Conditional recommendations means there must be some individual decision. Good practice statement means common sense practice despite limited evidence, and in our practice statement means expert practice pattern only. So let us start our journey with a case. A previously healthy 6-year-old boy presented to A&E with a history of fever for 6 days, cough for 6 days, poor feeding for 3 days and lethargy for 1 day. There was increasing breathing difficulty for last 12 hours. On examination, he was tachycardic and tachypneic, drowsy and irritable, cold extremities with low pulse volume. There is a prolonged CRT, temperature is 102 degree Fahrenheit. Saturation was 90% at room air, blood pressure was 80/40, NIBP, MAP was 52. So my question to Dr. Devdatta, that does this child have a septic shock?
Yes, as we can see over here, the child has got a suspected infection, having fever for a few days, and in addition to that has got hypotension, lowish BP, a prolonged CRT and altered mental status. So according to the Phoenix sepsis score, it is suspected infection and involvement of any 2 of the 4 organs. Here we have already involvement of the cardiovascular system in the form of prolonged CRT, hypertension, and also altered mental status, that is the neurologic involvement as well.
So diagnosis is clear cut that this child having septic shock. So would your institution sepsis screening system identify this child? Do you want to do any sepsis screening system, Sananda?
So we don't routinely use any screening system. It is a clinical diagnosis. So there is insufficient evidence of using a routine systematic screening tool. But we can use clinical judgment and pediatric early warning system score, which is it sees the children as a whole, as appearance, cardiovascular, respiratory, and post-surgical any.
Do you prefer that the PWS score should be printed and posted in the wall of the ward and emergency?
Yes, it should be. I do it with my team. It should be done.
Okay, how sepsis is defined in 2026, Dr. Rupa?
The sepsis, according to survival sepsis guideline in 2026, the infection, any suspected or confirmed infection with organ dysfunction is the definition of the sepsis in 2026. It is not only the simply fever, tachycardia, and as the previous guideline SIRS, that was the tachycardia, tachypnea, increased temperature, and abnormal WBC count. Any of two was positive. Along with fever and tachycardia, it was assumed that it was sepsis, but now the definition has changed. Next slide, please. Nowadays the sepsis is defined as infection leading to life-threatening organ dysfunction, inclusive of patient with septic shock, and the septic shock is defined as the subset of sepsis which inadequate perfusion or cardiovascular dysfunction, as Dr. Debrata says that there is any organ dysfunction associated with sepsis, and the probable sepsis was clinical presentation consistent with sepsis, but infection is not yet confirmed, and the suspected septic shock is a shock of unconfirmed etiology with suspected secondary infections. And the septic shock with persistent type of hypoperfusion is sepsis with ongoing signs of hypoperfusion despite of initial treatment.
So this terminology has been used by the recent 2026 criteria. So there's a changing in the concept from 2020 to 2026. In 2020, they were mainly relying on the SIRS criteria and the organ dysfunction criteria just crippling in. And 2026, they are more concentrating on organ dysfunctions, perfusion abnormality, altered mental state, and they are giving a paramount importance to the lactate, initial lactate, serial lactate, lactase clearance. These things are coming in, and definitely on the hemodynamic instability. So the question that have we overcalled sepsis for years by relying too much on SIRS? The answer is possibly yes. So, Dr. Shantika, do you recommend any standard operating procedure for all that kids that presented to sepsis?
So, as per the 2026 surviving sepsis guideline, they have recommended to have a standard operating protocol for all the patients to manage for the septic shock. The recommendation is strong, and as per this protocol, if a patient comes with probable sepsis, we have to start investigation and management as early as possible within 3 hours of the initial suspicion of the sepsis. And this blood investigation should include the lactate, blood lactate, and the blood culture. And then you have to give the first dose of broad spectrum antibiotic within 3 hours of the initial suspicion of the sepsis. And if the patient comes with suspected septic shock, then we have to do it within 1 hour of the onset. And next come to the fluid bolus therapy, and start with the 10 to 20 ml per kg fluid bolus, mainly the balanced crystalloid solution, but
So
they have
we'll
recommended.
Go on in details on later on.
Okay.
So definitely you can see that these things has been red marked, so that they are totally defined two different categories. One is the probable sepsis, one is subtest septic shock. So in this category you have to act very fast according to this protocol. Dr. Devdatta, what would be the next bedside investigation you want to do for this patient?
Like we said that within
This
the
patient is
first
present with
hour
a
we
septic
should
shock.
be doing a blood gas.
Okay.
And it would give us not only the pH
So,
but the
this
lactate
blood gas
as well.
revealed a pH of 7.33, PO2 65, PSO2 35, SCO2 15, and lactate is 5.2. What's your comment on that?
There is some respiratory acid, there is some hypoxia and acidosis, metabolic also, and there is increased lactate.
So as they are giving a paramount importance on the initial lactate or serial lactate measurement, so ABG comes very fast nowadays for the new criteria. because they are giving more importance to the perfusions, mainly the organ perfusions. They are not giving importance to any other numbers, whatever may be your BP, saturation, they are not giving that number. They are believing in the perfusions, and lactate is nothing but the surrogate marker of the perfusions. So 2020 thinking, no recommendations to measure lactate at arrival. 2026 thinking, strong recommendations to measure lactate at arrival as a part of initial evaluation and management. So if your lactate is high, it's a red alert. So how are you going to resuscitate this kid? How much fluid you want to give? Any change in the resuscitation recommendation in 2026? This debate is going on for the last 2 decades. Each and every time the recommendation is being changed. What is there recently in 2026?
So we start with crystalloid ideally, and so in setups where child is in shock and we do not have pediatric intensive care settings, then we have to give around 40 ml per kg fluid bolus, and we should give the fluid bolus in small aliquots of 10 to 20 ml per kilo, and after completion of each bolus, we should assess the hemodynamic status or signs of fluid overload. So it should be a continuous assessment. So in case of healthcare setup where we have a pediatric ICU setting, then we can go that fluid bolus up to 60 ml per kilo in the first 1 hour. And again, we have to monitor signs of fluid overload.
Yeah, definitely. So in both 2020 and 2026.
One more point, and
yes.
there was, we should not give any bolus if there is no hypotension and no ICU facility.
So both in 2020 26, the guidelines are same. Initial fluid bolus, always crystalloids, always crystalloid. The BSS solution is preferred over 0.9% saline, as we got from the last speaker. And there is no role of albumin, starch and gelatin, at least in initial period of time. So 2026 thinking is that resuscitate in the same way, but reassess after each bolus. There should not be any blind resus. Avoid fluid overload. As advanced fluid status monitoring should be done by the POCUS, ECHO, IVC checking. Continue clinical assessment of fluid overload. So hemodynamic status should be reassessed after each fluid bolus. Fluid bolus therapy should be titrated to clinical markers of cardiac output and discontinued if shock resolves or signs of fluid overload develops. So there is no straightforward formula that you have to give 40 ml per kg, you have to give 60 ml per kg. So each and every patient is different and treat them differently with very close monitoring, specifically with non-invasive advanced monitoring. So my question to Dr. Rupa, would you perform POCUS before giving the second bolus? Would POCUS change your vasoactive choice? Would POCUS help identify fluid overload? Because in 2026 guidelines, they are bringing POCUS a bit upfront.
Yes, it is the answer is yes, definitely. We would do the POCUS for after each and every bolus also, and also we do POCUS for the to decide our vasoactive agent. We will see the cardiac contractility, whether there is the cause of the shock is reversible or not, whether it was hypovolemic shock or it was cardiogenic shock or it is distributive or septic shock, and also the POCUS can help the fluid responsiveness and the fluid overload by doing the lung USC and also the cardiac to monitor the cardiac output by cardiac POCUS.
So definitely we usually go by this protocol that is called FALS protocol, like fluid administration limited by lung sonography. So after each and every fluid bolus, we are doing a lung sono. So in our program, there is 30 ml per kg of valence salt solution has been given. Blood pressure is still on the lowest, 76/40. MAP is 50. There is a persistent poor perfusions. Worsening respiratory distress, there is a bilateral crepitations, IVC is full. So Shantika, what will be your next course of action? We are landing in this situation.
So now the patient is having still the low blood pressure, still in shock with fluid overload. So the next option is vasoactive medication, that is inotrop.
Yeah.
And the next
these questions usually coming from the juniors level, each and every day, that when to give, which to give, how to give, how to titrate.
So as per the 2026 guideline and in the 2020 guideline, both are against the use of dopamine in septic shock, and both are recommended either adrenaline or noradrenaline in septic shock. But in 2020 guideline, there is no such recommendation that what should be used first. and it remains same in the 2026 guideline, although in the 2026 guideline it was mentioned that the choice can be based on the patient's status and the clinician preference. And next is how to give. In the 2026 guideline, they have recommended to use it through the peripheral access until or unless the central venous line has been secured. And it can be started before giving 40 ml per kg fluid resuscitation, which was different in the 2020 guidelines. They have recommended it to start it after 40 to 60 ml per kg fluid resuscitation. And to start the vasopressin in early vasoplegic shock, both our recommendations remain same. And regarding the use of the angiotensin 2 and the methylene blue in the septic shock, there is insufficient evidence in the 2026 recommendation, and it was not at all discussed in the 2020 recommendation.
Excellent. So this is in a nutshell the differentiation and the different opinions between 2020 and 2026 recommendations. So the question is that, are we finally moving away from the fill the tank philosophy, and whether the pediatric septic shock moved beyond cold shock and warm shock era? I think yes. So our kit has been started with the infusion of adrenaline 0.1 microgram per kg per minute in peripheral dilutions, already shifted to PICU, put on NRBM, 45 minutes passed since arrival to A&E. We have managed to do a chest X-ray. You can see that right-sided dense consolidation is there. Dr. Devdatta, what should be your next course of action?
Since it's already 45 minutes, so we should have given an antibiotic, a broad spectrum antibiotic, as in septic shock. We should be giving it within 1 hour. And that was the recommendation before, and it continues to be the same in the 2026 guidelines. And we have also, studies have shown that the mortality will be increasing by, some studies say, about 1.8 to 2% with every hour delay in giving the antibiotics. If we are not in shock but we are suspecting sepsis, then again we can be giving it within 3 hours. That was the recommendation as before and continues to be the same.
So definitely. So there is a considerable change is that antibiotic stewardship and de-escalation had been stated in 2020, but 2026 has more been emphasized. So if you are getting a septic shock, don't go for any investigations, any evaluation, go straight for giving antibiotic before 1 hour. If your sepsis a bit stable, you can get some CRP, TLC, Procal to come around. And definitely this thing has not been discussed about the role of procalcitonin, and they are stating that routine involvement of infectious disease consultant documented in the bloodstream infection. So these are the basically key differences about the antimicrobials, about the antibiotic use and everything between 2020 and 2026 guidelines. So now another very doubtful area, that prolonged infusions versus intermittent bolus, whether we should give a prolonged infusion of BLI and carbapenem, why prolonged infusions should be there. So definitely there are lots of studies that are showing that if you are giving a prolonged infusion of BLI, beta-lactams and carbapenems, there is a survival benefit is there, good antibiotic killing because they are giving a time-dependent killing. There is a PKPD optimizations, but guidelines of 2026 are telling that there is insufficient evidence for or against these prolonged infusions. The 2026 guidelines, in most of the recommendations, they are telling some dubious. You can do, you can't. You can be doing this, there is no for, no against. In only few of the areas they are giving us strong guidelines, you have to do it. So again, the question arises after recommendations from 2026 guidelines that whether the pharmacological principles ahead of pediatric evidence, we don't know actually. So our patient had been started with IV ceftriaxone as after 45 minutes of arrivals. So at 1 hour since admission, still tachypneic, saturation is 93% in NRBM. Blood pressure is still low, adrenaline is 0.2 mics per kg per minute, non-adrenaline is 0.2 mic per kg per minute through peripheral lines. So what will be your next course of action, Dr. Sananda?
So at this point we will consider to send the relevant investigation, basic blood workup, and access wise I think we should secure a CV line because we need to increase our inotrope dilution to central line dilution. And then also we should start an arterial line and monitor the invasive arterial blood pressure because that is actually the reliable marker, the invasive arterial blood pressure.
Exactly. Your patient is already on fluid resuscitated, already developed fluid overload, on dual inotrope peripheral lines. There is no way you can escape a central venous line at this moment of time. So can you tell me the differences between the hemodynamic monitoring protocols that have been studied in 2020 and 2026?
Okay. So in 2020, so there was no target MFP map mean arterial pressure recommendation. So whether it should be 5th centile or 50th centile. And in 2026 also that has not changed. But at the same time, 23-26 guidelines has emphasized the ongoing clinical assessment of other hemodynamic marker status like heart rate, capillary refill time, temperature, pulse quality, level of consciousness, urine output besides blood pressure. And there was in 2020 guideline advanced hemodynamic variables such as cardiac output, cardiac index and systemic vascular resistance and central venous oxygen saturation. They had emphasized using them. But 2026 guideline has told that there are insufficient evidence of any advantage of using those advanced hemodynamic monitorings. But they have recommended measuring the target central venous oxygen saturation, which is should be kept above 70%. And also bedside ultrasound scan of lungs and cardiac echo to monitor the contractility and cardiac function has been
So I think this is the most confusing area of 2026 guidelines that has published. Sometimes they are telling us to go to the basics to monitor this patient clinically. Sometimes they are asking that do focus. They are going to the EGDT. Almost 30 years back, you measure a SCVO2 after 30 years back. And again, in the last couple of years, we are quite very much fond of doing this systemic venous resistance. We are getting this flow track machines and everything are doing. And now they are telling there's insufficient evidence. So this is much more confusing about the hemodynamic monitoring. Sometimes they are asking that go to the basics. Sometimes they are asking use focus. And sometimes they are doing the EGDT study, doing the SCVO2 monitoring. So it's very much confusing. So should we target excellent numbers or good perfusions from audience? Good perfusions, definitely. So 2 hours since admissions, got the first dose of IV antibiotic already, outline and CVL in place, and dual line approach to central line, now at 0.2, adrenaline 0.3. Blood pressures, arterial 76/42, 54 is a MAP, repeat APG, PO2 57, PCO2 23, lactate 4, saturation is 88%, already escalated from NRBM to HHFNC, sensorium is quite good, FiO2 70%, flow is 40 liters. What will be your next course of action, Dr. Santika?
So the patient is still in shock with high inotropes and the saturation is coming down with triple H FNC. So the next option is mechanical ventilation. Now what we give, non-invasive or invasive ventilation. Although invasive ventilation has some benefits, but there was no such recommendation in the 2020 guidelines for prophylactic intubation of the septic shock patient without respiratory failure, and it remains same in the 2026 guideline. And both have recommended not to use etomidate during this intubation. Although in the recent guidelines, it was mentioned regarding the target saturation of the septic shock patient, and it should be between 88 to 92, although it was not mentioned in the previous guideline. But the 2020 guideline has mentioned to give a trial of the NIV with high PEEP, recruitment, maneuver, prone positioning in septic shock with ARDS, but in this 2026 guideline, they haven't reviewed this.
Yeah. They have not reviewed the detailed management of ARDS in these guidelines. They are referring to the PALIC 2 guidelines. So I am not going to on details on that. But definitely one thing is that in few of the patients with shock, otherwise respiratory status is good, sensorium is good, saturation is maintaining. We had a feeling that we should intubate, prophylactic should be intubated before the patient crash, but they are not giving any recommendations on that.
Just one moment to note. If this child had a cardiac dysfunction, then maybe we should intubate this
definitely.
child. Because
if
to support
cardiac
the LV.
dysfunction, there is possibility to intubate, and if the sensorium is coming down, no doubt on that. So 4 hours since hospitalization, he has been already intubated and ventilated. You can see on ventilation is there, CVL is placed, and PRBC mode FiO2 of 80, PEEP of 12, TV is 140, the weight is around 20-25 kg, rate is 25, saturation is 92, ETSO2 is 45, blood gas reveal PO2 of 58, PCO2 of 52, pH still low 7.16, bicarb is 16, lactate is 5.1, arterial blood pressure 76/40 is 50, adrenaline is 0.5, NORAD is 0.5, and already on vasopressin. So what next, Dr. Rupa?
In that case, the patient is in shock and the inotrope support has been increased and it is the fluid refractory catecholamine.
Adapting therapy like this? What's the comment on
Catecholamine is, but in 2026 guideline, that they does not suggest the using of the steroid, methylene blue or any other immunomodulator agent. As per the 2026 guideline, the catecholamine resistant shock, we have to assess the hemodynamic monitoring and titrate the catecholamine, and also we can add the vasopressin also, but they didn't suggest the using of the steroids.
So what is our age-old thought that if the patient has been a fluid refractory catecholamine resistant shock, you have to give a steroid. How many of you are practicing this? I think everyone. But they are telling for children with septic shock who remain hemodynamically unstable despite adequate fluid resuscitation and vasoactive therapy, there was insufficient evidence to issue a recommendations on whether to treat with IV hydrocortisone. So they are telling there is insufficient evidence, but I think all of us practicing that if fluid refractory, if catecholamine resistance, give hydrocortisone. And definitely they are against using of any IV immunoglobulin. They are telling should not use methylene blue. Now we have a patient that is going on methylene blue. They are telling you don't use methylene blue, don't give IVIG. And definitely one of my favorite things like therapy with the vitamin C and thiamine, like this immunonutrients is no role. They are totally against that. You should not use these things. So 12 hours since hospitalizations. So this is our patient, and now we have done a focus. Patient is not responding.
But it tap korle kichu aste pare.
What is your opinion on that?
We can see that pleural effusion over there with a lot of sediments also there, septations and sediments. So we would immediately try to find the source of the infection, do a tap, and then send for culture.
So in 2026 guideline, they are giving paramount importance on the source control as early as possible. You see that we are almost cornered for this patient on high inotropic agent, not responding properly. We cannot use steroid, methylene blue, anything. So we have to find out that whether we can reduce the source or not. So we need to reduce the source. So we have put a chest drain for this patient. We got almost pus. So at that moment, we got the blood report, hemoglobin is 10.2, total count is high, platelet is on the lower side, CRP is sky high, procalcitonin is not measurable, the amount of AKI is there, transaminase is there, albumin is low, electrolytes are normal. So at 24 hours, status quo, moderate to high ventilation, febrile, triple inotrope. My question to Dr. Shanunda, would you use albumin? Are you using albumin for physiology or just for a comfort?
Okay, so this patient has already received high dose of crystalloid. So earlier in 2026 guidelines as well, it has been shown that crystalloid is the only choice, and crystalloid plus albumin therapy has no extra benefit over the crystalloid only therapy. But again, it is individual case. If you consider this patient is already on high inotrope and already they have received a maximum amount of fluid, crystalloid fluid. So in this patient, use of albumin is permissible, and of course if we use more crystalloid here, we have the risk of having more fluid overload. So albumin in this case can be used, but also with monitoring.
So remember that septic shock patients are very much dynamic for the first 48 hours. Sometimes they become fluid responsive, sometimes they do not become fluid responsive. Though 2026 guidelines are telling strongly against to use albumin for these patients, but even after getting 40, 60, 80, 100 ml of crystalloid with inotrope, after 24 hours, 36 hours, you are finding that the patient are bit still fluid responsive, where albumin is low. I think most of us are practicing giving a diluted 5% albumin bolus, a bit infusions over 2 to 4 hours for these patients. So at 48 hours, this patient is 1.6 liters positive fluid balance, definitely got lots of fluid balance. The kidney started deteriorating further. Urea and creatinine is rising up, almost oliguric. Saturation is crippling to 70 to 80, 90, PP is 12 to 14. Vasopressin has tapered off, but still on NORAD of 0.4 and adrenaline of 0.3. what should be your next management?
Now the problem is fluid overload and AKI. So you have to remove the fluid to save the child. The next option is renal replacement therapy. The 2021 guidelines suggested using renal replacement therapy to prevent or treat the fluid overload in children with septic shock or other sepsis-associated organ dysfunction who are unresponsive to fluid restriction and diuretics therapy. But there is no such recommendation in the 2026 guideline. But the 2021 guideline was against the use of the high volume hemofiltration, where the effluent rate was more than 35 ml per kg per hour. But the recent guideline have recommended to use this high volume hemofiltration over the standard volume of hemofiltration to save this kind of child.
So this is a significant change that happened from 2020 to 2026. So aggressive resuscitations causing definitely fluid overload. So the question is that, can successful resuscitation itself become harmful? We don't know actually. So at 72 hours on CRRT, urea is coming down 62, creatinine is coming down 0.7, urine output is low, definitely on CRRT. On circuit, FiO2 is 50 to 60% coming down, PPF coming down, adrenaline, non-adrenaline is 0.2. So hemoglobin is 7.2, platelet is 65,000. There's a bleeding from prick site. So what should be our thought at this moment of time, and what should be a transfusion threshold at this moment of time?
The patient is having low hemoglobin, low platelet. Probably the patient is developing the DIC, and the transfusion threshold is remain same as per 2020 and 2026. The hemoglobin should be maintained at 7 gram. And in a hemodynamically unstable patient, and the platelet should be below 50,000 and active bleeding, we can give the platelet transfusion, and there is no recommendation of the FFP transfusion if there is no active coagulopathy, and it's in that case we can there is no indication for the any blood product transfusion.
So definitely at this moment of time, what is lacking? Our coagulation parameters is lacking. So depending upon the coagulation parameters, Dr. Rupa, what will be your differential at this moment of time?
It can be DIC, it can be hyperferritinemic sepsis, and it can be thrombocytopenia associated multi-organ failure dysfunction.
So sepsis has different phenotypes. I'm not going into details. So the thing is that from that period of time, we are strongly differentiating from TAMO phenotype to a DIC phenotype, because in TAMO phenotype, the platelet will be low, there will be anemia, there will be cystocytes, and placing will be bleeding. But the coagulation parameter will be not that much deranged or maybe normal. But in DIC phenotype and hyperferritinemic sepsis phenotype, the coagulation parameter will be deranged because predominant liver dysfunction will be there. And they are strongly recommending for the TAMO phenotype, you have to do the plasma exchange. But here 2026 guideline that then for children with sepsis or septic shock who meet criteria for TAMO subtypes, there was insufficient evidence to issue a recommendations on whether to treat with plasma exchange. Again, for children with sepsis or septic shock, there was insufficient evidence to issue a recommendation on use of extracorporeal blood purification. I think Rajiv sir is there. I think he will be very much unhappy now. Rajiv sir is there? Oh, sorry. I think he is depressed, very much depressed. He's very much depressed. So we got Streptococcus pneumoniae from the blood culture as well as the pus culture here at 96 hours. Patient on a CRRT, urea creatinine coming down, urine output is same. We can decrease the ventilation a bit, inotrop struggling. So what next, Dr. Sananda?
So as we can see from our lab parameters, our urea has come down significantly, and also the ventilation requirement we are able to come down. So the fluid we have managed to take out. So at this point, I think the CRRT should be in the decremental phase.
Okay. So we can keep the fluid removal depending upon the fluid overload status, but we can dose. The dose of CRRT can be coming down. So again, CRRT is on decremental dose, urea is 34, creatinine is 0.5, urine output is 1.4 ml per kg per hour, even after decremental dose. Definitely we come down on FiO2 and PEEP. You can see there are bit pneumothorax is there and lungs has been improved. So at 144 hours of CRRT, extubated to NIV, febrile for 24 hours, shifted to general bed on day 7, on discharge on day 12. So what should happen after PICU discharge? Lots of discussion was there about the PICU liberation. Is survival still enough?
So, the patient was discharged from the PICU after recovering from septic shock. We have to give focus on the following points. the PICU rehabilitation, the neurocognitive outcomes, the family counseling, the post-sepsis syndrome, the school reintegration. In this recent guideline, for the children with the sepsis and septic shock, they have suggested to implement an individualized early rehabilitation bundle during the acute illness rather than not using a rehabilitation bundle. But there was insufficient evidence to recommend for or against the targeted post-hospital follow-up. And for the children who survive sepsis or septic shock, it's reasonable to assess the risk factors for the post-sepsis morbidity, educate the patient, the family members, and the clinicians on the symptoms of the post-sepsis morbidity, and evaluate for the new long-term sequelae after the hospital discharge.
So as this 2026 guidelines is emphasizing on that even after the discharge, even after the survival, your work is not completely done. As Dr. in the morning in the panel discussion, Dr. Kaushik discussed on the panelist on PICU liberations, and Dr. Satyarupa just discussed whether the survival is enough or not. So they are strongly recommending on this PICU rehabilitations, neurocognitive outcome. There must be a dedicated PICU follow-up clinic, and we have seen those who are the PICU graduates, they are a bit possibly immunodeficient due to some reasons. They are more prone to develop local respiratory infections, some diarrheas, even after discharge from the PICU. So, rapid fire about use of vitamin C, Dr. Sananda? No, yes or no?
No role, no role.
Use of vitamin D, Dr. Rupa?
No.
Use of thiamine, Dr. Dutta? No role. Extracorporeal blood purification, Dr. Shantika?
There is insufficient evidence in the current guideline.
So, now the most controversial thing. Use of immunosuppressant in hyperferritinemic sepsis. So we can discuss 2 or 3 days depending on that. And I think each and every PICU in a multi-specialty hospital, there is a battle between the immunologist and rheumatologist with the PICU specialist. The PICU specialist a bit resistant to give too much of immunosuppressant, maybe a bit dose of 1 or 2 dose of dexamethasone, 1 or 2 dose of hydrocortisones. But immunologists or rheumatologists are very enthusiastic. The ferritin level of 501, they are coming, this is a 501, we need to give anakinra. We need to give pulse methylprednisolone. I think this phenomenon is general all over the India. I have discussed with all of the PICUs, but still it is doubtful area. I am not going into details. Strict glycemic control, Dr. Sananda, you want to keep the blood sugar below 150 all the time?
It is 180, and strict glycemic control can cause hypoglycemia. So 180 and equal is...
Dr. Okay. Rupa, you want to put stress ulcer prophylaxis to all? No. Dr. Devdatta, DVT prophylaxis to all?
Not in children, but we should be aware of whether any cardiovascular complications is developed, especially we are putting in central...
If adolescents, always risk factors are there, we have to give DVT prophylaxis. So, evaluation of pediatric sepsis care, earlier era to modern era, SIRS focus, this is organ dysfunction focused, aggressive fluid, now this is a precision fluid like precision missile, small target, NS dominant, now BSS dominant, delayed vasoactive, early vasoactive, broad antibiotic stewardship, resuscitations and PICU survival focused, whole recovery focus, protocol heavy, and there is mostly individual care. The journey from SSC 2020 to SSC 2026 represents a transition from protocolized pediatric sepsis care towards individualized precision resuscitation. Thank you.
Very nice panel discussion. Thanks to Prabhas and the excellent women brigade, women empowerment. So few questions from, and very happy to see all the pediatric intensive care is being led by the stalwarts, lady stalwarts. 1 or 2 questions because of time.
Yes.
What's happening is, these guidelines, they are becoming almost like political statements. Okay. And that's right. For a guideline, from a guideline perspective, that was a disaster that you state something, you should use it in a guideline, and the next guideline, you have to withdraw it. That is a disaster from a guideline perspective. They cannot do it. So they are trying more and more to avoid that. And the fact remains that we have very little pediatric evidence. So that is why there is so much about, we have no definite recommendation. For this junior specifically, you know, that doesn't, we have no specific recommendation, does not mean you cannot use it.
Definitely.
That does not mean you cannot use it. Like say PKPD, we have got very good, you know, very good adult evidence that infusions work better. We don't have enough pediatric evidence. Will I not use it? I will use it. So whether to use it or not, one of the most important factor to think that, does it have any potential bad effect, whatever is your intervention. If it have a potential bad effect, then think twice. If your protocol, it can be either effective but will not cause any harm, I will use it, even if it is not there in the guideline, or the guideline says, yeah, plus minus, I will still, because if you keep working, excluding all the plus minus, then you are hardly left with anything. Yeah.
So, thank you very much. We conclude here. Okay.
Thank you, sir. I request our chairperson, sir, and our panelists to please proceed for the felicitation. Although I'll have to request the speaker, Dr. Prabhas sir, to kindly stay back, because now we move on to our partnership sessions. The first session will be taken by him. It will be a session on pneumococcal pneumonia in PICU, a case vignette.
Thank you. So now we are entering to the partnership session. So my presentation will be on pneumococcal pneumonia in PICU. Different case scenarios. This session has been sponsored by Pfizer. So the pneumococcus continues to be the leading cause of morbidity and mortality for persons of all ages. It is one of the 5 pathogens that account for nearly half of the infection-related deaths among children less than 5 years of age. Still now, the causative agent Streptococcus pneumoniae is found in nasopharynx of 30% of children in the high-income countries and as many as 80% of children in the low-income countries. So we are getting lots of pneumococcal cases, and there are recent outbreak overviews are there. All over the world we are getting recent outbreaks. There is increasing in the non-PCV13 serotypes, rise in penicillin resistance cases, higher hospitalization rate, increased severity among young children. And from all over the world we are getting different case studies and case series, and we are all very much concerned that we are getting more and more pneumococcal diseases. Even if a fully vaccinated patient, severe pneumococcal disease we are getting. So we are going few interesting cases. This case one, this 2-year-old female, 2-year 10 months old female presented with a fever for 4 days with cough, tachypnea for day 1, saturation was 85% in room air, chest X-ray revealed bilateral patchy opacities, focus revealed left-sided empyema. So you put a ICT on admission, streptokinase has been given, suspecting community acquired pneumonia. We have started with ceftriaxone or vancomycin. So you can see the this was before putting the chest vein. You can see loss of septations, empyema was there. Total count was eosinophilic leukocytosis was there. CRP was 332, sky high. From pleural fluid, basically empyema fluid from the pus, we got the Streptococcus pneumoniae positive. So on day 3, fever came down, X-ray improved, and TLC CRP coming down, so distress has been settled. So we thought, okay, we have managed this patient very well. But there was again new onset fever spike from day 4 to day 6, and we can see there is new onset opacity on the right side. Patient already on sensitive antibiotic, most probably sensitive antibiotics. There's new onset opacity, and focus again we are getting a empyema on the right side. We have got the empyema on the left side, we have treated it, it's improved, now the empyema on the right side. So again we have to put a chest drain on the right side, we have to put a streptokinase, and after that sometime this patient recovered. And surprisingly this patient got 4 doses of PCV13, and the culture revealed that it's a Streptococcus pneumoniae pan-sensitive. So the patient was fully vaccinated, patient on a pan-sensitive Streptococcus pneumoniae on both very good drug against Streptococcus, ceftriaxone and vancomycin. On antibiotics, still the patient developed right-sided empyema. This is a very unusual case that we got. So recent studies are going on that that possibly the incidence of empyema is increasing day by day. We are getting lots of increased pediatric hospitalizations in empyema in UK, in Australia, as well as in our cohort we are getting more empyema cases. Case 2, this 8-year-old girl appeared in the emergency with a complaint of high-grade fever for 3 days, respiratory distress. On examinations, GCS was 7/15, heart rate was tachycardic, tachypneic, blood pressure was very much low, central cyanosis, temperature was high. You can see how this patient was during on admission, usually tachypneic, given fluid boluses on NRBM. So ultimately, immediately this person has been intubated, ventilated, central line secured. You can see the bilateral patches, opacities were there. Ultimately, it developed refractory hypoxia. Patient has been prone on high frequency ventilations. Even at the highest possible high frequency ventilation, you can appreciate the saturation is only 79%. So you referred this patient for a ECMO center, but they are non-affording, so they did not afford ECMO. You can see the saturation of 71%, of hemodynamic stability has been achieved with the highest possible mechanical ventilations. And definitely the bronchial valve lavage reveals Streptococcus pneumoniae, and blood culture also reveals Streptococcus pneumoniae. You can see the blood gas just before putting the patient on HFOV. You can see the severity of the blood gas. So ultimately, this patient developed multi-organ dysfunctions. This patient developed refractory status epilepticus. This patient developed AKI, put on CRRT, chest X-ray wise a bit improvement was there. There was increased GI bleeding. There was a feed intolerance. Liver dysfunction was there. Coagulopathy was there. Patient was bleeding all over from the peak sides, giving FFP and cryoprecipitate. Patient developed suprarespiratory status epilepticus, commenced on barbiturate coma. MRI revealed multiple small acute ischemic lesions. Sensorium improved gradually, but he developed quadriparesis, ventilator dependent. There was diaphragmatic dysfunctions. NCB revealed critical care myoneuropathy. Ultimately, the patient was on 7 days of high frequency ventilations, tracheostomy, 25 days on conventional ventilations, and decannulated on day 33 on post tracheostomy. And this is the picture before discharge, and no PCB has been taken. So you can see the difference between first case and second case. The first case, though a bit complicated, but never intubated, survived smoothly, and this patient giving so much of travel. So definitely the implication of vaccination is there. The case 3, this 7-year-old kid presented with the rapid onset flaccid paralysis of both lower limbs, followed by right upper limb paralysis 24 hours. There was no URTI, LRTI symptoms on admissions, febrile. NCS was suggestive of GV syndrome, commenced on IVIG, initial blood report and chest X-ray was normal. Intubated within 24 hours of admissions due to progressive respiratory failure, bulbar palsy and unable to protect airways. But after 48 hours, you can see the patchy opacities has been started, the new onset fever is there. The CRP has increased, and from bronchial valve lavage, we got a Streptococcus pneumoniae. So this is basically a aspiration pneumonia. This is taken from the Fijian infectious disease. That pneumococcus can be there in the nasopharynx, and they aspirated GV syndrome and developed a pneumococcal pneumonia. After starting with ceftriaxone, the patient has improved. This patient also did not take any PCB. This case 4, this 17-month-old baby girl admitted with a history suggestive of a pneumonia. There's a pleural effusion was there, empyema was there. We have taken some fluids. Pleural spirit was exudative in nature. It was a Streptococcus pneumoniae. And then we got few things that hemoglobin was dropping, platelet counts were dropping, CRP was strikingly high, and peripheral blood smear you can get the cystocytes. So we got anemia, thrombocytopenia, cystocytes and uremia. It is nothing but a case of HUS. So this is a pneumococcal HUS, it's a very rare occurrence. So in pneumococcal HUS you cannot give plasma, you cannot do plasma pheresis. We just have to do a slate, 6 cytal slates has been there, and patient has been extubated on day 6 and discharged on day 12. This patient got a PCB10 government supply. So initial assessment for this patient presenting with again with a pneumonia. The focus shows multiple B lines, good cardiac contractility, chest X shows multiple bilateral opacities. Within couple of hours, the patient deteriorated, intubated, ventilated, whiteout lung, prone, HFOV, pneumothorax, chest drain. You can see everything has been done. Blood culture gives Streptococcus pneumonia, antibiotic changed to ceftriaxone and vancomycin. Initially started with meropenem and vancomycins. Finally has improved. He's on 5 days of HFOV, 3 days of proning, total 10 days of mechanical ventilations, completely bilateral whiteout lungs with air leak was there. This is a picture of the kid on proned on HFOV. So we also got few of the ARDS patients definitely was very much responsive to ARDS. Few of the patient was not responsive to HFOV, and we got this excellent machine that saved ultimately 20 to 25 lives from the almost dying, those who are not quite affording for a ECMO. So and this is the kit on discharge. So this patient got PCV vaccines as well. Last case is 4-year-old girl present with accident emergency complex for fever for 2 days and respiratory distress for 4 hours. This is only fever for 2 days, respiratory for 4 hours. They did not even consult any pediatricians, just fever for 2 days, just given oral paracetamol, just developed respiratory distress from 6 p.m. in the evening, and they landed in our emergency at 10 p.m. In the first hours, child was irritable, tachypneic, saturation was only 70% with NRBM, tachycardic, pulse volume was feeble with cold extremities, IVC was collapsed, functional echocardiogram, so poor cardiac contractility. You can see the blood gas, lactate is already elevated. The child intubated, ventilated immediately, there was physiological difficult airway, modified RSC was done, preload optimization of crystal light was given, adrenaline has been started from peripheral lines, safe taxon was started within 15 minutes of hospital admissions. On second hour, on mechanical ventilation, you can see almost right-sided whiteout lung. If it was 100, PEEP was 15, and BL sent for culture and respiratory biofire, vancomycin and doxycycline has been already given with subtractions. On circulation, perfusion was poor with delayed CRT, echo revealed very poor myocardial contractility, fractional shortening was only 14%, IVs was distensible, there was no urine output after hospital admissions. On 4th hour, there was torrential pulmonary bleeding, you can see the pulmonary bleed. Cardiac arrest was there, ROSC with 3 cycles of CPR, ABG further deteriorated with pH of 6.8, PO2 of 60, bicarb was 9, base deficit was 19, lactose was 8. We have counsel for ECMO, they are not affording, counsel for CRT to control the acidemia. Controversial whether to start IVIG, we are thinking we can start IVIG. But again, on the 6th hour, there are 2 more cardiac arrests and succumbed after 4 hours of PICU stay. And ultimately, BAL we have sent, we got a Streptococcus pneumoniae, and this is the blood report we got after the hospital patient died. So this patient presented with only 2 days history of fever, 4 hours of respiratory distress, came direct to us, everything has been done, but within 4 hours of hospitalization, this patient expired. So this patient did not get any PCV. So in our data, in most of the sick patients with pneumococcal disease that needed PICU care, most of them, around 80 to 85% of them did not get any vaccines. So the amount of 15%, those who are vaccinated even developed severe sickness. We got only 1 patient that was vaccinated with PCV 13, they got very severe and got admitted. All the other patients either vaccinated with the private PCV10 or government PCV10. But almost 85% of patients has not been vaccinated. Thank you. No, this is the most important thing, is that to identify the strain, but all over the India, nowhere strain identification is there. Only one microbiologist from South India, he was doing the strain identifications, but the ongoing study has been finished in 2024 December. So we cannot send it for a strain. So we got total 42 patients with a severe resistant pneumococcal disease, but we are not able to send the strain, and this serotype identification is paramount importance for this patient. Until and unless we can identify the serotype, it will not help in the future vaccine development. Exactly, whether non-vaccine strain or vaccine strain, definitely.
Also, majority of the strains, vaccine strains, if you look into it, for strain for serotype 3, the vaccine efficacy is only 50%. For serotype 4, the vaccine efficacy stands for about 65 to 70%. So it is not also, even if you are including that particular serotype in your vaccine, it gives you a complete coverage of like 85-90% coverage.
Yes.
So that's where the problem is.
But definitely, almost 85% of patients who came to the PICU with pneumococcal disease have not been vaccinated.
Thank you, sir. We'll continue with our partnership sessions. Our next session will be with airway mucus in pediatrics, approach for clinical resolve. It will be taken by Dr. Nandini Sinha, who is a consultant pediatrician with the West Bengal Health Service.
Thank you, sir.
Good afternoon, everybody. Thanks to the organizers for giving me this opportunity.
Now today I am going to discuss on airway mucus in pediatrics and approach to clinical resolution. Now where from this airway mucus come? It's secreted by the goblet cells, that is a part of the lungs' native immune system which traps the particulates and the microorganism, and the subsequent clearance is aided by the ciliary transport and the effective cough reflex. Okay. This picture shows. Now what happens if there is excessive mucus production? That can also be associated with certain other qualities of the mucus. Like if there is increase in the viscosity or elasticity, together with there is some defect in the mucociliary clearance, and if again the cough reflex is ineffective, this collects in the airways and that leads to infection, inflammation, airway obstruction and even parenchymal damage. Now this mechanism that I discussed, that is playing an important role in the few diseases like acute bronchiolitis, bronchiectasis and cystic fibrosis. Let's see how. We all know in bronchiolitis there is the viral lower respiratory infection in the bronchioles, that is the smaller airways, and what it leads to, there is difficulty breathing in the young children because of the obstruction in the small airways and the inflammation, swelling, necrosis of the airway lining, and together with the increased mucus production as well as plugging, and the young children carry on coughing. And we all know the viruses predisposed to this. Again, now coming to bronchiectasis, what happens? You can see there is deformation and persistent bronchial expansion. You can see the picture. This is a normal bronchus, and in bronchiectasis, what happens? And this leads to, there is damage of the smooth muscles, elastic tissue with chronic purulent inflammation, fibrosis, and the surrounding lung tissues, which leads to reduced mucociliary activities, reduced expectoration and viscous mucus. Finally, long-term accumulation and facilitated by the colonization of bacteria, recurrent cough and expectoration. I'm not going into details. These are the causes of non-cystic fibrosis bronchiectasis in children related to primary secondary immunodeficiency, primary ciliary dyskinesia, recurrent respiratory infection and recurrent aspiration because of various surgical reasons. Okay. Now, in cystic fibrosis, as we all know, there is a disorder with the CFTR and there is reduction of water secretion into the airway contributing to mucus hypersecretion. There is again persistent cough, expectoration, shortness of breath with airway mucus hypersecretion. These are few airway clearance techniques. This is huffing. That is, we blow into our hands or into the mirror. If we blow, it's like this kind of thing. It helps in expectoration. Then there is infant positive expiratory pressure. There is a device into which when the child breathes in the expiratory phase, a pressure is generated. Then there is a device called flutter. These are all physical measures that can be tried. Here we can see this child is blowing into a bottle through a tube. This is called bottle peep. And there are assisted autogenic drainage where in young infants or young children during expiration there is a pressure being provided from outside that helps in expectoration. Now the common pharmacotherapeutic options that we use: hypertonic saline, guaifenesin, ambroxol, acetylcysteine, Dornase alpha, thymosin beta 4, the glucocorticoids, macrolide antibiotics. They are called the mucoregulatory agent. They act as anti-inflammatory and inhibit mucus secretion. There are also agents called mucokinetics which increase the mucociliary clearance, even the surfactant. Now let's see how nebulized hypertonic saline can help. It predominantly decreases the viscoelasticity of the airway secretion to ease their clearance from the airway. It breaks the ionic bond within the mucus gel, increases the depth of airway surface liquid layer. The other modes are disrupting the structure of the mucus gel, stimulates the movement of the cilia, causing sputum induction, cough, which helps clear the sputum outside of the bronchus. And it absorbs water from the mucosa, submucosa, reducing the edema. This is how the disease process goes on, and this is how hypertonic saline can help. Now coming to few evidence. Studies have shown that addition of nebulized hypertonic saline significantly reduces VAP in premature infants. Nebulized hypertonic saline in RSV positive patients decreases the length of hospital stay. Now coming to cases of acute bronchiolitis, what evidence is shown? Compared to normal saline, infants who received 3% nebulized hypertonic saline showed better outcomes in terms of length of hospital stay, rate of hospitalization, clinical severity score improvement, respiratory distress assessment instrument enhancement, and no adverse events been related to it. Indian data also give similar results. In case of non-cystic fibrosis bronchiectasis, there is significantly higher mean improvement with hypertonic saline group as compared to the control group where we have salbutamol. In case of cystic fibrosis, hypertonic saline significantly reduces the lung clearance index compared to isotonic saline. So to summarize, cystic fibrosis, children with cystic fibrosis benefit from initiation of hypertonic saline inhalation if it started from the time of diagnosis. Acute bronchiolitis, inhale hypertonic saline reduces the rate of hospitalization and readmission. Inhale salbutamol followed by hypertonic saline may be considered in children with acute bronchiolitis. Inhaled N-acetylcysteine is not studied well in children, so we are not recommending and we are not regularly using it. In acute wheezing, hypertonic saline has been shown to give benefit if used with salbutamol, and it shortens the length of hospital stay in preschool wheezers as compared to normal saline nebulization only. In critically ill patients on mechanical ventilator support, it has reduced the incidence of VAP in premature infants. It has helped in sputum induction even in children who do not expectorate, and evidence on the efficacy and safety of inhaled hypertonic saline in adults has been shown in non-cystic fibrosis bronchiectasis. More studies are needed in case of children. So thank you. I think I have completed my presentation.
Sponsorship. Okay. I would like to invite our next speaker for the sponsored session, Dr. Pooja Chaudhary, who is a junior PICU consultant at Manipal Hospital, Mukundapur, and she is going to speak on HHFNC in pediatric emergency and ICU.
A very good afternoon. My name is Dr. Pooja Chaudhary, and I'm going to be speaking on HHFNC in pediatric emergency and ICU. At the very outset, I'd like to make a disclosure. This is a sponsored talk and is being given in partnership with Fisher & Paykel. I am assuming all of us are comfortable with HFNC, or at least familiar with HFNC, and we've all used HFNC in some way or the other in our ERs as well as in our ICUs. And through the scope of this talk, I'll just do a quick small revision on how HFNC works and helps us, and the latest model of the HFNC that is coming, which is Airvo 3, which has a certain new installments that will help us to apply HFNC better. So to first understand, we have to understand what exactly is a high flow system. We have to understand that anything that meets or exceeds the peak inspiratory demand is actually a high flow system. Although no set flow rate is designated as high flow, It is accepted, any flow rates more than 6 liter per minute in some texts is accepted as high flow. But in case of children, especially in children who have respiratory distress, they end up generating a lot of, the peak inspiratory demand is quite high, which is not met by normal conventional systems like an oxygen cannula and oxygen mask. So what happens is that if these children in respiratory distress who have a peak inspiratory demand, which is way in excess of what the low flow system is providing them, so if we put these children on a low flow system, the rest of the demand, whatever is not fulfilled by the oxygen cannula, the rest of the demand the child fulfills by entraining room air. So even in an oxygen cannula, you might have put the child on a good FiO2 or on a good flow rate that you're thinking 4 liters. In a mask, you've put the child on a 6 liter. But because it is not meeting the inspiratory demand of the child will end up entraining the room air, and the FiO2 delivered finally to the child will actually be quite less. That is why it is very important that we employ high flow systems like a nasal high flow system, especially in ERs and ICUs. So as I said, what is a nasal high flow? It's a form of non-invasive respiratory support which delivers a broad range of flow, 2 to 70 liters per minute. Earlier in Airvo 2, it was still 60 liters per minute, but in the newer machine that is coming now, in Airvo 3, that is expanded to 70 liters per minute, and it is given through an unsealed nasal interface. In normal low flow systems, in oxygen cannulas or in bubble humidifiers, those bubble humidifiers are incapable of humidifying the air at such high flow rates. So that is why these nasal high flow systems comes with a separate humidifier which humidify these air better at such high flow rates. So it heats and humidifies the air, and that mixture is provided at a very high flow rate through an unsealed nasal interface, and that is why we call it heated, humidified, high flow nasal cannula, HHH AFNC. So as I said earlier, the minimum flow rate that defines high flow is not precisely defined. Although flow rates of more than 4 to 6 liter per minute are considered high, but your demand, especially in children who have respiratory distress, are much higher than this. Now, oxygen, if we provide without humidifying, we all know it's a dry air, and it can cause irritation of mucous membranes, and it can impair your mucociliary clearance. And the bubble humidifier that we commonly use with the nasal cannula cannot provide adequate humidification for gas at high flows, so it's essential to heat and humidify the air first. Very shortly, how does the nasal high flow cannula work? So it approaches, you can see it in two ways. One is the effect of the high flow per se, what help does the high flow rate give us, and what help does the humidification give us. So if you look at the high flow part, if you are giving oxygen rate or at a very high flow rate, the major part it does is that it washes out the nasopharyngeal dead space. So when a child without any flow there, if the child is just respiring like that, when the child expires, your nasopharynx has very CO2 dense air. So when the child is rebreathing, so initially the child is taking in the CO2. So in this situation, if you put the high flow, because of that continuous flow, it is washing out your nasopharyngeal dead space. Your CO2 is coming down. So because of that reduction of dead space, combined with the fact that this high flow is also giving a positive air pressure. Please don't confuse it with a PEEP. It's not exactly a PEEP. It's only at the level of the nasopharyngeal thing, because the child is expiring, right? And at the same time, you have a continuous flow coming. So at the level of the nose, there is a certain kind of a back pressure that is generated that helps to increase the FRC. So it helps preventing the collapse. It helps increasing the expiratory time. So these are the two main mechanisms by which high flow helps us, by reduction of the nasopharyngeal dead space, as well as by providing a dynamic positive airway pressure. And of course, as I said earlier, it meets the increased flow demands in a child who has respiratory distress, preventing the entrainment of air. Of course, as I said, the second pronged mechanism is the effects of the heated and humidified air that is given. So since now the oxygen that we're giving is heated and humidified, so the mucociliary clearance is better, the child is more comfortable, and the child is able to tolerate it better. So in broad spectrum, if you can see, that is how a nasal high flow works. I'm not going through this, we have already said that. We are all using probably Airvo 1 or Airvo 2 in our ICUs. This is the latest that they have come up with. Fisher and Peckel has come up with Airvo 3. There are certain new features in this. primarily one most important is that it has an integrated battery. So it has an integrated battery which facilitates short transport. It takes a recharge time of 6 hours and will give you a mobility for around 40 minutes. Worst case scenario, 20 minutes, that's what the company literature says, but around 40 minutes. Also, an additional feature is that earlier when we used to disinfect a high flow, I don't know how many of you have seen the disinfection. There used to be a red tube, a disinfection kit that we connect to the high flow. So we have to wait, once a patient is done using a high flow, we have to wait till that entire, for at least 50 minutes. We use a thermal disinfection kit. A full turnover time of 50 minutes is there. In Airvo 3, the outlet elbow can be disconnected. In Airvo 2, earlier it was just fixed, you cannot disconnect it. In Airvo 3, you can disconnect the outlet elbow and then you can send it to your CSST. So the turnover time then becomes very rapid. So if you have a CSST done outlet elbow, a patient is done using it, you just remove this outlet elbow, put a new outlet elbow, and your machine is ready to use. This Airvo 3 comes with both options. You can use the old thermal disinfection kit as well as it comes with the facility of removing the outlet. The other good advantage of this is, this I have already gone through, since I'm running short of time, so I'll run through. The other big advantage of Airvo 3 is that it has 2 oxygen ports. Earlier we used to have just this, the lower oxygen port that we used to connect to a flow meter, and we had to manually do the oxygen flow, and we would not, and then the machine would then kind of estimate the FiO2 that was going on. But here, Airvo 3 comes with 2 oxygen ports. One is a high flow oxygen port. You can directly connect it to your wall mounted oxygen, and just on the display interface, you just put in what FiO2 you want, and the machine will ensure that it gets delivered. Also, the advantage of having 2 ports is that you can simultaneously use it. In that, if you want to transfer the patient, and your patient is on high pressure oxygen from the wall mount, you connect it to your oxygen cylinder with a low pressure mount, turn that on, turn it off, turn the wall mount off, and you can take it off. So it's a seamless transfer, and the patient is ready for transport for at least 40 minutes if your battery is fully charged. So those are your usual, and of course, since this is a new machine, you don't need any new consumables. All your consumables that were compatible with Airvo 1 and Airvo 2 are good to go with Airvo 3. Clinical indications, we all know, bronchiolitis, asthma, and pneumonia also has seen uses in extubation. And that is it for my session. I don't want to take any more time of yours. Thank you very much.
Thank you, Pooja. I would request Dr. Rajiv Sinha, who is HOD Pediatric Nephrology in ICH Kolkata, and sir is going to deliver a talk on optimizing a typical HUS care through early detection and prompt management.
I think now I'm audible. So I'd like to start with thanking the Society of Pediatric Intensive Care Kolkata for giving me this opportunity. And I will be speaking on in the next 10 minutes how we can optimize the HUS care of atypical variety with the help of like early detection and prompt management, and hopefully we will also sort of introduce you to something which I say the Sanjivani of life, or maybe Sanjivani of kidney, eculizumab. And we will be doing this with the help of a few cases, and all of these are true cases. Like this one came to the Apollo hospital a few months back, I think 1 month back, with a 4-year-old boy, oliguric, couple of transfusions before arrival, and the ER was hypertensive, and right at the start, I am not sure whether you can see it from that back, but there were bluish discoloration of his fingertips. And if you look at the blood parameters, low hemoglobin, low platelet, high creatinine, and lot of broken RBCs. Second child, slightly different, came to us at ICH and came to us almost 2 to 3 months after their initial presentation. He was like he already had diagnosed HUS and had couple of a few sessions of hemodialysis, almost 8 sessions of plasmapheresis, but was not responding quite well. So for the last couple of weeks before presenting to us, they had stopped everything and they were doing what normally family from here do, like window shopping. No, sorry, I didn't mean window shopping, I meant doctor shopping. Doctor shopping across India, and came to us very bad. Again, the same thing, low hemoglobin, low platelet, lot of fragmented RBCs and a high creatinine. And the third one was a known child with lupus, came to us in convulsion with deteriorating consciousness, intubated, ventilated, and again the same sort of a picture, but slightly different if you look at it closely. The platelet was too low, 16,000, and the creatinine not that high, 1.2. So the common thread is the presence of the microangiopathic hemolytic anemia. Hemoglobin less than 10. The Indian guideline says that the fragmented RBC should be more than 2%. Most of the international guidelines are happy with 1% and presence of LDH. So all these three child, they were having MAHA, they were having thrombocytopenia, and they were having AKI. So can I say that this child were having hemolytic uremic syndrome? Because after all, HUS mane ki hemolysis hobe or uremia hobe. So we were demonstrating hemolysis as well as uremia, but the answer is no, because HUS is a diagnosis of exclusion, and we have to exclude things like sepsis, DIC, some infection which can cause or mimic sorry, HUS sort of thing, and importantly we also have to exclude TTP. How we do that? We can go for the ADAM-TS13, which is quite difficult to get, but it can be get, like you can get it, and or you can based on something called the plasmic score. So in our 3 children, the first 2 we did not failed was the TTP, so we did not send it ADAM-TS, but in the third one we did send ADAM-TS13, and it was very low. So now that we know that we have excluded that all this, can we now start discussing the topic that was given, atypical HUS, because we are almost 4 minutes gone. Unfortunately still no. We cannot still brand it as an atypical HUS. We have to further exclude various things like stake induced HUS by looking at the SIGA toxin. It is done at ICH. Pneumococcal HUS, you can do the pneumococcal thing, or you can go for a DCT also. If the DCT positive, high suspicion of pneumococcal HUS from other infections, the cobalamin C deficiency HUS, which is very rare, and the secondary HUS. All of these conditions like BMT, solid organ transplant, postpartum, all of them can cause HUS. So all that excluded, and now we can see, we can say that yes, our child has having atypical HUS, and that is the list of investigations which can help you in coming to the diagnosis of atypical HUS. Once you have diagnosed atypical HUS, in India we usually send blood for complement activity like C3, CD46 flow cytometry, anti-factor H antibody, and in India, since we cannot really measure the factor H, factor, all this activity, we send genetics, looking at all those proteins which are involved in complement pathway. Unfortunately, speaking about the complement pathway, we have to go back to the school very quickly. If we remember that there are these 3 pathways, but ultimately what happens is that you have to have a C3b. C3b is an important molecule. It causes 2 things. One is that it helps in keeping this alternative mechanism tick, 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 tick going on. And the other thing is that it helps in the formation of the C5, like it activates C5. You get C5a and C5b. C5a is the anaphylatoxin, C5b is the ultimately results in the formation of the membrane attack complex, and it is the membrane attack complex which is the culprit, which cause lysis of the cell. Without understanding this, it is impossible for us to understand about the eculizumab as well as about the atypical HUS. Now, all of this activity, why? Because to help us protect from infection. Now, if this activity is more, then there will be damage to the body. If the activity is less, there will be infection. So, we need check and balances, and for check and balances we have got other proteins like factor B, factor H, factor I, and you can get antibody to factor H, factor I, which will be like deficiency of factor H or factor I. So, some of these proteins, if more, bad, if less also bad, because your life yin and yang is disturbed. So, hopefully keeping that in mind, let us see what happened to our child. So, as advised, we did send the blood for the factor H antibody and for genetics. Genetic takes 4 weeks, factor H antibody, if you are lucky, then it takes about 3 to 5 days. Should we wait till then? Well, no. Be it Indian guide, and this is a very important message, be it Indian guideline or international guideline, atypical HUS is an emergency. Treatment has to be started within 24 hours. Indian guideline is plasmapheresis, international guideline is eculizumab. If you don't have that, then plasmapheresis. So, we started on plasmapheresis, and this is what happened. The first child, this is the one with the slight discoloration of the fingertips. So, not much of an improvement, some improvement. The hemoglobin slightly better, platelets slightly better, cystocytes 2%, and this child had a very high antibody titer of 35,000. Second child, there was hardly any improvement. Third child, if you remember, this is the one with the ADAM TS13 was very low. So, we branded it as TTP, secondary to lupus, and was started on plasmapheresis. But for the first 2 child, there was not much of response, and none of them were having hematological remission. How do you treat the atypical HUS? Well, if it is antibody positive, idea is simple. You take away the antibody with the help of plasmapheresis, and you prevent further antibody formation with the help of steroid, immunosuppressant, rituximab, MMF, etc. On the other hand, if you are having antibody negative HUS, then it is usually eculizumab. If you are not having eculizumab, you can go for plasmapheresis followed by infusion, plasma infusion, but the outcome is poor. And going back to what is eculizumab, if you remember, with all this pathway, eculizumab blocks this C5 activation. C5 হবে না, membrane attack complex হবে না, membrane attack complex হবে না, then you are safe that your further damage is stopped. That is the work of the eculizumab. Eculizumab, as I said, is something new in India, and it is now available. Government hospitals are giving it free through this some scheme, provided you fit the criteria. Indications, this is one of the guidelines from Bagda group saying that children less than 5 years with obviously any of those protein mutations like complement factor H, B, all those mutation, family atypical HUS, and even in antibody mediated HUS, if you are not responding well, if they are limb threatening or organ threatening. This is a potent drug, so you have to remember that it causes a high incidence of encapsulated infection. So, antibiotics and vaccine is important. Summary, what happened to our child? The first child, third child is okay. TTP went on plasmapheresis and became weak. Okay. The first 2 child, first one, the one with a slightly discoloration of the peripheral fingertips, was not responding well. We continued on plasmapheresis. Because of the high antibody, we gave immunosuppressant. Still, this is what was happening. If you, I am sure you can look even from the back, the fingertips were getting worse. And in fact, we had counseled the family, we might have to amputate. And then we gave eculizumab, and this is what happened. You can see a remarkable improvement, and the fingertips were completely saved. And Kostov works in the right time because it was co-managed with Kostov. And what happened to our second child? Second child, if you remember, came to us almost couple of months, 2 months more delayed. I was worried what is happening, whether we are having any underlying CKD or not. So we did a biopsy. Biopsy showed there was no CKD. It was still a quite alive kidney, live kidney with a 10% IFTA. So we convinced the family to give eculizumab, and I think we were justified in the sense that the mutation came back as complement factor H mutation. And after that, with the eculizumab, you can see the remarkable drop in the creatinine, improvement in the urine output, and the child came off dialysis completely. So it was a good response. Summary slide for any of the trainees, if you can at least take this reference, which like all the MAHA and their differential diagnosis. So in conclusion, eculizumab is a powerful drug, and it is now available in India. But as they said, with great power comes great responsibility. So we have to use it carefully, under guidance, with the help from the various guidelines, etc. Thank you very much.
Thank you, sir.
So, eculizumab is about 80,000 plus 80,000, about 1,60,000 for the first course. And but in the government hospital, once you have established the diagnosis, it is the government is giving it, and cost
government is giving it free.
Yeah, yeah.
So another question.
And you also have to, but the problem at the moment, and they are trying to overcome is that government is giving it after you have confirmed the diagnosis of complement mediated HUS, which takes about 1 month. So the initiation has to be there, and I always say, answering you, that cost of a kidney transplant, dialysis is much more.
So one more question.
80,000 into 2. It's not like buy one get one free, or some such.
They are planning.
They often offer that, no?
They are planning to come up with some scheme, but at the moment I am not aware.
So we can use it both in factor age positive as well as negative, right? Because you said in negative only, but you used it in the first case.
Current guideline. So if you are abroad, then everyone gets eculizumab, even antibody positive. Indian guideline is for the refractory. So our case, first child was less than 5 years indicated, and secondly, it was not responding quite well.
Thank you, sir.
Thank you very much.
I would request Prabhash sir, Nandini ma'am, Pooja and Rajiv sir to please collect your mementos from the memento corner. Coming to our next session on immunology and novel therapies. To chair this session, I would like to invite Dr. Joydev Roy, who is the Principal and Professor of Pediatric in Institute of Child Health, Kolkata. And the speaker for this session is Dr. Jacob James, sir. And sir is going to speak on precision management in pediatric sepsis, biomarkers and therapies.
Change it. Change it.
Next session is on precision management in pediatric sepsis, from biomarker to personalized therapy, the next frontier in the critical care. And speaker is no other than Dr. Jacob James. I think for the intensivist, she does not need any introductions. She is now the chairperson of the Indian Academy of Pediatrics Intensive Care chapter, and he is also senior professor and head of the pediatric critical care and clinical lead facilities of PISU Christian Medical College, Vellore. And there is so many also in his favor. He is also in ICMR expert in the pediatrics. There is 44 indexes, national and international journal. He was the previous vice chancellor of IIP College intensive care chapter of the IIP college, there is so and so. And we all know the pediatric sepsis is, we came across day to day in our pediatric practice, and it present in a heterogeneous way, it present in the different way. But for the management, early diagnosis treatment is one of the important thing. Early diagnosis, the aggressive fluid therapy, all these things is one of the important thing. And for the early diagnosis, we use different biomarker. And from the sir, we will know what is the value of the previous biomarker, what are the new biomarker come, and how it will be used in the treatment of the pediatric sepsis. And with that, he will give us the idea about the precision of the medicine means what is the right therapy to the right child and to the right dose in the right time. I think sir will do all these things and we will learn a lots of things from him. Sir, please continue.
Thank you, sir, for the kind words, and I'm not sure whether I will be covering or fulfilling your expectations. Anyhow, good afternoon. I'm just in between your lunch and the talk, right? So, however, I bring greetings from Christian Medical College, Vellore, and on behalf of the IAP Intensive Care Chapter, I extend a warm greetings to you all for the Monsoon conference, and I thank Dr. Mehir and all the organizing team as well as the office bearers of this chapter branch and having such a wonderful academic event. So the topic given to me is about precision management in pediatric sepsis. As I say, no conflicts, but when I say it is more about immunology actually. But I am a clinician. I know what is happening at the bedside. So as I will be going through it, I will be giving an overview of what we need to know about precision management and now in the next decade what may go through. So as we know, sepsis is very important, right? 50 million cases per year, both adult and child, 14 million deaths happen, and 85% happens in a country like us with low middle income, and 40% is under 5 children. That is very important to know. And also you need to understand about 3 million children die under 5. This mortality data which is given here, it is westernized, and even they say septic shock in PICU is 13%. In our setup, it will be 30 to 50% they die. When they go to severe or refractory, or when they go to ECMO, or they are more. What is sepsis? There are a lot of evolution has happened. From 2005, the sepsis are the Stuart Goldstein's definition of SARS plus infection that you all know, and come to the present 2020, which said life-threatening organ dysfunction caused by a dysregulated host response due to infection. We know there is a trigger, infection, and the host response is very important, and they need to have an organ dysfunction. This is a couple of months back has come, the second edition of Pediatric Surviving Sepsis. They are also talking about that same organ dysfunction has to be there. Have you all heard about this Phoenix sepsis score, right? For organ 1, which has come about a couple of years ago, based on certain organs, that is respiratory, cardiovascular, coagulation, and neurological impact, or how much these organs are affected. And based on that, it has come as a Phoenix sepsis score. If it is more than 2, you may say the patient has a sepsis, and there should be a one component from the cardiovascular dysfunction or a score, and then it should be septic shock. But remember, this is not a screening tool. Phoenix sepsis score has to be employed after being suspected or you have confirmed or probable sepsis. You may put this score and say, yeah, this is sepsis, and prognostication as well. Screening, still the same, bedside clinical perfusion as you are learning in the PALS, all right? And this is the 2020 guidelines algorithm, and this is the new 2026 one, and it's not much change, it's more or less the similar one. I'm just putting it to you know that is all the update on the recent sepsis. Coming back to know what the word precision medicine, what does that mean? Nowadays there are a lot of fancy names comes, right? Personalized also we call. Then comes a precision. What does that mean? What's the difference? Personalized is, you may say, in fluids, you all talk about that. Probably today also you would have had a talk. In sepsis and septic shock, you say a group of people, fluid responders, responsiveness. They may then have a tolerance, where you may give fluid and see. They are personalized. You stand at the bedside and decide this patient requires. There is a group of clinical characteristics shared by these people. Precision medicine is little more. That goes underneath, not only what we see overtly, that is what we call phenotypically. This need to go down biologically or immunobiologically underneath. Then you customize the therapy for that group of or that individual. For that, we need the biomarkers, the omics and the immunoendotypics. When we say omics, that is another big fancy name comes into that. That is all study of the molecular biology. That is divided into many things, transcriptomics, metabolomics, proteomics, okay, so that and all comes in my talk as well. That is the branch of studying of certain things, right? But it's all at the molecular level. Coming to, I'll start with two cases. This is a 13-month-old infant who has come with fever. There is an injury. You can see there is a swelling. Patient is in shock. Purpuric rashes, that is mottling is there. Then patient is in hypotensive shock, typical sepsis. Infection induced, right? Evidence of shock is there. Cardiac dysfunction is found. High CRP and procal. Ferritin is not that high. Appropriately treated with antibiotics. Source reduction has been done. As we all know, that is very important. And patient survived. There is a next person come to our ICU, 7-year-old child, who came after 3 days of illness, treated with pneumonia to start with, from another hospital and come. And the child first blood culture has grown a CRO, and the patient is in 3-drug refractory septic shock. When we did, you can see the days of 1 week, when we doing all the inflammatory markers are very high, especially ferritin, CRP, and organ dysfunction. And we tried all maneuvers, and in this you can see this anakinra as well, will pulse methyl and all these extracorporeal therapies. But in spite of all that, the patient died. Are these children the same? They look overtly hypotensive shock and septic shock, but their underneath the immunobiology is different. One had a sepsis infection induced, but they manifested as cardiac function, or sometimes people may call septic cardiomyopathy. The another one as a hyperinflammation. You may call it as macrophage activation, but rheumatologists say, oh, it is reserved for only rheumatological conditions. Or okay, you can say secondary HLH, or the newer term cytokine storm. So this is we do see in our practice different phenotypes. So future of sepsis care is not only the first hour management, which is very important. I am not undermining. Recognizing at timely is important. The first hour management of fluids, antibiotics, vasoactives are important. But it is beyond that. What is that? Which child needs which therapy? That is what we call it as phenotypes. And then comes endotypes. That is knowing the biomarkers. That is a big challenge in our country at the moment. Okay, the chronology of sepsis classification, we have come from 2005 to 2022-26 about surviving sepsis campaign. They talk about lot of, syndromic, not the definition, Finnish sepsis score, how to recognize all that. But there is the similar time, work has been done to find out how to define or why the sepsis mortality is still high. How do I come down that? Then only this come phenotypically and endotypically, all work has been come on the way. So when you see that dynamic, now we are in, probably in the next decade is dynamic subtyping and real-time clinical decision making as a clinician at the bedside. Why this dynamic classification matters? See, this may be looking little complex, but it's all about this today's talk. Clinical dynamic classification means why there are in adults they have found 80% or 80 to 82% of the patients who present with sepsis, they change their subtypes within the first 48 to 72 hours seems. They may come like a hyperinflammatory, they may switch to a immunosuppression. So it is very important, still a lot of work is going on. So that is very, very important. That is, they call it as a fuzzy classification. That means they are fuzzy, they just change. Especially who are at the margins or more prone to change like this. So this is very important, which is dynamic, is going on. Sub-phenotypes is from 2024, Scott Weiss, who is a lot of work has been done. He has proposed based on these studies, there are many different subheadings and under that as well. I am not going into that. But you need to understand clinical phenotype is there. But that is not equal to biological endotypes. That is immunobiology, which is underneath, which requires to need about biomarkers, and what is to be need to know is transcriptomic studies. What is this omic? It is about molecules, smaller molecule levels, and especially mRNA, messenger RNA level. So that will be why this patient is behaving differently. All that is necessary for the therapeutic implication. For example, if you look at a shock dominant vasoplegic shock, the patient may present like hyperinflammatory biomarkers. What we have at the moment is ferritin, interleukin, CRP, proal, all that may be elevated in a patient like what I presented the second case. But in down, when we do the transcriptomic, there SRS1, MAS1, what we know has to be found. That will tell, yeah, this patient is going to be a high risk, and then later on they may become immunosuppressed as well. So these are the ways of integrating all these markers. So this is a good article written by Hector Wong in 2017 about in 50 years what is going to be the precision of intensive care medicine. For example, in the sepsis, it's okay. Right, so in the sepsis cohort, whatever that circles are patients, those who are having the similar color may have similar characteristic clinically or biomarkerly or immunobiologically. What is prognostic enrichment means? Prognostically selecting some group. They are high risk, they are low risk, they have a high mortality, they have a high chance of developing multi-organ. What is this? Then you have a high risk. For a low risk, probably you may give just standard treatment. Antibiotics, source reduction, all that is going on. For higher risk, you may have to find out, again predictive, means what sort of a therapy I need to give. So that is what is going to be in the next 10 years or more, the research will be. So based on all these findings or whatever the research happening, from 2015 onwards, but 2017 onwards, papers have come from Joe Carcillo in Pittsburgh's team, as well as this Scott Weiss team as well. So they have come with these 4 types of phenotypes, which is actually been there. So one is macrophage activation, the cytokine storm. Then the term of thrombocytopenia associated multi-organ failure. There the patient is having a thrombocytopenia, may be presenting with non-thrombocytopenia, developing thrombocytopenia, having features similar to thrombotic microangiopathy, where the ADAMTS13 deficiency is found. That lead on to the multi-organ failure. Then they have described something called sequential multi-organ failure, which they are saying develops like an ARDS, moving to a liver, and then again other organs. Then immune paralysis, you would have heard about this. Okay, so I am not explaining in full. These are the 4 phenotypes is well described. Now when we go, they put this again into a prospective multiple center study, the same Joseph Carcillo, and they found, again they are saying these 3 groups are well known. Term of thrombocytopenia associated multi-organ failure, immune paralysis, and sequential multi-organ failure. And they found CRP and ferritin to be higher in these groups compared to the other groups where they couldn't differentiate. In this group is Stamov as well as immune paralysis, hyperinflammatory, these CRP as well as ferritin. And in another study they found when these both are high, they are a high risk one and for mortalities as well. Still they are doing lot of work on this. They put all the features into a machine learning and come out with 4 groups as PCEP A, B, C, D. A has low risk, they are less inflammatory. A has respiratory and neurologic. C has some moderate amount of inflammation, and the 4th one of the D is hyperinflammatory, which we may say as cytokine storm. And you can see they put it in their ICU patient, and they found there is a difference in the mortality, especially from the A to D. There is 17% or 17-fold increase in the mortality. So you may understand the significance of this phenotypic as well as endotypic differentiation. This is done by our Juma Shankar in AIMS. They also found, they are trying to, but this is more clinically only, differentiating term of, and found yes, they could do that. Coming back to these clinical phenotypes, are they enough? No. So, is it 20 minutes or 5 minutes? Okay. So the clinical phenotypes we discussed now, right? So especially the 4 groups which I told, are they enough? Biomarkers are important. When we say biomarkers, it's not a single at the moment. It is like a panel, or at the moment what we have is, I told you, CRP, ferritin, and it's a combination probably. They are the bridge to what we see, that is the clinical appearance, to the biological reality. Ideal biomarkers, you all know we need to, but still we try to find, right? And the key biomarkers as of now we have is CRP, procal, ferritin, lactate. All this we do and we manage accordingly. This is what at the bedside we are able to do it, correct? And we know at what level they go up, PCRP, procalcitonin, all that. We try to keep it as for a trend and antibiotic de-escalation, all that we do. These are the inflammatory markers we have now, and we know the sensitivity and specificity. Nothing, no single is a highly ideal biomarker. We use it in combination with the contextual patient. We try to do that. But now they are coming out called something called persevere markers, that is pediatric sepsis risk, biomarker risk model. The lot of work has been done by this man Hector Wong, Dr. Hector Wong from Cincinnati. Unfortunately, he passed away in 2022. He and his team has done a lot of work on these persevere markers and endothelial markers. Persevere markers is immune biological. Endothelial markers, which are from the blood vessels and lymphatics as well as in the heart. These are the red ones, are very, very important. They integrated this immune marker, biological, that is the persevere markers, as well as the endothelial markers, and combined with a model. And they found they could discriminate the death or day 7 mods, and the area under the curve is 0.93. It's quite good. If it comes into that, this integration of this immunological markers as well as, these are the endotypes which they have put it in all that, right? And immune biological as well as the endotypes. Endotype may say, which is all the endothelial markers, right? Which is lining the lymphatics, blood vessels and from the heart. This has been replicated in Pakistan by Sidra Azak, and they could find out this persevere has a 0.83 area under the curve. How does this, we talked about phenotype, yes, there are differences, but we need to know biomarkers as well to integrate to find out which is prognostic as well as predictive, which type of therapy has to be there. But little bit in the next 2 minutes I'll try to say why all this happens. You need to understand there will be lot of immune dysregulation. That's what India said, I am not an immunologist. Lot of immune dysregulation. This is from the physiology book, if you read, stage 1 to this, very important thing to know. When there is an infection or an inflammation happens, local response, then if it is not controlled by pro and the anti-inflammatory, they spill over then comes SIRS, and if you see the anti-inflammatory is more, there will be compensatory anti-inflammatory response syndrome. If it is both or nothing happening, then they go to immune paralysis. This has been described long ago. So this is what is the basis for all this differentiation. You can know that increase in the damage associated molecular pattern or the pathogen damp and PAMS we say, right? So when they go and insult or that has an impact, there will be divided, we can say the common 4 mechanisms happen. There will be a change in the innate and adaptive immune response, mitochondrial dysfunction, endothelial and epithelial. When we talk about innate and immune adaptive, this is the reason for immune paralysis as well as for hyperinflammation. When there is interleukin 10, 1 and 6, they overspill, that will go into a hyperinflammatory cytokine storm. When we see there is the HLA-DR expression is more, that will cause immunosuppression. That's what each patient, they go differently. That's very important to know about this. The next, what is the treatment? There are different treatments, you know that. I am having only 19 seconds, so I am not going into that. Immune paralysis, you may use interferon gamma or there's GCSF in some conditions you may try. There is, I am saying no clinical trials have been proved. This is all at the physiological and pathophysiological level. When there is hyperinflammatory, you may say giving, just 1 minute or 2 minutes, I'll just finish it. When there is hyperinflammatory, we have been trying, right? What are we trying? What we do? This is the pathophysiology, I am not going into that. We do give pulse methylpred, we do IV immunoglobulin, now the interleukin 1 blocker, anakinra is coming, all these hyperinflammatory. It can happen in sepsis or any virus. Dengue also we talked, right? Severe dengue, they just go into a hyperinflammatory. And some of the extracorporeal like plasma exchange, high flow CVVHF, all that may be helpful for the hyper. That if we know specifically, this patient may be helpful. Then the second mechanism at the mitochondrial level, there will be a lot of apoptosis happens, and as of now what we know, the vitamin C may be helpful. That's what a lot of clinical trials are going on to find out high dose vitamin C, is it good in sepsis? But that is the basis is because of that. The third mechanisms of this organ failure is endothelial dysfunction, which has mainly the microcirculation. There will be impaired microcirculation, that we know, even in sepsis, we have talked about that. Ischemia, reperfusion injury, and the TMA, thrombotic micro, which is the culprit for TAMOF, or thrombocytopenia associated multi-organ failure. So I'll just say, so this is one important thing which Dr. Rajesh Sinha talked about HUS, where there is Adam TS13 deficiency. It's similar to that mechanism. There is thrombotic microangiopathy leading on to microorgan failure. Why? What is this Adam TS13 deficiency? It's a cleavaging enzyme which cleaves the big polymer of von Willebrand factor into smaller monomers. If there is no Adam TS13 or insufficient, the von Willebrand factor will be big, or as a big polymer. All this, platelets will come and aggregate and form microthrombi, which is the basis for organ failure. That is what is very important to identify, at least at the end of my talk. There is an entity called thrombocytopenia associated multi-organ failure. The treatment again here similar to what is that is the plasma exchange. I'll move on to the next, and epithelial dysfunction. This is still under research. I am not going into the detail of this.
Thank you, sir, for your nice presentation. In his presentation, what is through us?
No,
It is finished. You are finishing.
No, I just don't.
Oh. I think he has aimed it.
No, that's okay. That's okay. I am going more time probably. So we know immunoglobulins we give steroids. What we do at the moment is, in a desperate condition, patient is in refractory, we give all that. But that is not the answer I am going to say. That is, may take a decade for us to come to the biomarkers to find out which patient will respond to immunoglobulin, which patient will respond to steroid. As of now, we know toxic shock syndromes, we give IVIG. Like that, specifically also, we may be able to find out. Then extracorporeal, that has a value, definitely, because as you see, the cytokines, low molecular weight cytokines are removed by the conventional hemofiltration. Higher molecules are removed by the plasma exchange. So there is a definite role of these extracorporeal therapies like CRRT and TPE, but we need to find out which patient. That is the challenge which we do have. I'll just skip these all the things, research and all. I'll come to the finally. What to take home? I talked about, yes, in sepsis, not every one size doesn't fit all. Sepsis has a lot of clinical, or at least 4 phenotypically. When we see, there are 2. When I said hyperinflammatory, as a cytokine storm. Immunosuppression, where you will see the patient's counts below goal neutropenic, was a premorbidly well child, right? So they are the immunoparalyzing type. The third is like sequential multi-organ, that we may not see much, but they are saying in the North American paper that entity is there. They are saying it starts with respiratory, like a severe ARDS, move on to liver and the severe shock. So all these phenotypes exist. So what I want to end with is sepsis is not one, it's a heterogeneous disease. Biomarkers are helpful, but alone are insufficient. So we have to integrate these phenotypes with immune and endothelial biomarkers, and future research is very important. These 4 phenotypes we do see. So it is not only theoretical, or this is a study done from North America. In our country also we can see these type of differences. Biomarkers, certain things are only available to us, which we have to use it cautiously and to interpret with the clinical context. Adjunct therapy like this are useful, but not routine. Not routine, but we need to find out which patient may be helpful. What do the surviving sepsis talk about? But at least they mention about this. They say for everything, insufficient data, insufficient evidence. So they don't recommend, but they are come out with all this. Yes, because in the next decade is for the precision medicine in sepsis. So I'll just stop with this. These are some of the cases which I had, these 4 types of, different types of organ phenotypes. So what I try to say is, these phenotypes we do see. We have to stand near the patient and see clinical with the biomarkers which we are available, like ferritin, as well as CRP, as well as procalcitonin, and some of the centers may do interleukin. What we have, then interpret with the clinical phenotypes and come out with the individualized therapy. That is going to happen in the next decade. Thank you very much.
Thank you, sir, for interrupting you. And he has given so advanced in case of pediatric infection in our day-to-day practice. Generally, the basic thing he was stating, he was giving the advanced thing, all this thing. Specifically, he has given, along with routine treatment, we have to focus on phenotype and genotype. In the phenotype, he has given 3 things, main 3 things. One is he has given, there is a immunopheresis, the multi-organ failure. Later on, he gave thrombocytopenia with multi-organ failure. After that, he has told sequential multi-organ failure. He has given trace on these 3 things. Later on, when he talked about the biomarker, one thing he has given importance. It is not the single biomarker, it is the battery of the biomarker. Along with, you have to dose to the phenotype, and after that, the endotype has to be added. Accordingly, the treatment pattern has to be given. In the treatment pattern, he has told you, if there is a immunoparalysis, the treatment is one varieties. If there is a hyperactivity is there is immunological hyperactivity there, the treatment will be different. And after that, he also given the when it will help in the extracorporeal treatment, and also he give the idea about the adjuvant therapy. So sepsis is a heterogeneous manifestation. It is biologically, immunologically, and it has to be precision treatment. You have to mean it is not the personal You have to give the more text on the phenotype and endotype itself. I think what I understand from your talk, I want to say this thing.
Fine, fantastically summarized. Thank you, sir.
Any questions from the audience? Anybody? Any questions from the audience?
I've got hello, just one comment that the chairperson is saying that the extracorporeal therapy is still there in sepsis. The chairperson of the society.
Thank you, sir. We will now proceed to the inauguration, and lunch is also open, but I think that information has already been transmitted. A very good afternoon, and I take this opportunity to welcome you all to the inauguration ceremony of the Monsoon Conference of Pediatric Intensive Care 2026. At the very outset, I'd like to request Dr. Iber Jacob, who is the chairperson of the IAP Pediatric Intensive Care chapter and also the chief guest for this conference today, to kindly take his place on the dais. I'd like to call upon Dr. Tridi Banerjee, who is the chief patron of Society of Pediatric Intensive Care Kolkata. Dr. Shubhashish Bhattacharya, who is the president-elect of West Bengal Academy of Pediatrics. Dr. Mili Sharkar, who is the chairperson of Society of Pediatric Intensive Care Kolkata and also secretary of the West Bengal Academy of Pediatrics. Dr. Abhishek Poddar, who is the secretary of Society of Pediatric Intensive Care Kolkata. And last but definitely not the least, Dr. Prabhas Prashan Giri, who is the organizing secretary of the Monsoon Conference of Pediatric Intensive Care 2026. I now request Dr. Nandini Shina Roy to kindly felicitate Dr. Iber Jacob, sir. Dr. Manideepa Datta will be felicitating Dr. Tridi Banerjee, sir. Dr. Madina will be felicitating Dr. Subhashish Bhattacharya. Dr. Nandini Shina Roy will be felicitating Dr. Mili Sharkar. I request Dr. Manideepa Datta to kindly felicitate Dr. Abhishek Poddar. And I request Dr. Madina to kindly felicitate Dr. Prabhas Prashan Giri. We will now proceed with lamp lighting. The tunes of Saraswati Vandana. We will be doing the lamp lighting with flowers and floating candles.
या ब्रह्माच्युत शङ्कर प्रभृतिभिर्देवैः सदा वन्दिता सा मां पातु सरस्वती सरस्वती भगवती
I now would like to request Dr. Mihi Sharkar, who is the organizing chairperson for the Monsoon Conference of Pediatric Intensive Care 2026, to kindly deliver the welcome address.
Very good afternoon to all. It is my proud privilege to stand here and welcome you all for this Monsoon Conference of the Pediatric Critical Care organized by the Society of Pediatric Intensive Care Kolkata. So we have the chairperson of the IAP Intensive Care Chapter, Professor Dr. Ibor Jacob. We have Dr. Tridip Banerjee, who is the main drive and the chief patron of our chapter. We have our Professor Dr. Subhashish Bhattacharya, who is the president-elect of West Bengal Academy of Pediatrics, my good friend Abhishek, and my beloved junior Provas, who is the organizing secretary. And all my teachers, the respected seniors, and all my colleagues, the respected faculties, all the past presidents from the chapter who have helped us to grow the chapter starting from 2023 to 2026. We have grown like our National Intensive Care chapter has grown, so the West Bengal chapter has also been come up. So this is the 9th version of our state, and sometimes we have do the East Zone, but we have a big dream now. So for 2027 in October, we probably, this is the most probable day, so we are going to organize the next Pedicriticon. This is the national conference of the IAP Intensive Care chapter. So we need all your support, all your blessings, all your involvement and bonding to make it a successful one. Thank you.
Thank you, sir. I'd now like to call upon Dr. Abhishek Poddar, who is the Secretary of Society of Pediatric Intensive Care, Kolkata.
I would take this opportunity to invite, as Dr. Mehir has already said, to invite everyone to the Pedicriticon 2027, and I think we'll have a very short video for that. So I'll be with the time it takes to keep the video on. So what I would say is that Pedicriticon 2027 is a very prestigious event for all of us in the West Bengal Pediatric Critical Care Group, because this is the first time we are going to organize an event of this stature, and I invite everyone to be a big participant for all of that. Your blessings, your support, your involvement, everything is warranted. So, is it ready?
Every day, across hospitals, emergency rooms, and intensive care units, lives are changed in moments. Moments that demand knowledge, moments that demand teamwork, moments that demand extraordinary care. In pediatric critical care, every decision matters, every second matters, and every advancement has the power to transform a child's future. This October, leading minds in pediatric intensive care come together to share experience, to challenge ideas, to explore innovation, and to shape the future of critical care. 4 days, thousands of conversations, hundreds of experts, one platform dedicated to advancing pediatric critical care. Join colleagues, innovators, educators, and leaders. Experience learning beyond the classroom. Experience collaboration beyond institutions. Experience Kolkata. Pedicriticon 2027. 14th, 17th October 2027. Kolkata, India.
Thank you. We all shall be there to welcome you all.
Thank you, sir. I'd now like to request Dr. Ibo Jacob, who is the chief guest for today, to kindly say a few words.
Good afternoon, everyone. Again, I'm coming to you. And respected dignitaries and teachers on the dais and off the dais, the delegates, and my friends. So it is my pleasure to be here in this Monsoon conference of Pedicriticon of the West Bengal chapter. And I bring greetings from the IAP Intensive Care chapter as well as from CMC Vellore. First of all, I congratulate all the organizing team, Ms. Premi here and their team, for organizing such a conference every year consecutively. Now, how many years? 9 years. 9th year. So that's a big challenge, right? Organizing conference is not that easy, right? Giving an academic, not only that, lot of expenses, financial burden. So it's been conducting regularly is a really a big thing, and I really congratulate everyone and give a big hand for the organizing team. This is a prelude for your next 2027, as everyone is expecting the big event. So it has been growing over the years. So I think this is 28th Pedicriticon, and next year will be 29, right? As I'm correct, yeah. So this pediatric critical care chapter, or what we call IAP intensive care chapter, has been growing over the years with more than 3,000 members. Not only that, we are an academically strong chapter, and initially we had a college. Now we merged with IAP Intensive, that means Indian College of Pediatrics, but still we conduct a lot of the fellowship courses. So the entrance exam is conducted by them, but the curriculum and the exit exam is by the intensive care chapter. So we do have about 60 centers and about 100 fellows come out every year, which is now we call Indian Fellowship in Pediatric Critical Care Medicine. Not only that, so we are pioneers in that, because in that time there was no DRNB or no DM Pediatric Critical Care to start with. So the pioneers of this land who trained in pediatric critical care overseas and brought here, since over the years we have seen a tremendous improvement or tremendous growth, I would say. Pediatric critical care. Is it necessary? Of course, right? In COVID times, probably even the government of the national government and state governments, they have found it's the importance of critical care, how it can change lives, right? Even for our infant mortality or under-5 mortality, we have been improving over the years. There is no challenge for that. Yes, there are improvements, but still we have to go a long way. For that, pediatric critical care has to have a real impact on that. For that, we from IAP Intensive Care Chapter also contributing, especially with the Ministry of Health. We have coming out with a manual for all. It is not only from the chapter, it is maybe individually. Now all the members from the chapters are only in the task force, coming out with a manual for district hospitals to have improving with the protocol-based pediatric critical care. That hopefully this year sometime they will roll out from the Ministry of Family Welfare and Health. So, and another important thing is not only this, strengthening the healthcare system, training the healthcare professional is very important. That's what this sort of conferences and workshops are important, right? So you have 200 odd delegates, and I heard from Dr. Mihir that workshops were fully packed. So all the postgraduate general pediatricians being trained in ventilation, not only the doctors, nurses. So they are the backbone, right? So there are two when you are having pediatric critical care nursing. So that's all very important to strengthen the healthcare team at the district as well as the rural level as well, so that our country's under 5 and infant mortality rate can come down. So with these words, I'll just stop talking because we have to go for the lunch, and I wish all the best for this conference, on not only then 2027 Pedicriticon from all of the IAP intensive care community of this country. Thank you very much.
Thank you, sir. I'd now like to request Dr. Tridip Banerjee to kindly address the gathering.
Good afternoon, Dr. Eber, other dignitaries on the dais, and even greater dignitaries sitting on the floor like Shopnadi and other didis. Splendid performance, Mihir and your team. Congratulations, but you have got a big challenge ahead next year. I wish that all of us, very old people like me, not so old Joydev Rai, and other young people will actively participate and support. Our success is guaranteed because we'll have the wholehearted support from the Union Health Minister Naddaji, our Honorable CM Shubhendu, our Health Minister who is a successful practicing doctor. So all of us will get support from all the necessary quarters, and Shomen would be of particular importance because the Health Minister is Shomen's batchmate. So he can pull the strings, so can I. And I'll certainly pull the strings from the Union Health Ministry Naddaji, who belongs to my city, Patna, and all his family members are my batchmates, etc. And CM is very keen to see West Bengal being successful in all areas. So success is guaranteed. All of us have to forget all the differences and fight, particularly the younger ones and very old ones like us. Shopnath, you are not that old. Thank you very much. All the best.
Thank you so much, sir. I'd now like to call upon Dr. Shubhashish Bhattacharya, who's the President-elect of West Bengal Academy of Pediatrics, to kindly say a few words.
Respected dignitaries on the dais and off the dais, my IAP colleagues and my juniors and seniors, I think I am privileged that I was invited in this program, and I am also attending this Monsoon conference for last 3-4 years. So it is excellent because the organizing team which is so much dedicated, academic and energetic, they are organizing this thing, and I wish in next year in 2027 National Critical Conference on Pediatrics will be highly successful in our city, Kolkata, and thank you all. Thank you for coming in this program, and I also wish grand success of this today's Monsoon conference of the Pediatric Critical Care. Thank you.
Thank you, sir. I now call upon Dr. Prabhas Prasungiri, who is the organizing secretary, to kindly deliver the vote of thanks.
Good afternoon. So it is my honor and privilege to deliver the vote of thanks to my respected chairpersons, the faculties and respected patrons, the dignitaries, other friends, colleagues and juniors. So I want to express my heartfelt thanks to all the speakers, all the moderators of the sessions who have made the conference successful till now. The 9th year is going, and the next challenge is that to take the opportunity to organize the Pedicriticon 2027 in the next year. So I think all the speakers, all the moderators, they have enriched us, all of us with their extreme knowledge, will significantly pour the knowledge in the next conference as well. I want to express my sincere thanks to the whole organizing committee. All of you have worked very hard to make it success. So I think we need a big and robust organizing committee for the next year too, because the big challenge is ahead. I also want to express my sincere thanks and gratitude to all the sponsorship partners and industry partners, those who are supporting us for the last many years, and we are expecting a big support in a great way. It's almost 16 months it's pending, so we are expecting a big support from all the industry partners. And lastly, I should mention that delegates, those who are coming, they were traveling all the corners of the state as well as all the corners of the country to attend this program and delivering their academic activities through different posters presentations and oral presentations. A good conference cannot stand without good delegates. Lastly, I want to express my thanks to our event organizer, Rosni Enterprise and Rohit and Somnadda and their team. They are working very hard day and night for making this conference successful. So let us concentrate on the next big event on Pediatrician 2027. Thank you. Thank you all.
Thank you, sir. That brings us to the end of this inauguration ceremony. I've been told that Professor Dr. Kalpana Datta ma'am would like to make a few announcements.
Yes, sir. Good afternoon, everyone. This is all intensivist people, intensive-minded people. So without nutrition, the mortality and morbidity will increase and the predicted outcome will be poor. So nutrition very important for us, everyone, every corner. So we are going to arrange one national conference, first time in Kolkata in West Bengal, the paid Nutricon, and the fourth time I think, sir. And sir? Yeah, you are the patron, you are always our patron and advisor. So it will be on the 18th as a workshop on IY shape, preterm nutrition and lactational management. There will be hands-on training, how to express based milk, how to collect, how to preserve milk banking and all. And then conference will be 1.5 days, whole day Saturday and half day of the Sunday. So I request all of you please, yes sir. So all of you please join the Nutricon first and make it grand success. And as an organizing chairperson, please help me for the organizing of the conference also. Thank you for giving me the opportunity.
Thank you to all our dignitaries. We'll now continue with our scientific sessions. The next session is again a partnership session. It will be delivered by Professor and PISO in charge at AIMS Kalyani. He'll be speaking on optimizing respiratory care through vibrating mesh nebulization during non-invasive ventilation.
এটা নিচেরটা একটু সরিয়ে দিলে ভালো হতো।
এটা আমি টেপ মেরে দিচ্ছি, আপনি খাবেন?
রাখবো?
রাখুন। ভাই এখানে দেখাবো। ফটো তুলবে, ওকে দিয়ে দেবেন। আচ্ছা।
আমি তোমাকে দিয়েছি, রিজেক্ট করো না। সময় কমপ্লেন আছে, ওকে আমি রিটার্ন গিফট দিলাম বলকে।
বেশি দিচ্ছি না।
না না, এই তো
অল্পই দিই।
হ্যাঁ, একটু দেখে নিন। এটা মনে হয় চেঞ্জ হবে না। না, এটা তো চেঞ্জ হবে।
ওটা চেঞ্জ হবে না, ওটা শুধু আপনার ইয়ে হবে। ঠিক আছে,
ঠিক আছে, এটা দিন।
আপনি কি এখন চেক করবেন?
না, বলে দিই।
আপনি বলুন। ঠিক আছে, আর করবেন। আর করবেন না।
Okay. Good afternoon, everyone. Thank you, the organizer, for giving me the opportunity. This is a sponsored talk on optimizing respiratory care through vibrating mesh nebulization. As it is post-lunch session, so the audience a little bit less. Anyway, we'll start. So first, we'll start with a case scenario. This is a 10-year-old boy presented with noisy breathing and breathing difficulty for last 2 days, and we have seen there is extensive wheeze on auscultation and there is persistent similar illness. Most likely the patient is suffering from acute exacerbation of asthma. Child has come to ER with heart rate of 166 and tachypnea and hypoxemia. So which device will you choose for delivering short acting beta agonist? Some of them might start with continuous jet nebulizer, few of them they start with MDI. So we'll see which one to choose from. So in the next 5-8 minutes, we'll discuss about aerosol therapy in pediatrics, particularly in pediatric critical care patients, and what are the peculiarities of aerosol delivery. What is the mechanism of deposition of aerosol in the airway, and different aerosol delivery devices, their advantages, disadvantages, when to use what device in respiratory distress, few of the guidelines and take home message. So the aerosol is nothing but suspension of liquid particle which is generated by aerosol producing devices. So if you see in the diagram, if the particle size is more than 10 micron, usually they are getting deposited into the nostril, oropharynx and nasopharynx. They are not getting deposited lower down. Whereas if the particle size is between 5 to 10 microns, they can reach the larger airways up to the first 6 generations. Whereas the ideal particle size should be 1 to 5 microns, where they can reach the lung parenchyma up to the last 6 generations. So that we have to always think of. Next, what are the mechanism of depositions? So there are 3 mechanisms. First you can see the inertial impaction. So the inertial impaction means these are all bigger particles which are more than 5 micron diameter. They are just getting deposited into the bigger airway walls. So think of it like the bigger car which is going in a very high speed, and they are getting collided with another car and they are getting destroyed into smaller particles. So this is inertial impaction. So this actually doesn't have much of medicinal benefit. This is mostly useful for bigger particles to break into smaller particles, and these are the mechanisms where the drug will deposit in the upper airway, oral mucosa, and they cause lot of side effects. Next, the very important mechanism is known as gravitational sedimentation, which is most likely to occur if the particle size is 2 to 6 microns. So now the important thing what you have to remember is this sedimentation is the most important factor for drug delivery during asthma. And in asthma, you know, we will give MDI with spacer. So when the patient is on spacer therapy, the patient is not actively breathing. We will tell them to hold the breath. When the patient is holding the breath, that time this gravitational sedimentation will take place and the drug will deposit and they will produce its pharmacologic effects like bronchodilatory effects. Third but not the last one is the Brownian diffusion. So Brownian diffusion usually occurs when the particle size is very less than 2 microns, where they are getting deposited in the very distal airway. Here also they doesn't have much of pharmacologic role. Sometimes these are the smaller particles, they are getting exhaled when the patient is exhaling. So these are the 3 different mechanisms of deposition. So now we will go to the different aerosol delivery devices. I am just discussing two important devices. One is the nebulizer and the pressurized MDI. So now nebulizers, as you all know, there are three types. One is jet nebulizer, second one is ultrasonic, and third one is the mesh nebulizer or vibrating mesh nebulizer. So first we will discuss jet nebulizer. Jet nebulizer, they will use a compressed gas source, that can be a compressor, or it can be the pressurized oxygen which is there in all our ICUs, and they will produce particle size, but the particle size are usually a little bit smaller size because the pressurized air is going past by a capillary tubes, okay, and usually the continuous aerosol generation is the norm because continuously the gas or pressurized oxygen is getting supplied. Because there is continuous aerosol productions, so when the child is not actively inspiring, also the aerosols are getting deposited. So that's why many of the aerosols are getting wasted. So maybe during expiration or when the child is not breathing, that time also the aerosols are getting wasted. And only 10 to 20% of aerosols are only getting deposited into the airways. So jet nebulizer is the most commonly used one. Any patient who has come to ICU and ER will use the jet nebulizers. So we have to remember that many a times the drug delivery is not optimum with jet nebulizers, but as it is cheap, so we are using it very commonly. Next very important thing is the ultrasonic nebulizer, where there is a piezoelectric crystal that generate high frequency vibrations. And the third and most important is the mesh nebulizer, where you have a mesh or aperture plate which will vibrate with some piezo ceramic elements, and the vibration rate is very high, 130 kilohertz, and this vibration will act like an electric pump and they will produce exceptionally fine aerosol. The target aerosol for our medical purpose, pharmacological effect purpose, 1 to 5 microns. So they will get delivered into the peripheral lung tissue. So these are the different things. So now a little bit about MDI. MDI has this canister propellants and the drugs. So all of them, they will get delivered. So now what is the recommendations? If the patient is less than 3 years, the coordination is not good. There you have to use spacer with MDI and mask. 3 to 5 years MDI with spacer, above 5 years MDI with spacer is the first line. But we have to remember, when the patient is very sick, in those situations MDI cannot be used because it can have lot of coordination issue. But if it is used or patient is cooperating, the studies have shown that MDI drug deposition is as good as nebulizer also, and sometimes it is better than the nebulizers. And sometimes in pediatric patients, drug delivery is very difficult because they have smaller airway, fast breathing, tidal volume is less, and particularly when they are crying, whenever we will start to give jet nebulizer, they are crying. During crying, the drug delivery come down to as low as less than 1%. So that has to be remembered. So now we have seen few literature review. Here they have shown the pediatric aerosol device, and they have shown that the pediatric aerosol device in non-invasive ventilation has to be connected if the patient is in single limb circuit. Suppose you are delivering non-invasive ventilation by single limb circuit, that is not commonly used in pediatric practice, but if you are using that, then the mask has to be there, or the pressurized mesh has to be there in between the leak and the mask. So as close to the mask as possible, the device has to be adjusted so that the drug delivery is optimum. If you are using the or two limb circuit, then it has to be there in between the interface and the expiratory cassette. So that is important. It has to be always in the inspiratory limb and in between the exhalation, in between the this leak and the interface. So that is important. So there, this between the Y piece and the this leak. And this is the adult article where they have shown that aerosol delivery by non-invasive ventilation, there they have shown the vibrating mesh nebulizer has to be delivered between the exhalation valve and the interface, and the non-vented mask should be used even if it single or dual limb. And the recommendation is not to turn off the humidifier. Previously there was a concept the humidifier has to be turned off, but now in the adult literature they are telling no need to turn off the humidifier, it can be continued. And there is no need to change the mode and parameter also. So the same ventilator settings can be continued. And there is absolutely no need to disconnect or discontinue non-invasive ventilations for the purpose of connecting the nebulizers. So that's why the importance of this vibrating mesh nebulizer, because it can be directly connected to the inline of the ventilator circuit, and there is no extra dead space is also added. It is very less, and the drug or whatever fill volume is required for vibrating mesh nebulizer is also very minimal. So these are the same recommendations. So this article, they are telling that most efficient nebulizer for drug delivery is vibrating mesh nebulizer. And here also this is a study where in the Spanish ICUs they have shown that the NIV single limb circuit, the 41.7% correctly placed the device between the exhalation valve and the interface. That is the correct way of connecting the vibrating mesh nebulizers. In this systematic review also they have told that vibrating mesh nebulizer provide better lung deposition, more efficient drug delivery and superior clinical outcome. This is an adult study, that's why they have used it mostly in COPD patients, though it can be used in asthma also, and they have very few adverse effects, greater patient comfort, which may contribute to improved compliance and treatment success. So that is the thing. So all of this can be seen here. So the ventilation also, for single limb circuit the device should be between exhalation port and interface. For dual limb circuit it should be between Y-piece and interface. Humidification should not be stopped. Vibrating mesh nebulizer has better drug delivery, lesser fill volume and lesser side effects. Thank you.
Thank you, Dr. Niladri. I request you to collect the memento for the memento corner. Now we proceed to the next session. It's on theme 5, hematology and coagulopathy. We are honored to have Professor Dr. Mihir Sarkar to present on paradigm change in management of coagulopathy and anticoagulation. I'd like to request Dr. Govinda Mondol to kindly chair this session. He is the Associate Professor and PIC in charge, Department of Pediatrics, attached B.C. Roy, Postgraduate Institute of Pediatric Sciences, Kolkata. I'd like to request you, sir, to kindly welcome our speaker.
Hello, good afternoon. So welcome Dr. Mihir. He is the professor and head of the unit of the PIC unit of at Medical College Kolkata. His major achievement is that he is the teacher of College of Pediatric Critical Care. He also won the Purvanchal Pioneer Award in 2019. He is the chairperson of Society of Pediatric Intensive Care Kolkata, President of Pediaster India. He is the EB member of the College of Pediatric Critical Care and Secretary, West Bengal Academy of Pediatrics. He has many publications, both international and national. And I request Mihir to start his session, that is paradigm changes in the management of coagulopathy and anticoagulation. Okay, so start Mihir.
Thank you Govinda for these kind words. And my topic of discussion is paradigm change in the management of coagulopathy and anticoagulant. Because as of now, this idea is that the major coagulopathy is the bleeding in children, critically ill children, but there are the spectrum or there are the changes in this the pathophysiology over the times, and the trajectory may change. So let's see how we can define the coagulopathy in critically ill children. What is the spectrum? What are the point of care testing that are now being helpful to take the decision at the bedside, and that leads to goal-directed therapy, not just the drowning the patient with a lot of transfusion of the plasma or the PRBC or the platelet, but how goal-directed therapy is helpful. Anticoagulants, now the new guidelines of when to start anticoagulant and what are the recommendation, and recently the directly acting oral anticoagulant which are being used in adults but now got the pediatric recommendation as well. So coagulopathy is broad term, but now the terminology, this is the, you can see this may be the both phenotypic, the hemorrhagic or the thrombotic, and in pediatric or the critically ill children, there are now subgroup like the SIC, that is the sepsis-induced coagulopathy, or the TIC, that is the trauma-induced coagulopathy. And also in the DIC spectrum, there is a term now called the early phase DIC, which indicates when the patient does not have any overt signs or clinical symptom, but the lab parameters are indicating. So our target is to pick this patient at these early phases. So what is the criteria for diagnosis of coagulopathy in children, critically ill children? So the podium criteria given in 2024, it says that the platelet count less than 1 lakh, INR more than 1.5, fibrinogen less than 150, and the D-dimer level more than 10 times upper normal. If the two are positive, then it is the coagulation dysfunction is there in critically ill children. And you can see this is the our International Society of Thrombosis and Hemostasis guideline. What they have seen, given that in 2025 the guideline for over DIC, there are criteria and scoring system based on the platelet count, D-dimer, PT-INR, fibrinogen level, and the total score. If it is more than 5, then the patient or the sick patient had over DIC. But they have also given a separate score for the sepsis patients. So the sepsis-induced coagulopathy, I am coming to that later on. So DIC spectrum, it can be due to different disease and different process. Also it can be early phase DIC or late phase DIC, and also it can be the thrombotic phenotype and the hemorrhagic phenotype. So simple DIC is not a synonym to the bleeding. So there are a lot of other things to do as well. So this the management perspective also will change when if it is the thrombotic, you can identify then the anticoagulants will be the first in the early phase, followed by when the patient will go to the later phase, the overt phase, then the other supplementation of the plasma, fibrinogen and platelet will be there. And if it is the hemorrhagic type, of course the first line of therapy could be the antifibrinolytic, that is the tranexamic acid, followed by the supplementation of other blood products, the plasma, fibrinogen and platelet. And if you look at the sepsis-induced coagulopathy, again the same thing, the sepsis-related disorder can be also the early phase and the overt DIC phase. Even you can see that the scoring system here based on the platelet count, D-dimer, INR and the fibrinogen, and SOFA score is what has been added in this scoring system besides what we diagnose and DIC. So here you can see to detect in early phase, the score, the cutoff has given as a more than equal to 4. For the sepsis-induced coagulopathy, it is that mostly the initial phase is a thrombotic, that how we can identify with this simple scoring system. So this is the study particularly that was seen that within the first 4 days of the patient with sepsis, there is over the risk of the DIC and the sepsis-induced coagulopathy, and they have the outcome parameters is also the mortality is high. The patient who have the sepsis-induced coagulopathy diagnosed from the day 1 to the emergency to up to day 3 in the ICU stay. So what does this sepsis-induced coagulopathy you have diagnosed, how does it in place? Does it require the anticoagulant therapy? There is still no answer, but it can help you to early identify and prognosticate the patient, and at least what you can do is that enables the clinician to tailor the treatment strategy and take the interventions aims at preventing the further coagulation abnormality to improve the outcome. So that's how it is giving a caution to the clinicians to look at the measures that does not further increase the coagulation abnormality, the intervention given. So now coming to the trauma-induced coagulopathy, there has been major and lot of change here. So now we are going from this massive transfusion protocol that we used to give the patient with the trauma with the fixed ratio based, the plasma, RBC and the platelet, but that has been changed now to the goal-directed coagulation management based on the point of care testing. So what is this point of care testing? So the goal-directed treatment coagulation management in trauma patient is based on the point of care testing. So what is the advantage for that? So you can monitor the coagulation and hemodynamics before the during the treatment, and reduces the sometimes over transfusion and the under transfusion at the same time. So it reduces the massive transfusion, reduces the RBC and the PRBC and the FFP transfusion, decrease the allogenic blood product exposure, decrease the transfusion reaction cost, related cost, and there is more of an increased use of the fractionated coagulation or the concentrated factors instead of the giving the plasma or cryoprecipitate to the patient, and may further reduce the blood product utilization and cost. So the trauma, mainly we go to the point of care testing and the goal directed coagulation management, so that leads to the better targeted transfusion, fewer blood products, lower cost, and the potential improved outcome. So what are the point of care tests available? Is it that is the traditional test or the standard test we do, doing the PT, INR, or the APTT or the fibrinogen level, that is moving to the viscoelastic testing, that is the TEG or the TEM. So what are the advantage of this point of care test? You can get the result quickly, that is within 10-15 minutes and 20 minutes, and the use whole blood, and the provides feedback on treatment. So it is a dynamicity of the disease you can identify, and what your treatment is helping the patient you can identify. And regarding the standard laboratory test, what are the disadvantages? Are the poor predictors of bleeding. They are the long duration of the turnover time, at least even with the tertiary care center will not get the report within the 1 or before the 2 hours, and they do not provide the information about the hemodynamic changes, what is changing in the patient after the transfusion, and the performed at a normal pH, because the patient condition is the trauma or the septic shock patient is acidotic patient, the temperature is low, so the hypothermia acidosis that changes the result. So TEG, I'm not, this is the going to the details is not the scope for today's, but just to sensitize is that you can determine the clot, different stages of clot. So starting for the clot analysis, then the clot kinetics, how the clot is forming and how the clot is strengthening and ultimately leading to the fibrinolysis. So there are different parameters. Based on that, you can give the targeted therapy. When you will give the antifibrinolytic, that is the tranexamic acid, when you give the platelet concentration, we will give the fibrinogen. So based on that, this test in the bedside will help you out that this patient is required for this. So now this algorithm for treatment of bleeding in patient and trauma-induced coagulopathy, though this is a busy slide, so I am not going to the details, but to highlight is that first optimize the temperature, pH, calcium, and the hematocrit of the patient. Then going for this test, you can see that if there is the focus on fibrinolysis, that is the parameters of the extem CT is more than FTEM, then you need only the tranexamic acid. If the focus on fibrinogen defect, that there is a fibrinogen concentration is defect, then you need to transfuse the fibrinogen concentrate. So it is differing, it is the transferring from the massive transfusion protocol to the goal-directed therapy. If there is a thrombin generation defect, then you have to treat the platelet, the prothrombin the complex concentration instead of the FAP. So you need that there is lot of now shifting from the whole the plasma to give the concentrated factors. And if there is the platelet defect is identified, then you have to transfuse the platelet. But of course, there will be the severe category where there is all is defective. So you have to try with the all. So the tranexamic acid, fibrinogen, and the platelet concentrate. You can also detect the potential heparin exposure and clot instability. So what I want to highlight is that with this, the targeted therapy and the point of care test, you can reduce the cost of therapy, the lot of blood products, and the transfusion is the over dilution or the overload. Now, lot of focus on fibrinogen concentrate. So this is the coagulation factor 1. So normal plasma value, what is the clinical significance? Fibrinogen is often the first coagulation factor to reach the critically low level during the major hemorrhage, and the early fibrinogen replacement improves the hemostatic management. So giving instead of the cryoprecipitate or the plasma, if you give the fibrinogen concentrate and target it to according to the disease, so at least 1 to 1.5 gram per liter, then the lot of patient will able to manage the bleeding in most of the cases. So our goal-directed management would be to give this, if this test, the point of care testing may not be available in all centers, because I think the most of you who are present here don't have this facility to go to the bedside to get the TEG and the TEM testing. So how this, the physiological parameters that we easily available to our day-to-day practice can help to this goal-directed therapy. So you have to go to the age of the patient, heart rate, body temperature, hemoglobin concentration, blood lactate level, and the base deficit. So based on these parameters, so what the guideline says for the targeted therapy, you can say is that the basic is the giving the oxygen and the fluid management, laboratory blood testing, so maintain the pH, so the acidosis should be prevented, temperature normothermia more than 35 degrees should be maintained, maintain the calcium level, take the medical history of taking the anticoagulant of the patient or not. Then these three factors are very important: hemoglobin, base deficit, and fibrinogen. If the hemoglobin level is low, base deficit is high, more than 6, and the fibrinogen level is 0 to 1 gram, so these are the patients who are the more risk factor, and then you have to target the higher fibrinogen level here. So you can see the hemoglobin less than 8 and the base excess less than 10, then this patient, the targeted fibrinogen level should go up to the 4 to 6, so that your dose of fibrinogen will be required high. So, and the number 3 is the prothrombin complex concentration will be required if the patient have the clot aggregation defect. So here, whenever the hemoglobin is low and base excess is high, in spite of giving the tranexamic acid and fibrinogen, if the clotting, if the coagulation profile is not normalized, then you have to think of the prothrombin complex concentration, and if it is not available, then you can go for the fresh frozen plasma, and other you can do therapies. You can try, if the refractory cases are the desmopressin, tranexamic acid, and the factor 7 concentrate, the recombinant factor 7. So in the acute liver failure patient, again, so we try to give the patient with the blood products, but you have to know that the coagulation factor, the procoagulant proteins, that is the clotting factor, that decrease leads to the increase the INR, but at the same time we do not measure the anticoagulant proteins. So that's the increased level of the INR on the prothrombin time. Based on that, if we give the platelet therapy, that will lead to the patient to there are a lot of problem on that. So what it can lead is the fluid overload, transfusion related acute liver lung injury, and the FFP will obscure the important prognostic indicator, that is for the liver transplantation. So that's why they give the FFP only clinically significant bleeding before invasive procedure, like giving the patient requiring the ICP or the other invasive procedures. So now from the coagulation profile, the bleeding point of view, what are the take home, the tailors the treatment of the individual patient coagulation status, the VTE, that is the point of care testing guidelines guided algorithm, and the reduces over transfusion and the under transfusion. Coagulation factor concentrate are now more effective, and when the point of care testing is unavailable, blood gas parameters and the hemoglobin level can guide the initial concentration based treatment. So our aim should be the right patient, right factor, right dose at right time. So this is the patient who are coming with the hemorrhagic phenotype. So now going to the anticoagulant therapy. So this is when we start giving the prophylaxis in the patient with the anticoagulant. So you can both. So these are the two molecules have been approved now for the standard care. So after giving the patient with the fractionated heparin or the unfractionated the heparin, if after the 5 days the patient able to move to the oral, go for the oral medications like the dabigatran and the rivaroxaban. But you have to take the care that the gut and absorption issue is maybe the one of the you have to not use, or we use with the great caution, is the gut absorption issue, recent surgery, liver disease, kidney disease, antiphospholipid syndrome, preterm neonates, and the active cancer. So these are the conditions where you will not use this oral direct anticoagulants, and you have to be cautious before using. Now, what should be the duration of anticoagulation? Now, it has been reduced to 6 weeks, but if it is the provoked venous thromboembolism with the high risk, then it is 3 months, but unprovoked venous thromboembolism or the pulmonary embolism, then 6 to 12 months treatment has been suggested. So this is another change. So it has been reduced to 6 weeks with the patient, to the selected patient with the provoked venous thromboembolism and the low risk. So the reduction in the duration of the treatment. And when we do for thrombolysis, you can see here there are two conditions. One is the life-threatening renal vein thrombosis. Another is the pulmonary embolism with hemodynamic compromise. These are the two conditions where the thrombolysis has been suggested. In other conditions, thrombolysis versus only anticoagulant, the guideline has suggested the only anticoagulant. So in these two conditions, you have to go for thrombolysis followed by anticoagulant. So when we remove the central venous access device, if there's this guideline says that the CVAD is non-functioning or unnecessary, then remove it. If the central venous access device is functioning and it is not necessary, then it should not be explicitly, no removal has been suggested. So these are the new the changes or the new guidelines. So these are the shift from the previous. So the take-home message will be the point of care testing for coagulation disorder is now the demand of time. We have to do it, and the early risk stratification by objective scoring and lab parameters are very important. And the goal-directed therapy over the blind transfusion, like the massive, the fixed protocol, the ratio-based massive transfusion protocol is now warranted. Judicious use of anticoagulant, the when to use, what to use, and what should be, when should not use. So this is the new guideline has been delineated, and the directly acting oral anticoagulant has a new approved pediatric age group with a better safety profile. Thank you, and again I welcome you all to the Pedicriticon 2027 that will be in Kolkata next year.
Thank you, Mihir, for your nice presentation and a very good deliberation of the management of coagulation and anticoagulant therapy. So you can have any question from audience, 1-2 questions. Hello.
Fibrinogen concentrate, we are getting it. I understand that the volume is less. You can give more fibrinogen in a much less volume. In a patient where I am not really that concerned about volume, does it give any advantage over cryo, because it costs much more? So suppose I can give as much fluid I can give, then does it have any other advantage?
Yeah, so the other advantage, other complication that may arise with the blood products may be, but as the patient is not overloaded, then the transfusion associated overload may not be issue, but the trally and other things, the transfusion related infection and all can be there risk factors. So if it is the fibrinogen concentration is available and you can achieve, then because if it is the single parameters that is being depressed in this patient, that is the cause, then that will be the best.
Okay, thank you, Mihir. So no more questions. Okay, thank you.
Thank you, sir. I would request Mihir sir, Niladrida, Joydev sir, and Jacob sir to please collect your mementos from the memento corner. Moving ahead with our session, we have our next panel discussion on ethical and legal issues. And to chair this session, I would like to invite Dr. Shwapna Chakraborty. Ma'am is a professor, former professor and HOD of Pediatric Medicine, JNM Hospital, Kalyani. And I would also like to invite Dr. Shumita Basu. Ma'am is professor and HOD, Department of Pediatrics, Vivekananda Institute of Medical Sciences, Kolkata. I would like to invite the moderator on stage, Dr. Abhishek Poddar, who is a pediatric intensivist at Apollo Multispecialty Hospital, Kolkata. And his panelists, Dr. Arun Manglik sir, Dr. Govinda Mondal, Dr. Mukesh Kumar Jain, and Dr. Shankar Prasad Jha. The topic for panel discussion is ethics in the PICU, withdrawal of care, brain death in children, and organ donation.
Hello. Now, this is the very important and I think probably the toughest part of the discussion. So long since morning, we have discussed about the medical aspects, I mean treatment aspects of the intensive care. Now, the ethical issue is very tough, and the other part, that is the withdrawal of care, everything, every point are to be separate, to be discussed, can be discussed in one session completely. And the only one thing is, the term should not be the withdrawal of care, because actually it should be the withdrawal of the sustained, the treatment which sustained the life. Because treatment can be withdrawn, but care can never be withdrawn. And I would request our moderator, Dr. Abhishek Poddar, and he is known to everyone. I need not introduce him, but he is the secretary of this chapter of, pediatric intensive care, and he will discuss about he will do a panel discussion and will invite the panelists.
Madam, would we invite
So the panelists are Dr. Arun Mangalik, Dr. Govinda Mandal, Dr. Mukesh Kumar Jain, and Dr. Shankar Prasad Jha.
Thank you, ma'am, for that wonderful prelude. I would like to, after going through the rosy aspects of the PICU, as ma'am very well said, that we will now come to the difficult aspects and the things which we face in a daily ICU. So I have tried to put it in the form of cases so that it's easy for all of us, and I think everyone has gone through at least some of the few of the cases, so that it will be a good experience for them to learn from the cases which they have not experienced. So the first case, before we go to the first case, we will just go through a prelude that the objectives of today's session is to apply the ethical principles in real PICU cases, and I mentioned that whatever cases we are discussing today are all real cases, they are not hypothetical cases. We should analyze the dilemmas systematically, which will help in improve the decision making, apply the principles specifically in the Indian setting, because we do not have too many precedences in the Indian setting, especially related to pediatrics. Extrapolate cases from the adult aspects. We will be discussing a few adult cases where rulings have been given by the courts, and provide consensus on managing legal issues. The ethical principles basically which we see on which guide us include autonomy, beneficence, paternalism, non-maleficent justice. These look like very legal terms, but we'll get through these and try to understand what are these. The PICU context, why is it important? Because we deal with critically ill children. No one other than intensivists deal with critically ill children and who have a very high uncertainty, and daily counseling is required on that matter. It's a family-centered care with no very clear concepts related to what to do in cases of medico-legal issues, and absence of legal viewpoints, specifically in the Indian setting. Now we'll come to the cases, and these are proper cases, as I told you, proper real cases. So to Dr. Mangalik, the first case, a 6-year-old child wheeled into the hospital emergency room, post cardiac arrest status, 20 minutes CPR given in the emergency room, ROC achieved. Now the child has been ventilated. He's comatose with a GCS of E1, M1, VTube 1. Over the next few days, we are seeing that there are no brainstem reflexes which are evolving. MRI has been done, shown severe hypoxic injury with herniation, very poor prognosis as we all understand. Parents request for full support, however, hoping for a miracle. Ethical issues, we all know that there will be medical futility, prolongation of suffering, resource use, best interest standard, and physician responsibility versus the parental wishes. Now, to you, sir.
Exactly. Now, we have a situation where child is almost, if I may use the term, almost like a vegetable or furniture in the house. Now, the parents have very clear, they are emotionally bound to the child and they want full support, and obviously they are expecting a miracle that may happen weeks later, even months later. Gradually time will be a healer. Now the problem here is, what are we considering? We are having a child who is occupying a very important bed in a resource poor situation, whether that is allowed or not. We cannot dictate to the parents that you got to stop. We have to go along with what they say, because their autonomy is one of the ethical principles. They can take their own decision. So the respect to the autonomy is always there. At the same time, if we consider the two other aspects, beneficence, are we benefiting the child at all? In the long run, probably 99 point several times 9, we are not benefiting the child. non-maleficence, are we harming the child? Irrespective of the fact that the child may be comatose, has a GCS of 3/15, even then, we still don't know when we are doing some painful maneuver, do we really feel that the child does not feel the pain? Probably the child does, but the child is not able to express it. So going in all those non-maleficence, probably we are doing more harm than good. So we have to finally sit down with the family, maybe several sittings may be required, maybe we can involve the hospital management also, hospital social workers also, to explain to them that they have to accept reality, not live in a utopian world that they can expect that the child may come out of this situation. Well, miracles do happen, agreed. And they are expecting that. Probably they are praying, they are having yagnas and all sorts of things depending on what their religion they follow. But we have to sit around with them, explain things to them, might be multiple times, and finally they may come to see reason. And then only they will probably come to the situation of withdrawal, as Madam said, not withdrawal of care, but withdrawal of support or withdrawal of treatment. Now here again there will be several things. It is now legal, one, that we are now legally allowed to withdraw support, provided the parents agree. Here there is another important aspect. The patient himself or herself is not the decision maker. An adult patient, when in the full senses, can take a decision that in this situation, as they say, making a living will, that please don't support my life once such and such situation arises. But here things are different. The parents are the sort of the decision makers who will be taking decision on the behalf of the child. There may be again discrepancy. The mother may say something, the father may say something else. The grandmother may come up. So we have to finally have to come up to a decision, and then we'll have to either have a DNR, like do not resuscitate situation, or stopping of treatment. Passive and euthanasia may be allowed. In our country, active euthanasia is not permitted as of now. I think that way we can go about it.
So the approach in this case should be regular family meetings, as sir said, regular family meetings, and allow the family to come into the situation which will make them understand that this condition or whatever they want to do with the child is futile. Explaining the prognosis clearly and give a time limited trial. So for example, tell them let's see for a period of 1 week or a couple of weeks, and then if there is no response, then we can think about the ultimatum. In this case, as sir mentioned, the ethical and legal framework regarding this has evoked from the famous 2011 Aruna Shaunbach case, and the landmark judgment in 2026, where the Supreme Court ruling on passive euthanasia, which allows for withdrawal of life-sustaining treatment under strict guidelines. So the common cause guidelines, the Supreme Court simplified the process of withdrawing life support, permitting it if the patient has a valid advance medical directive of a living will, which sir mentioned, or if two medical boards separately confirm that the patient is in a terminal or irreversible vegetative state. Again, a similar case, the Harish Rana case of 2026, in March 2026, the Supreme Court permitted the first case of passive euthanasia, the removal of clinically assisted nutrition and hydration for a 32-year-old man in persistent vegetative state for 13 years. This has now, especially in adults, has set a precedent for allowing withdrawal of nourishment if recovery is deemed impossible. Still, in pediatrics, we expect similar judgments. We have similar kids, so probably it can follow suit. Procedures of withdrawing support would include a medical assessment. Two separate medical boards must certify that the patient is in irreversible coma or a persistent vegetative state. Consent, informed consent or refusal from the next of kin or surrogate. Here the family members, mostly the parents. Judicial or administrative oversight should be there. Hospital must inform the jurisdictional judicial magistrate or high court, especially for patients without a living will. And a palliative care, withdrawal of support does not mean abandoning the patients. It just implies shifting to compassionate palliative care.
This judicial oversight, that has been simplified lately, that you just got to inform the magistrate. Before that, it was you got to take permission from the magistrate, and the magistrate would physically come and examine, and then he would give the consent. Now you just got to inform them. I think this needs even further simplification. Two separate boards at two different times, and the speciality of the composition of the board That has also been simplified. Earlier used to be an anesthetist, an intensivist, blah, blah, blah. The things have now been simplified, but I feel the courts must look into this and make it further simplified, so that in a terminally in situation where there is no hope, of course, the parent can always say, and we always know, a child is far more plastic than an adult. So the hope for a miracle is probably more in a child than in an adult. But even then, in a terminal situation, well, I think in a hopeless situation, we have to simplify things to get things out of the way.
Thank you, sir. So this has been the most difficult type of scenario which we are going to face, or we face on a regular basis. Now coming to the relatively less, or rather a little bit easier cases, a 8-year-old girl, this is for Dr. Mukesh Jain, 8-year-old child with a grade 3 dog bite, suspected rabid dog, severe lacerated injuries, mostly in the face region, came with severe anemia with a hemoglobin of 4, needed urgent transfusion, needed rabies vaccine as well as immunoglobulin as per the protocols. Surgical repair also needed to be done for the facial injuries. But the parents do not want to transfuse. They are refusing rabies vaccination and immunoglobulin also. As you must have seen in the latest social media updates, things are coming up against vaccination. So parents especially are coming up with this. Parents are, however, consenting for surgical repair of the facial injuries. How to, the risk in this case, as we all know, a hemoglobin of 4, again a risk of cardiac failure without transfusion, high risk of contracting rabies without vaccination, and surgical correction is required, though it's not a priority. So how would you come to it, Dr. Jain?
So this scenario is a very difficult thing actually, but the first thing is counseling. So you have to know, understand that why the parents are denying for all this treatment. So maybe there is some religious misbelief, we don't know. Maybe there is some conception regarding the misconception regarding vaccinations, or there is a fear factor in their mind for blood transfusion. And maybe there is some financial issue, we don't know. So first we have to talk to the parents regarding all this, and also you have to explain the risk. So hemoglobin 4 is very low, and it's very fatal not to transfuse in such conditions. Second thing, rabies, if clinically detected, then the mortality is almost 100%. There is no treatment available till now. So your child is in a high risk situation. So and also the surgical repairs. So these things are very clearly explained to parents. And regarding the autonomy, here autonomy means my body, my decision. So that is what we think understood. But in children, there is a parents are actually giving the autonomy for the children, but it is not 100% absolute. So if there is a life risk, and that treatment must be done even if the parents are not agreed for that treatment. So autonomy is not absolute, 100% not absolute. So you have to be like as a clinician, as a caregiver, we have to decide whether this treatment is actually life saving or not. If it is life saving, even if they are denying, we have to go for that. But only thing is we have to inform the medical superintendent or your management people, and also sometimes we have to inform the judiciary. So that is the thing. But if it is life saving, we cannot. You should go for the treatment. That is the most important thing.
So here comes 3 very important concepts: autonomy, beneficence, and paternalism. Autonomy, as Dr. Jain mentioned, is the patient's right to self-determination, in this case the parents. Beneficence means it's a providers, that is us, our duty to act in a patient's best interest. Though patient or guardian may refuse treatment, it requires navigating the legal rights, mental capacity of the persons who are taking the decisions, the patient values, to balance care with respect for personal choices. And we, by doing paternalism, that is the provider can override the patient's wishes, believing that they know what is better for the child's long-term health. And then obviously child protection comes in, and you can step in and do whatever is best for the child. Emergency doctrine, also known as the implied consent doctrine, is a legal and ethical principle that allows healthcare providers to treat a patient without their explicit informed consent during life-threatening situations where the patient is unable to communicate or lacks decision-making ability. In this context of that autonomy plus beneficence dilemma, this doctrine acts as a critical pivot point where the duty is to preserve life, that is beneficence, and is legally presumed to be what is a reasonable person would want. Thus, temporarily overriding the standard requirement of patient, or in this case parental autonomy. So the approach would be counseling of the parents, explaining the risks, involve the ethics of the legal team as is required in majority of the cases, and court intervention is if required. Transfusion was given in this case in the best interest, vaccination both active and passive was done, surgical wound care was done as per parental wishes, child was discharged home on day 7. Case 3 for Dr. Govinda.
Just a point, if the parents had not agreed to it, would you override their autonomy?
Agree to what?
Yeah, paternalism would paternalism come in?
Paternalism would definitely come in for the interest of the child.
That means that you would override their autonomy, their decision not to take it, but you would override that in the child's interest.
Absolutely. So, Dr.
Without any legal interference.
If required, if the parents don't agree, then go for a legal interference.
So be very clear about that.
Absolutely.
Now
Absolutely.
So suppose your patient is not, your parents are not agreeing, they do not want to give consent.
Absolutely.
Agni, I'll answer your question. Here the situation is, there is no immediate life risk, but there is a very strong potential life risk in the next few weeks or maybe the next few days if the child develops rabies. Child is not going to develop rabies in the next few hours. Okay. Now in one situation where there is an immediate life risk, like going for an emergency cesarean section, the parents are not agreeing to it, and you've got very bad fetal distress, fetal heart rate is coming down to 10 or something like that. So there you got to immediately override. Now here you may have some time, a few hours also. You can counsel them, and you can, in a way you can go through a back door. You can threaten them legally, I'm going to the police, I'm going to inform the judge. That brings in a sort of a fear factor, and they'll agree to it. If they don't agree, obviously you can go to the police, or you can go to the legal authorities or to the hospital authorities, and they'll take over.
Take a legal permission and go ahead. For want of time, we'll cut the questions short. We can take the questions at the end of the session. Dr. Govinda Mondal, pandemic surge, you must have faced this lots at BCY. Pandemic surge of COVID, only one ventilator available, 2 sick patients brought into the hospital simultaneously. Child A, first child, known case of developmental delay with respiratory distress. Second child, normal child with respiratory distress. No hospital beds or ventilators are available elsewhere. So what?
So although pandemic has gone, but still we are facing the problem in day-to-day practice in our hospital actually. So every day we are getting such situation that there are too many patients who need ventilator support, who need PICU support, but we could not able to accommodate them in our PICU. So always that there should be a triage in this method. So we are triaging. Initially it was the patient-centered triaging, but subsequently we have shifted to population-centered triaging. That is, we try to improve or try to save as many as possible life, not a single life. Suppose if in this scenario, the 2 child, one has comorbid condition, another child is otherwise normal but having respiratory distress, maybe improve after 2-3 days of ventilator support, but child may be improved. So in the first scenario, if we put that child in ventilator support, that child may take long time to recover, and even if the chances of recovery is also poor on that child. So we should give importance to that we should at least try to save the child who is more chances of survival. Okay.
Very well mentioned.
So that should be, so the triage should be population centered. Okay.
So during a pandemic, what happens? The triage usually shifts. We know that there is a triage system for all critically ill children, but during a pandemic, the triage system shifts from a patient-centered approach to a population-centered model. And this transition is governed by the need to maximize the public health benefit, as can be stretched during episodes of pandemics. Justice and benefit should be provided, and in this case there are certain terms such as utilitarianism or consequentialism, which is aimed at the greater good for the greatest number, and maximizing the life saved, prioritizing patients with the highest probability of short-term survival they are aimed for, and maximizing life years. So these should be looked for both for short-term and long-term survival. So in this case, what we should do is use appropriate triad scoring systems, which should be, there should be a transparent policy by the institute. Otherwise, the parents will come and say, no, why my child was not taken. So there should be a transparent policy written down in pen and paper.
So institutional protocol should be there.
Absolutely.
So that we said to the patient party that
Absolutely.
I have taken that child to the ventilator and not that child to the ventilator because of that.
So go for institutional protocols, written protocols. There could be a little bit of moral distress among staff when one child is neglected than the other child, and take medical legal help as and when required, as is required in majority of the cases. Our fourth case, Dr. Jha. A 3-year-old child presented to the hospital in a very sick stage, no previous history of any major illnesses, but the child has now not been improving over the next few weeks since admission. Diagnosed to have a rare metabolic disorder on the extended metabolic panel. There is no proven therapy for this condition. So what to do in this case? Experimental drug is there. It was suggested as part of an ongoing trial being conducted. You don't know unproven benefit versus harm. Informed consent. What are the things we are going to do now for the parents in such cases?
Yeah, thank you. So first of all, before going to the case, I must tell you, being a student of law, every case is a medical legal case. You must be cautious before arriving at a diagnosis, and you must know your rights and you must know the rights of the patients. So here comes a case where a new experimental drugs is given. We must take ethical permission from the ethics committee. Most likely they have whatever newer drugs are there. We must read it carefully and we must inform the patients here, maybe the patient's guardian. A pediatric patient can take his decisions after 18 years of age, not before that. Before 18 years, his parents are the legal guardians. So you need to have, and parents, both the parents, not one patient. Suppose you have a talk with the father, the mother may disagree. So you must document it, tell them what is the drug and what are their side effects, what is you are going to do and what are the benefits they have, and autonomy says they have every right to approve or disapprove. If they approves, okay. If they disapprove, we can't do anything. Thank you.
Probably here the concept of autonomy versus beneficence does not come into the picture. Here probably autonomy will take the upper hand, right? So assess the scientific rationale that the child may not improve even after the trial should be instilled in the parental minds. Case number 5, 10-month-old child, Dr. Bangli. A 10-month-old child with high-grade fever for 2 weeks, diagnosed with leukemia, T-cell ALL, very poor prognostic variant as we all understand. Counseling was done. Father wants aggressive care. Mother prefers palliation, as Dr. Jha right now said. Both parents should agree, but here there is parental agreement. Father wants aggressive care, mother wants palliation. So how to go forward?
Well, we have to sit down with them, explain things. Probably the father is being more emotional than the mother. Mother is being more realistic, because she's probably understood that the outcome is not going to be good. Now in the long run, finally, if it comes to a situation where the father just doesn't agree at all, then what do we do? Because there the mother is agreeing, but the father just is very adamant and says no. Well, here unfortunately, whether we like it or not, it will not look gender neutral, but the law still says the father gets the upper hand. That's unfortunate that the mother, unless the child is less than 5 years old. If the child is less than 5 years old, then the mother gets the upper hand in so much as the custody part only. But final decision making will be resting with the father, both in Hindus and in Muslims. I'm not sure about the other communities. And in any case, we'll have to sit down with them and make them understand, make the father understand. And I mean, there are several ways of counseling. You know, you can tell him that this will cost you so much of a fortune. You may lose all your money. What will you feed on? After 6 months, when you've lost everything, khabe ki. This has happened to many of us. The parents are saying, I'll sell my land, I'll sell my house, I'll do everything, I'll break all my FDs. But after an outcome which is not going to be good at all, what will happen to the family? How will they feed themselves? These are real life situations which all of us face. So we got to make them understand, not trying to be acting like God or being too much paternalistic, but at the same time make them realize reality.
So here, parents were adequately counseled. If required, you may take legal help. In this case, pediatric palliative care was a consensus for pediatric palliative care was taken, in where the focus shifts from curing to maximizing the quality of life and relieving suffering in children. And the care is not only limited to end-of-life situations.
That's the most wonderful part. Palliative care means minimal suffering and good quality of life, not prolonging life.
We go on to the next case, Dr. Gobindo, 10-year-old child with traumatic brain injury following a road traffic accident, came in with a GCS of 3/15, intubated, ventilated, CT scan done, severe HIV with herniation, brain death criteria met, counseling done, family now refuses for organ donation. Profound so how do you go forward? You want an organ donation?
Here again the problem of agreement and disagreement. Regarding organ transplantation, consent is must. So we just simply don't go that the child is not going to survive, so we can donate the organ to other people. Not like that. So before that, we just make them try to understand that what are the benefits. First of all, we should be sure that this child will not survive. So yes. So after that, if there is all the criteria of brain death has met, and there is no chance of revival of the child, so we should go for open discussion that if we donate the organ to other person, there may be chances of survival of many patients or many life. So after that, if they agree and give written consent, then only we can go for planning for organ transplantation. Okay. So the what are the what are the things, how the person who is going to die, he is helpful by donating the organ. Actually, he is not getting any benefit. Okay, so he is going to die, and the part of the organ which will helpful for the others. So that should be our motto, to try to understand the parents so that they will give consent. Okay.
Absolutely. So there are various rules such as the consenting donor rule, the dead donor rule, yes. And mostly the parents or the legal guardians have to take a decision about the organ donation. If they say no, it's a no. So you cannot hear your thing of beneficence does not come into the matter, right?
So as a treating physician, we should not directly tell parents for organ donation actually. There should be a third person or any other person who should tell all these things after confirming the brain death or something like that.
Absolutely.
So this is a conflict of interest otherwise.
Now this case is for you, Dr. Jain. Infant on ECMO with severe ARDS. No recovery is seen over the last 3 weeks on ECMO. Parents want continuation, but you know the prognosis here after 3 weeks becomes very guarded. What to do next?
So here again we have to see parental autonomy is definitely there. But we cannot say we are going to stop ECMO like that. We have to explain them clearly that even if you are continuing the ECMO, there is not going to benefit the child. So that point is very important. Parents are always very emotional and they want to continue the treatment for long. But such a therapy like ECMO is very resource limited setting, is very less number of ECMO things are available. Suppose in the meantime another child requires this ECMO, then there is a problem. So we should not directly stop ECMO, we should not utter that type of word, and in the same time we have to make them explain that it's not going to help the child. So that's how we should go.
Similarly, on the other aspect, medical teams are not ethically or legally obligated to provide futile or non-beneficial treatment that merely prolongs the suffering of the dying. So this
yes, they were not able to compel us, the treating physician, to continue the therapies.
Now a very few quickies, a few quick one-liners. Dr. Jha, infant with SMA type 1 admitted with respiratory distress, now ventilator dependent. Parents want full support. What to do? Do you go ahead or stop? What do you do?
Everywhere we are coming to a conclusion where counseling is very important. And being a doctor, we are seldom good counselors. But after 2019, government has started NMC competency-based medical education, where attitude, ethics, communication skills are treated. So you must be a good counselor. There is no single answer to anything. If you don't, you take help of your colleagues. But here, one-liner will be, if they don't give consent, don't try. Thank you.
Now, parents want full support.
Yeah, they don't take away the support.
Okay, don't take away.
He'll be in a deep shit.
Okay. Next, Dr. Jain. 16-year-old child has been newly diagnosed with ALL. Parents have consented to start treatment, but on the day of treatment onset, the patient refuses chemotherapy. 16-year-old, remember the age. What next?
So 16 year is not adult till now in India, 18 years that is what recommended, but 16 year is well enough, mature enough to take the decision. So we have to respect that decision, but it is not 100%. Again, we have to counsel the parents and the patient itself to go for the therapy, and that's what.
So these restrictions apply only in life-threatening situations and not in other situations.
Yes,
Just to remember
right.
that. Dr. Mangli, 9-year-old child with respiratory distress has come to the ER. Treatment is initiated at the ER. Again, a similar situation, no PICU bed is available. No bed is available in the PICU or other PICU or hospital. Only ER bed is available. But we see in corporates many a times, influential family demands an ICU bed. What to do?
I'll come to this in just a moment. Just I'll highlight two important issues. Regarding this organ transplantation, the parents may refuse, but there are several ways we can counsel them or we can make them understand. Like there are instances where parents have come up, or patients of or relatives of donors have gone to the recipient and says, I can see my child's eye over there because the cornea had been transplanted. Or the mother goes to the child where there has been a heart transplant and just puts her ears to the recipient's chest and says, I could hear my child's heart beating. So these are instances and these are anecdotes which have come up, and these can be explained to the parents. So this goes a big way, they can understand things. And the last case, I mean, there was one, I forget it. Now in this particular situation,
the family wants a bed.
Family wants a bed, yes, the family can definitely, I mean, you remember that, that Sanjay Dutt movie? Huh? He brings a bed from outside, he says, bed nahi hai, to hum bahar se le aata hai. That is something like that. I mean, yeah, Munna Bhai MBBS. So they can go to that extent also. But the thing is, well, yes, there are ways we can do it. We can call in the hospital administration, make their influential parents go inside the ICU and see, where will I put your baby? Can I put the child who's already there down so that your baby can be accommodated? There are several ways we have to make them understand. Influential doesn't mean that they are absolute rulers.
Just counsel and make them understand. Yeah. Okay, Dr. Jha, 14-year-old child.
But many times we are arranging the beds. That is the practical thing I am saying.
Okay, now from beds to time, we are running short of time. 14-year-old child diagnosed with mesenteric paniculitis receives pulse methylprednisolone, started on MMF, severe abdominal pain persisting, gastro review done, the consultant wants retux, primary consultant was cyclophosphamide. So there's a confusion between both the consultants. What to do?
Yeah. This happens. There are two things you must know, that primary consultant is the main doctor responsible for the patient. He should take the decision. He may take opinion of others, and here also, talking with the patient, autonomy. Talking with the patient parties, guardians. You should talk and decide.
The primary consultant is the sole decision maker. Whoever waits, the primary consultant has to take the decision because he is medically viable. Dr. Govindo, 16-year-old obese child ventilated in PICU since last 1 month, severe ARDS, difficulty in giving nursing care, has developed multiple pressure sores. He will require surgical debridement and dressing, difficulty in shifting the child to the OT. Parents don't want to bear the added burden. What to do?
Actually, in this scenario, the life of the patient is more important than this burden. Okay, so you cannot deny any treatment, even if they don't have money.
So the hospital has to bear the cost?
Yes.
Okay, good. Dr. Jain, 10-year-old child ventilated for GV syndrome, tracheostomy done, tube beds blocked at night. Child develops cardiac arrest. Many a times we commonly face. Revived, family members create ruckus in the hospital, malign doctor on social media. What next needs to be done?
So you have to be very honest and like first you say take care of the patient first. Whatever is happened is already happened, so we have to take care of the patient first. And then during the counseling you have to be very honest that this has happened and we have taken care of that and we'll take care of the child. So the two things are very important. You have to be honest. You cannot hide everything.
Last case, Dr. Jha, 2-year-old child with massive intracranial hemorrhage, very commonly seen scenario following a suspected ruptured AV malformation, intubated and ventilated, will require urgent surgical dip compression, but parents want to take the child, discharge against medical advice, to another institute or home citing financial reasons. What to do? Can you leave such a child?
Yeah, it should be individualized. Here also we were talking about communication, taking permission. You must talk with the patient guardians and convince them that what may be the consequences here. If they want to take, what are the risks involved, always videograph it, do it in the patient's language, and then you need to take decision.
So if there is a significant immediate risk to life, you cannot let the child go DAMA even if they are wanting to take the child home. So explain consequences of refusal to treatment. So take home points at the end of the session would identify the ethical issues related to your case, assess the prognosis of each case, apply ethics, specifically consider Indian law, though we don't know much of it is not available, discuss with co-consultants, medical admin, and as we know each case is unique and there is no uniform solution. To do all the necessary things which are required. Thank you.
One last line, if there is a discrepancy between the primary consultant and the referrals, please don't let the relatives know about it.
Thank you, Dr.
They
Poddar.
know you are in a soup.
Thank you, Dr. Poddar, for that excellent session. Yes, ethics and law, I think there's still a lot of gray area because law should be structured and most of us have to have that incorporated into our medical curriculum because all of us are facing these problems day to day. So thank you once again. And children, again, they are more vulnerable and this is a very sensitive issue about how to really talk about, because right now I have a newborn who is on ventilator and we have a DND. The parents have said do not resuscitate, but now what about nutrition? What about antibiotics? They are not paying anything. The child is on the in our hospital cost, and it is going on for days together. So these are very difficult. I think every hospital should have a legal team who's going to able to guide us. We with the medical knowledge, really it's very difficult to follow all the real, and every scenario is different. So it's a very complicated subject. I think we are still learning, but thank you so much for this wonderful session. Thank you.
Thank you, sir.
I think we have discussed this thing already with Dr. Abhishek. Regarding the comment from Dr. Govinda, I'm not fully convinced because with that case of single ventilator and both the child is having respiratory distress, one is having developmental issues, the developmental delay, another is normal development. So legally, developmental delay cannot be a criteria deciding factor for withdrawing ventilator to some who is having normal development. Because it is only that when there is a pandemic like COVID, there you can take a decision on the population-based decision. But if it is like normal conditions like just now, you cannot take a patient-centric conditions just saying that I am taking a population-based centric idea and not giving ventilator to the other child, like who is developmental delay. So developmental delay is not a criteria for deciding that who will get the ventilator, number one. Because ultimately the short-term goal from the respiratory distress, whether it is equal for both the child, should be checked for. If it is equal, then possibly you need to go for randomize between these two and give the ventilator to the child who is getting that randomization. Number two, possibly, as because it's not a pandemic situation and you can always ship this child to another hospital, the best idea will be to ship that child intubated and ship that child to another hospital where ventilator is available.
Definitely we try to save both the child, but in this scenario, if you don't have such, in this presentation, it is written that there is no other way to send the child to other hospital. So only, yes, that is written. So the only thing is you have only two choices, although there is no definite yes or no answer in medical science. As in law always lawyer asks us whether it is yes or no, tell me yes or no. But in medical science there is no answer like yes or no. So there is always in between yes and no. So you have to judge to whom you can save. So that is the first criteria. If you are able to save one, that I can save this one, it is your sole discretion that you can take that child to the ventilator. And if you have, suppose we used to initially use what you used to do, we intubate that child and we manually do bag and tube ventilation. So that was another way. But in this clear presentation, according to that presentation, I must ventilate that child who I can
So intubate the child and send
So
the
that
child
is
to another.
the single criteria I have taken.
Another very,
Okay.
very important, I agree completely with you that a developmental delayed child cannot be, denied that.
No, ma'am, I am
But I
not-
think the point of, what we can
Never.
make an understanding of point of entry into the PICU or an admission, who came first, maybe that will be more medically acceptable. The first come first ventilation. So closing comments from Dr.
If there, if
Another
the
question
child
to
came
you, that,
simultaneously, so there is no.
Thank you, sir.
When to pass
I am just asking you, that brain death, you have detected that there is brain death. Is there any time limit after which you will declare to the party?
There are strict guidelines and time limits are mentioned. As per those time limits, the brain death can be declared. Different time limits for different ages.
Actually, those going to
There are different
Even-
time limits for different organs.
different organs.
Like for cornea, I think it's 4 hours.
That is for donation.
Yeah, that's
Okay.
what you are asking.
But you will declare to the party
Acha.
that you have detected that is brain death. Brain death means it is legally death. So when you will declare to the party, if after some time or immediately, there is time limit.
12 hours or 24 hours based on, unit will have a separate thing. Based on the age of the child, whether it's an infant or pediatric or neonate, there are different time of declaration.
চলছে ভেন্টিলেটর চলছে এরকম তো হয় না ব্রেন ডেথ হয়ে গেছে কিন্তু সব কিছু চলছে
Thank you, sir. Thank you, ma'am.
Thank you, thank you.
I would request the chairperson, moderator and panelists to collect the mementos from the memento corner, please.
Please carry on. Otherwise, we will be delaying matters.
Going to our next session on nutrition, neurology, AI and communication. To chair this session, I would like to invite Dr. Rita Chatterjee, former professor, pediatrics, PC Roy Postgraduate Institute of Pediatric Sciences, Kolkata. I would like to invite the speaker, Dr. Momita Shamantu, professor and HDU in charge, Medical College, Kolkata. And ma'am is going to speak on medical crisis in PICU.
Is it working? Hello? Good afternoon, everybody. Thanks to the organizer for inviting me here. And now it's my pleasure to invite Dr. Momita Shamantu to talk on the topic of the metabolic crisis in PICU. And Momita is a worker of intensive care for a long time, I must say, and she is the professor and in charge of many critical care units in pediatric medicine in medical college, and her major achievements are she is the recipient of Women Research Award 2021, and there are lots of publications by her, and I would request her to start her topic. Okay.
Thank you, ma'am, for the kind words. Going through my topic, it's on metabolic emergencies in PICU. What is metabolic crisis? It's an acute decompensation of metabolic homeostasis seen in 2 to 4% of the PICU admitted children and mostly occurs due to inherited or acquired metabolic disorders. It requires rapid recognition, immediate intervention as a life-saving measure. The common presentations are superrefractory status epilepticus, a child who is and then a child presenting with encephalopathy of unknown origin, a child born out of consanguineous marriage having recurrent vomiting, lethargy may give us a clue. A child may present with shock, there may be respiratory failure, or may present with multi-organ dysfunction. The common causes are inborn errors of metabolism, mitochondrial disorders, liver failure, hyperammonemia, diabetic ketoacidosis, poisoning, drug toxicity, and sepsis-associated metabolic derangements. The common triggers are the children usually present with concomitant sepsis, or it occurs following a surgery or some kind of physiological stress. It may be after exposure to certain drugs, toxins, or environmental exposures. And It may be following certain medicines like valproate, salicylates. It may present following diarrhea, dehydration. So there is some intercurrent illness or stress that pushes the child towards a metabolic decompensation. The important clues that the child in PICU might be suffering from a metabolic crisis are hypoglycemia, hyperlactatemia, high anion gap metabolic acidosis, ketonuria, hyperammonemia, hyperlactatemia, and also several dyselectrolytemias like hypernatremia, disorders of potassium, calcium, and phosphate. So what is the 0 hour management besides stabilizing the airway breathing circulation? We need to stop catabolism, stop all forms of protein intake, start high glucose infusion at 10 to 12 milligram per kg per minute, and maybe we have to give a little bit of insulin if required, but we have to continue with the high glucose infusions and do fluid resuscitation. But there are certain critical management steps. As management is important, drawing blood for critical sample is also important to get to the diagnosis. So blood is drawn for plasma amino acid, acyl carnitine profile, lactate, ammonia, blood gas and blood sugars. Urines are examined for organic acid, ketones and reducing substances. Especially in if the children is younger infants like or say 3-year, 2-year-olds, we need to give them a cofactor trial. Cofactors are basically certain vitamins that may enhance the residual enzyme activity and bypass the metabolic blocks, and it may be life-saving. However, we need to monitor for the response. If after giving the cofactor trial there is not much biochemical response within 48 hours, the trial needs to be discontinued. These are the common cofactors we often give, and these are the conditions where these specific cofactors may work. So coming on to the hyperammonemia. Hyperammonia, any ammonia more than 50 is hyperammonia, and ammonia more than 100 to 150 is a point where we need to act. Children usually presenting with hyperammonemia are those with urea cycle defects, hepatic failures, fatty oxidation defects, and other medicines like long-term valproates, etc. Beyond 100 to 150, we may start ammonia scavenging agents like phenyl acetate, phenyl butyrate, injection arginine, and if it goes beyond that and child is encephalopathic having recurrent seizures, then we may have to start with dialysis. Dialysis is life-saving in these children. But one small thing which I want to say is ammonia should be sent in a EDTA vial in ice, and it should be examined within 30 minutes of drawing the blood. Coming on to lactic acidosis. High lactate is very commonly seen in PICU. Mostly they are due to poor perfusion, impaired oxygenation, and these are called type A lactic acidosis, and we usually correct the underlying etiology. But sometimes, rarely we come across a child whose perfusions are okay, but still he is having high lactate, he is not doing very good, and these are the children who are probably type B lactic acidosis, which is due to liver failure. So how do we go about them? We have to send lactate pyruvate ratio in these cases. So hyperlactatemia with a normal to low lactate pyruvate ratio may indicate underlying pyruvate dehydrogenase complex deficiency or a biotinidase deficiency where thiamine can be life-saving. If the lactate pyruvate ratio is high, more than 20 to 25, it is probably a mitochondrial defect, a respiratory chain problem, or a pyruvate carboxylase deficiency. And if it is very high, above 40, it is mostly due to systemic shock or regional ischemia. Now this lactate pyruvate, this sample should be sent in perchloric acid, and that special tube usually comes from the lab, and again the sample should be sent in ice and examined within 30 minutes of blood drawing. Now we need to stabilize these children, start high calorie dextrose infusion, add insulin if required to maintain euglycemia. The goal is to suppress catabolism, improve anabolism. We may consider thiamine, riboflavin, carnitine and CoQ supplementation in these cases and monitor for lactate clearance. Avoid sodium bicarbonate and give it only when pH is less than 7.1, as it may cause paradoxic increase in intracerebral acidosis. Now if the acidosis or the hyperlactatemia is not controlled by all this, we have to do dialysis. Next is hypoglycemia. Hypoglycemia is a dreaded complication. It is a medical emergency. We have to treat it first before diagnosing why it is happening. and we all know we basically give dextrose 2 ml per kg as a bolus, and then we start the GIR. But how to go about? While managing, very important is to draw the critical sample. When the blood sugar falls, we need to draw the blood to look for lactate, insulin, free fatty acids, beta hydroxybutyrate, cortisol, growth hormone, amino acids, and urine for organic acids and ketones. The key indicators are, if a child is having hypoglycemia with and his ketones are also low, there are two common differentials, hyperinsulinism or fatty acid oxidation defect. If free fatty acids are also low, it is probably hyperinsulinism. If free fatty acids are high, probably fatty acid oxidation disorder. Now, a clue to this is if you give a start dose of glucagon, there may be a large jump in blood sugar, so it goes in favor of hyperinsulinism. A child with high lactate level with hypoglycemia strongly suggests glycogen storage disorders. Now, metabolic crisis and severe sepsis. Regarding this triad of therapy, hydrocortisone, ascorbic acid and thiamine, there are a lot of, mostly people do not recommend it, but there is a role, and as Ibor sir in the morning just told us about the mitochondrial dysfunction that occurs in severe sepsis, and the cells fail to clear the dying mitochondria, and that can cause further inflammatory cascade. So hydrocortisone somehow controls the cytokine release, vitamin C improves the endothelial function, and thiamine supports mitochondria energy production in some way. Meta-analysis have shown that the organ dysfunction score, there may be some improvement, vasopressor duration may reduce, but in children, as of now, it is not yet recommended by any standard guidelines. So metabolic resuscitation, we have to goes hand in hand with other therapies and is life-saving. These are some of the real-time cases in our PICU which presented with, some presented with encephalopathy, with refractory seizures, and they did wonderfully, and they presented with metabolic crisis. These are my references. Thank you.
Thank you, Dr. Moumita. It was a very nice presentation. It is very clear from your talk that broad range of conditions can give rise to metabolic acidosis, from a very serious illness like sepsis to endocrinal causes like diabetes mellitus or adrenal insufficiency like that, other than the undiagnosed cases of involved errors of metabolism, and it produces a very catabolic state which we have to bring back to anabolic state, and that needs the coordination of many departments, and in the same department different people, and depth of knowledge is very important for the intensivist and the pediatricians for managing these cases. Thank you. Any question from the audience regarding this metabolic acidosis?
Thank you.
No.
I would like to invite our next speaker, Dr. Shamim Akhtar, who is a PICU consultant at Institute of Neuroscience, Kolkata, and he is going to speak on feasibility of continuous EEG monitoring in neurocritical care.
It's a pleasure for me to invite you on the dais, and you are Dr. Shamim Akhtar. You will be delivering on the feasibility of continuous EEG monitoring on neurocritical care in PICU like that. So it is a very important topic. You have done your MD from Chennai, and you are consultant in PICU in INK, and your affiliation in neurosciences in Kolkata, major achievement, you are a gold medalist, and there are multiple publications in national, international paper. Please start your topic. Okay.
Thank you, madam, for the kind introductions, and thank you organizers for the opportunity. So I'll be talking about feasibility of continuous EEG monitoring in neurocritical care. So EEG is usually done as a spot test, and it lasts for something around half an hour. But continuous EEG lasts something in between 6 hours to 6 days, it varies. So both tests, both spot EEG and continuous EEG, both are very valuable tools in treating a child who is sick and who is in neurocritical care. But the indications and the way we manage both of them is very, very different. So what I'll be talking about in next 8 to 10 minutes is continuous EEG, what it is, what are the indications, and how do we troubleshoot the challenges while implementing it. For that, first take a look at this case. So this is a case, a 6-year-old girl who had multiple seizures which went on to refractory seizures. So treated with multiple anti-seizure medications, ultimately midazolam infusion, and when the seizures stopped, at least the clinical seizures stopped, the sensorium remained altered, and after a couple of days when they tried to extubate the child kept on failing extubation. So this child was then referred to us. So the child was encephalopathic at admission, and there might be multiple reasons for this altered sensorium, but considering the background, the first and foremost diagnosis in this child is an ongoing electrical status. So the first thing we did is an continuous EEG in this patient, and indeed this child was in a electrical status. So you can see the patient not having any convulsive seizures. The vitals are actually okay, but the EEG shows clear status epilepticus. So we increased the midazolam infusion that was already going on, and at a very high rate, around 16 mics per kg, the electrical seizures stopped. But then after a few hours, it returned back. So we gave phenobarbital, and then again the child initially responded to the phenobarbital, and then the EEG was completely suppressed. Then we had to pull back the dose of phenobarbital. After that, we added more immunotherapy, we added ketodide, and only then the seizures, electrical seizures were controlled. And then this child was we could possibly extubate this child after about 6 weeks, and the child was ultimately discharged home. So you see, in this kind of patients, where the patient is has a seizure disorder and has a non-convulsive status, without continuous EEG, we cannot possibly treat this patient. Starting from diagnosis, every step of management is actually guided by continuous EEG. Even for a few years back, we had this question that is non-convulsive status as bad as convulsive status? Is ongoing status actually damaging to the brain? So considering the research for last 25 years, we actually have that answer to that question, and it is very clear that non-convulsive status is actually as bad as convulsive status. In fact, there is a dose-response relationship. The more the non-convulsive status goes, the worse the outcome is. And in one study recently done from sick kids, it shows that if the non-convulsive status exceeds more than 20% of the duration of recording, then the possible outcome is actually bad. That has changed to change in this criteria of definition in non-convulsive status, bringing it down from 50% to 20%. Another thing that data has shown is that in all the patients admitted in neurocritical care, non-convulsive seizures and non-convulsive status both are very, very common. So the ACNS has given us the guidelines regarding who are the patients in whom we should be actually doing continuous EEG. Basically, this treats with the patients who are actually having a background of seizures or are likely to have seizures, like noting periodic discharges in EEG, or we are treating anti-seizure medication and that needs titration. Those are the patients that actually needs continuous EEG. There are other indications like identification of cerebral ischemia, but that is more as an adjunct. And in case of prognostication and encephalopathy diagnosis, what we have is like there is a little bit difference, like should we use spot EEG or continuous EEG, but regarding treatment of non-convulsive status, it's always continuous EEG. So when it comes to the implementation, there are some problems. And the first question always is, who is going to read the continuous EEG? You can have a recording for 6 days, but who is going to sit there for 6 days and read it and interpret it and troubleshoot the problems? The thing is, the best person to read the continuous EEG is always a neurologist. There is no doubt about that. But nowhere in the world you will have a neurologist sitting down in the ICU to read the continuous EEG. What I would argue is, we are using continuous EEG for a different purpose than a spot EEG. We are not there to diagnose every single problem in the EEG. We only want to use it to diagnose very certain problems. It's like a point of care echo, where cardiologist is the best person to do the echo, but we go over availability over expertise. So we are looking for non-convulsive status, we are looking for effect of medication on the non-convulsive status, and those patterns are much more easier to detect, and it's quite dramatic. So here, change from this first part. So there is a video, can I run it? Anyway, I can't get the video to run, but you can see even here, the change of pattern from the first part to the second part is actually very obvious and very dramatic. And I would argue that any person, usually the doctors who are present in the floor, the pediatrician, the intensivist, or even the neurotechnicians, they can usually pick up this pattern. And there is always neurologists in the background. Where we have a doubt, we can always take a video and send it to them to have a confirmation. We sometimes use this EEG as to find out if the medications are working or not. Again, there are a lot of things going on in this video, in this EEG. We actually don't need to diagnose every single of them. What we want to see here is we actually given a dose of, so what happened in this patient, there was an automatism around the mouth. Patient of autoimmune encephalitis, we didn't know it was a seizure or not. EEG was not clear cut of seizure, but here at this point you can see we have given a dose of lorazepam and the EEG has completely changed. So which kind of tells you that this was actually seizure and we need to treat it. So this kind of pattern, this change is actually very obvious, and I would argue we don't need an expert neurologist all the time to identify this. Yeah, so at this point we had given the thing. The other second problem is the availability of neurotechnician, and sometimes this is even a bigger problem than availability of a neurologist. We always need a good neurotechnician in a case of continuous EEG, because in ICU is an environment that is full of artifacts. Unless you have a neurotechnician available there to troubleshoot it and get rid of the artifacts, all we get is a reading like that, full of rubbish, long reading, prolonged reading, full of rubbish without any useful information. The whole nursing team needs to be aware of the continuous EEG is going on. If they are not aware of that, what you get is this thing in the left, where it is full of artifacts. If they are like too much worried about touching a patient or continuing with the nursing care, then what you have is in the patient the right, that do the electrical burns. You also will land up with a big, if they are scared to do the nursing care, then you will end up having bed sores and all. The last problem that usually people ask is how much does it cost? Is it cost prohibitive? So from my experience, it's not cost prohibitive. It's cost anywhere between 10,000 to 25 to 30,000. So considering the grand scheme of things, the duration of stay, they stay in the hospital, and the utility, the necessity of EEG that is required in treating those patients, it is not a very big amount. Also, you can stratify it, because like this is what we do. We charge them by the hour. So somebody needs 6 hours and enough, and they'll be chargeless. And somebody, if they need for a longer time, you can charge them more. So to summarize, EEG, continuous EEG is actually an integral part of monitoring in any child who is sick in the brain. And it is more important in some cases than others, but you need to develop a team, you need to develop a protocol to have the full benefits of it. Right. Thank you.
Thank you, Dr. Akhtar. Very nice thing to hear that it can be done. It is a cornerstone of care in the neurocritical care to have a continuous EEG. But that interpretation, if cannot be done by the non-specialized persons attending the case, then in case of that, is there any scope of quantitative EEG? Can it be done there?
Ma'am, quantitative EEG is actually even more, it's not available at all in my experience. So it's even less available. The ones qualitative we still have, and with some training, I think with qualitative EEG, most of the units in India, what they do is they do the qualitative EEG, and the persons on the floor have some kind of training, and with a little bit of experience and a little bit of teaching, they're able to identify the patterns, and they're able to intervene based on that.
Because I heard that they can understand, even they are not very specialized, they can understand this what is not good, and they can call the neurophysiologic doctor, so like that. So thank you. So I was asking that it's very important to diagnose convulsive, non-convulsive seizures, subtle seizures which we cannot understand, and status epilepticus, convulsive status epilepticus. Thank you very much, Dr. Is there any question? Yes.
Can we have something of an alarm system which could boost up and set up an alarm that there's a convulsion going on, maybe, and
So that's a very novel idea, sir, but in the machines we have, none of the machines that I know have those kind of alarm. One thing that some people do, this is in one of the units I work, not in India, in UK, what we had is they have modified the whole machine, and they have made it much more easier. It's called CFAM, and it's much more easier for any people. This just gives us a pattern. You don't need to read the frequency, you don't need to read whatever is happening, but it gives very, very definite and very easy to identify patterns through which we can identify seizures, just to make it sure that whoever is available on the floor with the patient can identify the pattern and intervene at real time. But alarm, we are still.
You have already touched it. I mean, sort of this amplitude integrated or CFAM as well. That's what we have used in UK. The sort of amplitude integrated EEG. Yes. And then if you are a non-neurologist, it's much more easier. I've not seen it being used in India. Don't we have it in India?
No, so it's much more, I mean, in the units that I have been there, I have never seen, I have never heard of somebody using CFAM in India. It's a modified machine.
So no amplitude integrated stuff where you get a compressed stuff, no?
No, so not in the CFAM way that we used to use in UK. There is amplitude EEG that is a little bit different. That is also, I mean, that the one we use in neonatal unit. But CFAM that we used to use, that is a little bit different, sir.
I think amplitude EEG can be used in that multimodal monitoring, right? In PGI also we did it. And here also in the next door, they are showing that in the multimodal there is that amplitude EEG. So how do you differentiate between amplitude EEG in a monitor and that EEG which you usually do in that in a proper way with the two ability EEGs?
Sir, the raw EEG is a basic one. Based on the raw EEG algorithm only we have this amplitude EEGs. So the patterns are a little bit different, but I mean we are more used to seeing at least I am more used to seeing the raw EEG patterns. Even in CFAM machine you can go back and see whenever you have a doubt, you can go back to the original raw EEG and you can, the diagnosis, the criteria that is the standard criteria for non-convulsive seizures is basically on raw EEG. The amplitude EEG gives us some kind of indication that something is going on there, but ultimately I think we need to go back to the raw EEG itself to diagnose it with confirmation.
With multimodal EEGs, I think multimodal amplitude EEG, you can pick up those things early and then subsequently, because it's a continuous process, you just what need to do is
the number
just
of,
like
the number of channels are less. The one in the monitor that they were showing, the number of channels are much less. So it's unlikely. So if the seizure is going on, it's a frontal onset seizure, and you have the occipital electrodes, you're not going to get it. So that's kind of a screening that might help. It's better than to have nothing at all maybe, but ultimately the gold standard is still the 2020 system.
Thank you, Dr.
Thank you, ma'am. That brings us to the end of this session. I request the speakers and the chairperson to kindly move to the felicitation station. Our next session will be chaired by Dr. Prabhavati Banerjee, who is a former professor of pediatrics at Medical College, Kolkata. Our next talk will be delivered by Dr. Satyabrat Roy Chaudhary, who is an assistant professor and PICU in charge at IPGMR and HSKM Hospital. He will be speaking on predict before it happens. Can AI detect deterioration early?
Good evening to everybody. I am very much happy to see from the morning I am learning so many things. Actually, I saw the origin of this intensive care and we could understand the utility of intensive care. Now I can see the vibrant team of doctors and many of them, along with them I was there also. So now they are involved in this different types of these problems which we could realize but we could not see the effect. Really all of them are very dedicated. And from the morning, I can see there's so many problems like fluid overload, septic cardiomyopathy, ECMO, so many things. And now the topic is the most advancement which will really answer the non-answered part of those, that is the AI. Now, our Dr. Satyabrat Roy Chaudhary, who is known as Satya to us, and he is on that particular important subject, that is the prediction or early prediction of deterioration in the critical care unit, which may help by making the hands more stronger to this clinical team of critical care unit doctors. Now, Satyabrat, you
Thank you, madam. It is a privilege to talk under your chair. Good afternoon, everyone. So now, the most debated topic, that is AI to predict deteriorations early. Now, when I would like to give a declaration first that I am not using AI to predict deterioration. I don't have any personal experience. So when I got this topic, first thing that stuck in my mind was that, do we need to predict? And actually, if you remember the talk of the Ibor sir, all these things, this phenotype, this endotype, why do we need this thing? We want to identify the subset of the patients that will deteriorate. So predicting the patients who will deteriorate is a very important thing in our ICU. And a pediatrician will be very much happy if he knows or she knows that this patient will land in some deteriorations, so that she or he will be able to transfer that patient to a better care and possibly, if possible, in ICU. And next questions, are we not doing this thing without AI? Yes, we are actually always doing these things. And for that, we are using some of the scores like the early warning scores, the Apache 2, Apache 3s, all these scores are for this purpose. So knowingly or unknowingly, and with all this clinical monitoring, our nurses are sitting there the whole night and putting the vitals in their charts. And what they are seeing the deviations from the normals, and they are reporting, and all these things we are picking up and detecting the deteriorations. Now, but the system that is working actually requires lot of human resource, and it is not that efficient and it is slow. That is a problem. Now, that AI, it is the era of AI. Now, from the era of internet, we are entering the era of AI, and everywhere AI can be used. So, in this field, AI also has been used. And what has been found that AI tools like machine learning, logistic regression, neural network, support vectors, all these things have been attached to our electronic monitoring systems, and they find out the real-time parameters, lab parameters, clinical notes, analyze them, and they picked up the warning signs and reported. And what we found that this system is highly sensitive, specific, somewhat specific, and reduce false alarm and link to more rational allocation of the time. But from what studies? Most of these things were done from the retrospective data. Now, in our clinical field, we know if something new comes, it promises everything from the physiology or basic science. But we have to see actually in the clinical scenario it is working or not. And for that, only clinical trials and real prospective data can predict that. So I have done some literature search. And in my literature search, I have found lots of studies, and most of the studies are for development of these tools and on the retrospective data. I have found these 3 studies that are prospective and that worked on real patients, and this is the first one. This is single-centered study done in Australia. What they have done, this is done on adult population. They have they have compared the deterioration index plus, that is the AI tool, with between the flags, that is the traditional system. What they have done, in initial one year study, they used the traditional system, and next 1 year system, they have used the AI tool. Now, what do you mean by the between the flags? It is a Australian beach metaphor where the guide actually asks you to swim between the flags. That's a safe zone. So nurses are putting the vitals like heart rate, blood pressure, oxygen level, temperature. If something is deviating from the normals and entering the red zone, the nurse will hit the alarm. That is the between the flag system. And what is the deterioration index? That is AI tool that has been integrated in the electronic monitoring system. And it is actually crunching up 17 plus variables along with vital signs, lab results, and nursing inputs and medical history. And they are also initiating the alarm when they found it is critical. Now, what about the result? That it has been found that electronic deterioration system was found to be better discriminating between the patient who are stable and who will worse. And it was found that the between the flag system actually is very rigid, and it is always rising, always not, most a certain number of times they are rising false alarm. Now this second study, This second study is a multicentric study. This multicentric study involved almost, I think, they have 19 hospitals, and this ECART scored the electronic cardiac arrest risk triage. This is also an AI model that has been validated, and it actually pulls up 33 variables, including vital signs, laboratory trends, and other demographic variants. And in the phase 1, they have incorporated this AI tool in their electronic health record system, but it was blinded from the clinicians and the nurses. So clinicians and nurses were working under the traditional system, and they were getting alarm from the charts only. Now in the phase 2, they unblinded this system, and they incorporated this system into the mandatory work protocol. So what they found, this AI tool system was significant, with use of this AI tool system, mortality dropped significantly, faster ICU transfer, increased vigilance, and mortality drops among the average risk patients. That was very important, because this group of patients never activated any alarm in the traditional system, and this group of patients was picked up by the AI system. Now the third study. This study is also a multicentric study. They compared two groups of hospitals. One group of hospital was using the AI-based system, and another group of hospitals were using the traditional system. And there was something, they actually added a safety net to this thing. Like AI-based system, if the AI-based system is picking up more and more signals, and they are raising the false alarm, then the team will be overburdened. So they actually, AI-based system was not blinded from the treating nurses and the doctors. The AI-based system picked up the alarm, and they sent this alarm to a remote nurses, and they analyzed this thing clinically, and they found it valid. Then they informed the treating doctor and nurses. So with this, they found the drop of mortality in 16% drop of mortality. And they also able to prevent no massive influx in ICU overcrowding, because they apprehended that AI system is very sensitive, so they will pick up more warnings, and ICU will be flooded with the patients. So that part was addressed. Now there was this meta-analysis. This meta-analysis also included these previous 3 studies and also some prospective studies. And what they found out that after deploying the AI model in hospital, mortality and 30 days, in-hospital mortality and 30 days mortality were significantly reduced. Overall hospital stay decreased, and length of ICU stay increased significantly. That is very important, and there comes the limitations. So if we are using this AI-based system, these are sensitive systems, and they will they will also raise more alarms, and our ICUs, there is a chance of getting ICU flooded with the patients, and also the ICU stay may get prolonged. So what is the solution? The solution is the incorporating our clinical judgment along with the AI. It is not leaving everything on the AI. That may be a solution. Next limitation is that this the AI can reduce workload by automating risk assessment, but frequent alerts may lead to alarm fatigue and reduce trust in the systems. So the persons who are working under the AI, they have to be trained properly how to interpret these signals. Otherwise, this system will not work. So future scope of work. So all these things, with all this discussion, we can see this AI system has a very bright future, but we have some doubts and we have some limitations. So before going for recommendation, we have to test it with a proper RCT and long-term data. That thing is needed. Thank you.
Thank you, Satyabrato. You have really highlighted the role of AI, although it is not your beyond clinical experts and all, but still, if it is helpful for making you these things are less, loss of mortality is low, and also the ICU crowding is low. That is also a very good thing. So it will definitely help, and we have to wait and watch. Let us see how the AI is coming, still under study now. So you have done. Anybody, any question?
So actually we are not using these AI models, and only these AI models has been used in hospitals on an experimental purpose. If this perspective, it is mandatory for doing any prospective study to take the consent from the participants. I think they have taken this consent.
To answer your question, look, there are two ways of doing it. One is not AI driven, right? You know the risk factors, you know what you are doing. Okay? If it is AI, there is something called a black box effect of AI. So that means if the AI is stating that, yeah, you are high risk, there is no transparency. That means you cannot actually explain why the system thinks he is high risk. That is a problem. That is a problem of AI, that AI does not have, there is a black box effect. So AI can give you the decision, but you cannot explain why it is saying so. So you cannot really, all you can say is that system is saying that. One more thing is the legal responsibility still stays with you. You cannot say that I have done this because my AI system has said me to do so, and something wrong happens, it's the AI system responsible. It is always you who is responsible. So AI can guide you, then whether you actually override the AI decision or follow the AI decision is ultimately your responsibility. So the responsibility still remains with you.
See, ethical part is actually remain unexplored, because if someone is not listening to AI and that patient deteriorates, that also raises another ethical issue. So there are two types of ethical issues. That part has not been addressed because it is a very new thing to do. So I think in future it is also a research subject.
As of now, the current status is that you can never, the AI system or say the company which has developed the program, you cannot hold that company responsible. That is how it stands now. You are given AI is a tool. AI is a helping tool. Whether you use it or not is your discretion, and whatever is the consequence is also your responsibility. Not the responsibility of the AI or the company who is developing it.
So thank you.
Thank you for that very interesting session. We have another very interesting session coming up, which is the art of communication in PICU. Are we giving the carers the real choice? It will be delivered by Dr. Ritika Ghosh Dastidar, who is a consultant pediatric intensivist at Fortis Hospital, and Dr. Krishanu Mandal, who is a consultant pediatric intensivist at Mission Hospital, Durgapur. They will be joined by Dr. Nandini Sinha Roy as a role player.
So Dr. Ritika and Dr. Krishan. So both of you will, the first one, that is the art of communication in PICU. So it is a very difficult job, as you are working so hard, everybody in the critical care unit, but still you cannot satisfy the family party. It's very difficult to, so every moment of your care you need to have a communication with the family. So it is a very important thing, everyone, we are eagerly waiting to do. Okay, start.
Thank you. Good afternoon, everyone. Me and Dr. Krishanu, with the help of Dr. Nandini as the grieving, anxious parent,
now I'm the mother,
are going to try and demonstrate the art of communication in PICU, and are we giving carers an actual real choice? So an interactive role play and discussion. So why this matters? So communication is a core PICU intervention. It's as important as intubation. You can't not do proper communication and manage PICU patients. The decisions often involve uncertainty, risk, and emotion. Sometimes we ourselves are not very confident that what we are doing, how we are managing is actually ultimately going to save the patient, and you need to take the parent on board with that discussions. Families remember conversations long after clinical details. They will not remember the blood gas numbers. They will remember that their child is deteriorating. Consent is not communication. Communication is talking, making them understand. If they're agreeing, that's when consent comes into play. So we are going to try and do a role play. The scenario would be a 3-year-old child with severe pneumonia admitted in the PICU, is currently on high settings on high flow nasal cannula. The child is having worsening respiratory distress, and the PICU team and the PICU consultant decides that it's time for mechanical ventilation. Dr. Krishan.
Bed number 1 রোহিত বিশ্বাসের মা কে আছে? হ্যাঁ ডাক্তার বলুন। আপনি আছেন? আচ্ছা। দেখুন আপনার বাচ্চা আমাদের কাল থেকে আমরা চিকিৎসা করছি, কিন্তু এখনো সেরকম চিকিৎসায় রেসপন্ড কিছু করেনি, অক্সিজেনের মাত্রা কমে যাচ্ছে, তো আমাদের কিন্তু বাচ্চাকে ভেন্টিলেশনের মধ্যে দিতে হবে।
স্যার ও তো কাল কথা বললো আমার সঙ্গে।
সেটা কিন্তু আমরা যে চিকিৎসা করলাম, এখন আমরা যেটা দেখছি অক্সিজেনের মাত্রা খুব কমে গেছে, ভেন্টিলেশনে না দিলে কিন্তু আমরা বাচ্চাকে বাঁচাতে পারবো না।
স্যার আমি কি করব?
এখন আপনাদের যে জিনিসটা করতে হবে, আপনি কনসেন্ট দিতে হবে, অর্থাৎ আপনাকে অনুমতি দিতে হবে যে আমরা বাচ্চাকে ভেন্টিলেশনে দেব। সময় নষ্ট না করে আপনি তাতে অনুমতিটা দিন।
স্যার একটু সময় দিন, বাড়িতে একটু কথা বলতে হবে আমার।
বাড়িতে আপনি কথা বলতে পারেন, কিন্তু প্লিজ
বাবা আসছে।
হ্যাঁ, আপনি বেশি সময় নেবেন না, কারণ বাচ্চার অবস্থা কিন্তু ধীরে ধীরে আরও খারাপ হয়ে যাচ্ছে। ভেন্টিলেশনে না দিলে কিন্তু এই বাচ্চাকে আমরা বাঁচাতে পারবো না। সুতরাং আপনি যত তাড়াতাড়ি সম্ভব আমাদের সম্মতিটা দিন।
স্যার তাহলে কি বলেন আপনি, কি করব?
দেখুন, ভেন্টিলেশনে দিলেই যে বাচ্চা বেঁচে যাবে এরকম কোনো ব্যাপার নেই। ভেন্টিলেশনের অনেক রকম অসুবিধা আছে। অনেক সময় কি হয়, ভেন্টিলেশন থেকে ইনফেকশন হয়ে যায়, ভেন্টিলেশন থেকে বাচ্চা অনেক সময় ফেরেও না। কিন্তু এখন আমাদের কিচ্ছু করার নেই। আমাদের যে জিনিসটা দরকার সেটা হচ্ছে ভেন্টিলেশনের দেওয়া, কিন্তু এছাড়া আমাদের কাছে আর কোনো উপায় নেই।
বাড়ি নিয়ে যেতে পারবো তো?
বাড়ি নিয়ে যেতে পারবেন কি না পারবেন সেটাও আমি বলতে পারছি না, কিন্তু আপনি তাড়াতাড়ি প্লিজ এখন সময় নষ্ট না করে আমাকে বেশি সময় নষ্ট না করে আমাকে সম্মতি দিন, আমি যাতে তাড়াতাড়ি বাচ্চাকে ভেন্টিলেশনের মধ্যে দিতে পারি।
স্যার ভয় কিছু নেই তো?
ভয়ের কারণ আছে, কিন্তু যত তাড়াতাড়ি সম্ভব আপনি দিন, ভেন্টিলেশন আমরা দিই, তারপর আপনাকে আমি বলতে পারবো।
স্যার বাড়ির সবাই আসছে, একটু ডেকে নিই সবাইকে তাহলে একটু।
ঠিক আছে, বাড়ির সবাইকে রাখুন, কিন্তু তাড়াতাড়ি করুন, তাড়াতাড়ি করুন প্লিজ। এটা আমি
স্যার প্লিজ দেখবেন স্যার, আমি কিছু বুঝতে পারছি না।
ঠিক আছে, আপনি তাড়াতাড়ি করুন। ঠিক আছে, ওকে।
Just one point, Dr. Krishanu, you have said everything in a negative way. You have to say something in a positive way also.
So what was wrong with this communication? One.
Yeah.
So potentially everything was wrong. So too many things that we need to work on this communication. Medical jargon. The parent doesn't understand what a ventilator does, what is HFNC, what is worsening respiratory distress. They don't understand all of that. You need to come down to the level of the patient's understanding, the parent's understanding. Standing, hurried. 10 patients waiting in the OPD. We need to hurry. We have seen the patient, we have done our rounds, we have made our decisions. We don't have time to communicate with the parent. Not doing it standing. Come down to the patient's level. Sit down. Sign this consent. We have decided it's going to be ventilation. You sign and then I'm done. You decide. A parent does not have enough information to decide whether their child needs mechanical ventilation or not. No empathy or recommendation. We are talking about a child, a person's child. So a certain amount of empathy has to be there. And we as experts, we can recommend things that will be beneficial for their child. They don't have the necessary training, expertise or information. So potentially everything about that communication was not quite right. Did the parent receive adequate information? No. Did we check the parent's understanding? Did they actually get the gravity of the situation? No. And did we actually give a real choice? The parent might decide not to ventilate the child. We have to respect that. The child is still not there where the child is arresting, and we need to do something in the best interest. So are we giving a real choice? So PICU or ICU per se historically has been very paternalistic. We decide, the doctor decides, and we entrust that decision on the parent. Informative, the parent decides. But do they have enough information? Do they have enough training, enough expertise? Potentially not. So now we have moved on to shared decision. We decide together. We have the doctor's expertise, we have the emotional quotient of the parent, and we make a decision together. So paternalism, informed choice, and now shared decision making. Model PICU aims for partnership between clinicians and families. We decide together. It's your child as much as mine. So we need to make a joint decision in the best interest. So a typical PIC conversation is, what would you like us to do? This is the situation, what do you think we should do? The parent doesn't know what they need to do. They need to be given that information. They need to be helped in making that choice. So are they really choosing or just interpreting our recommendation? What do parents really want? They want honest information. If you feel like this child is going to die regardless, you need to tell them to the parents that no matter what we do, we might not be able to save this child. Hope without false reassurance. If you feel like there is still hope in what you're doing and this child can still recover from their current situation, you let them know. But don't falsely reassure, let's go on the ventilator and in 5 days your child will be walking out of the PICU. They need guidance. The commonest question is, what should I do? You need to guide them properly. Professional recommendation, you are the expert, so you know what is best for the child, and you need to give them the recommendation, not entrust your decision on the parent. Show them compassion. It's their child. If that child dies, their life changes. It's just another patient for you. So give that 10 minutes, turn off your phones, sit down in a room and have that conversation. Consistent messaging, extremely important. You say something after your morning rounds, and then your registrar or your resident comes in and says something different. Or a consultant that you had referred to comes in and says a third thing. So differential messaging plays havoc in the minds of the parents. Common pitfalls, excessive medical jargon. They don't understand ventilator settings. They don't understand blood gases. You have to talk to them in layman terms. Information overload, your blood numbers are this and this and this. They don't register any of it. They just want to know whether it's improving or whether that's worsening. Inconsistent team messaging, your nurses are there in the bedside all the time. So they should be aware what you're messaging the parents. They should be on board. They should have their understanding as well. And assuming all parents want the same level of involvement. Surprisingly, some parents don't want to make that decision at all. They don't want to be involved. Maybe they don't have that understanding. They're very poor, they're farmers, they're selling their land and coming to you. And some parents are probably doctors. So you have to understand their level of understanding and then make sure that you are offering them that choice to be involved. So there are a couple frameworks that actually exist in terms of communication. One is CARE, connect with the parents, assess their understanding, what they are actually getting from what you're saying, give your recommendation and also empathize. And the SPICK's framework, sitting down in a closed space without any interruptions, perception, perceiving what the parent is actually asking from you, invitation, listening to them, asking them to comment what they are thinking, knowledge, do they actually have the adequate knowledge needed to make that decision, show them empathy, if they are crying, wait, give them a tissue, and summary and strategize the next plans. Common PICU questions, is there any risk? Can we wait? Will my child survive? All very valid questions if you see from the lookout of the parent. But sometimes we hurry on these points and we just go on with our decision. What would you do for your own child? Extremely important. What would you do if it was your child in the PICU? So it's important that you take that as the most important factor into play. Forget about the cost. Forget about whether it's a government setting, it's a corporate setting. You don't worry about the money. You just initially do what is right for the child. You let the parents know, this is the test that we need. It's expensive, but I would do it for my own child. They will get how important it is. Suggested responses. So ventilation has risks, but I'm worried about the risk of waiting. You can't say, I'm going to put your child on the ventilator right now. I believe this gives your child the best chance and I recommend it. This stays with the parents. The wordings are extremely important. So, shall we retry this communication? Same treatment, same patient, and trying it in a different way. Dr. Krishanu. We should also not ask the parent to bring the chairs.
We have not started yet. We have not started yet.
আপনি হ্যাঁ আচ্ছা আপনি কি রোহিতের মা? আমাদের সঙ্গে যে পেশেন্ট আছে, একটু আসুন, আপনার সঙ্গে একটু কথা বলার ছিল, আপনি বসুন। দেখুন, রোহিত কালকে রাত্রে আমাদের হাসপাতালে ভর্তি হয়েছে, ঠিক আছে। তারপর থেকে ওর যে শ্বাসকষ্ট ছিল সেই জন্য আমরা অক্সিজেন এবং HFNC বলে একটা মেশিন দিয়ে ওর চিকিৎসা করছিলাম, বুঝতে পেরেছেন। কিন্তু তা সত্ত্বেও ওভারনাইট আমাদের 12 ঘন্টার চিকিৎসা সত্ত্বেও ওর শ্বাসকষ্ট কিন্তু কমেনি, ওর অক্সিজেনের যে রিকোয়ারমেন্ট আছে সেগুলো অনেক বেড়ে গেছে, ঠিক আছে। অর্থাৎ আমরা বলতে পারি ওর কন্ডিশন আমাদের চিকিৎসা সত্ত্বেও অনেকটা ডিটেরিয়েট করেছে বা অনেকটা খারাপ হয়েছে।
অবস্থা কি খুব খারাপ মনে হচ্ছে?
অবস্থাটা আগের থেকে একটু খারাপ, বাট ফরচুনেটলি আমাদের কাছে আরও উন্নত থেরাপি আছে এই কন্ডিশনটাকে মিটিগেট করবার জন্য, বুঝতে পেরেছেন। বাচ্চার যে শ্বাসকষ্ট হচ্ছে, অক্সিজেনের মাত্রা কমে যাচ্ছে, সেই জন্য ভেন্টিলেশন বলে একটা মেশিন আছে আমাদের কাছে, ঠিক আছে। সেই ভেন্টিলেশনের মাধ্যমে আমরা বাচ্চার শ্বাসকষ্ট এবং বাচ্চার যে অক্সিজেনের প্রয়োজন হচ্ছে সেগুলো কমাতে পারি। তো আমার মনে হয় এই মুহূর্তে আমার যে রেকমেন্ডেশন হবে, বাচ্চার চিকিৎসার জন্য ভেন্টিলেশন আমরা ইউজ করব।
আমার বাচ্চাকে মেশিনে দিতে হবে?
ভেন্টিলেশন মেশিন বাচ্চার শ্বাসকষ্ট কমানোর একটা মেশিন, বুঝতে পেরেছেন। এই যে বাচ্চার শ্বাসকষ্ট হচ্ছে, অক্সিজেনের প্রয়োজন হচ্ছে, আমরা আরও ছোট মেশিন দিয়ে প্রথমে চেষ্টা করলাম, কিন্তু আনফর্চুনেটলি আমরা রেসপন্স পাচ্ছি না। সেই জন্য একটু বড় মেশিন, ভেন্টিলেশন মেশিন,
ভয় নেই তো,
যেটার মাধ্যমে আমরা বাচ্চাকে নিঃশ্বাস দেবো এবং বাচ্চার যে শ্বাসকষ্টের যে কষ্ট সেটা ভেন্টিলেশনের মাধ্যমে অনেকটাই কমাতে পারবো।
আরাম পাবে তো?
অবশ্যই আরাম পাবে, ঠিক আছে। বাচ্চা যাতে সুস্থ হয়, বাচ্চার যাতে শ্বাসকষ্ট কমে, অক্সিজেনের পরিমাণ যাতে কমে, সেই জন্যই আমরা ভেন্টিলেশন মেশিন ব্যবহার করছি। আপনার যে প্রশ্ন যে কোনো ভয়ের কারণ নেই বা ভেন্টিলেশনে কোনো রিস্ক আছে কিনা, দেখুন রিস্ক যে কোনো মেডিকেল প্রসিডিউরের মধ্যে থাকে, কিন্তু এই মুহূর্তে যেটা আপনার বাচ্চার জন্য সবচেয়ে ভালো সেটাই আমার রেকমেন্ড।
কতখানি কীরকম রিস্ক স্যার?
ভেন্টিলেশন থেকে যে সমস্ত রিস্ক, ইনফেকশন ইত্যাদি আছে রিস্ক, কিন্তু সবচেয়ে ইম্পর্টেন্ট ব্যাপার যেটা আপনাকে মনে রাখতে হবে যে এই মুহূর্তে রিস্কের থেকে বেনিফিট অনেক বেশি।
আর কোনো উপায় নেই স্যার?
আর কোনো উপায় থাকলে সেটা আমি আপনাকে বলতাম, ঠিক আছে। এই উপায়টা আমার মতে এখন সবচেয়ে বেশি হাইলি রেকমেন্ডেড, ঠিক আছে।
স্যার আপনি কি করতেন?
এটা আমি হলে অবশ্যই আমার বাচ্চা, আমার পরিবারের বাচ্চা যদি এই অবস্থায় থাকতো, অবশ্যই ভেন্টিলেশন আমি কনসিডার করতাম।
আপনি কি বলেন তাহলে এটাই করা ভালো?
অবশ্যই, এটা আমার মেডিকেল নলেজ অনুযায়ী এবং বাচ্চার কন্ডিশন অনুযায়ী এই মুহূর্তে ভেন্টিলেশন উইল বি দ্য বেস্ট থিং ফর ইউ।
স্যার আমি তখন একা আছি, বাড়ির সব আসছে,
অবশ্যই
একটু টাইম দেবেন স্যার?
অবশ্যই, বাড়ির সমস্ত লোকের সঙ্গে আমরা ডিসকাস করব অ্যান্ড দেন আমরা আমাদের কাজ করব। ওকে
স্যার, বাড়ি নিয়ে যেতে পারবো তো?
দেখুন, ভয়ের কারণ অবশ্যই থাকবে, ঠিক আছে, এবং দুশ্চিন্তা অবশ্যই থাকবে। মা হিসেবে আপনার দুশ্চিন্তা আমি বুঝতে পারছি, ঠিক আছে, কিন্তু মনে রাখতে হবে যে আমরা আমাদের 100% অবশ্যই দেবো।
হ্যাঁ স্যার, একটু দেখুন ভালো করে স্যার।
100% অবশ্যই দেবো এবং ভেন্টিলেশন যেটা দরকার হয় সবচেয়ে বেশি রিকোয়ার্ড সেটা করব। আমাদের টিম 100% আপনার সাথে থাকবে এবং আমরা প্রতি মুহূর্তে আপনাকে সকাল সন্ধ্যে প্রতি মুহূর্তে 6 ঘন্টা ছাড়া আপনাকে আমরা পেশেন্টের কন্ডিশন সম্পর্কে জানাতে থাকবো, বুঝতে পেরেছেন।
ধন্যবাদ স্যার, ধন্যবাদ, অনেক ধন্যবাদ।
ঠিক আছে, আপনাদের ফ্যামিলির লোককে আপনারা ডাকুন, আমরা তাদের সাথেও কথা বলবো। দেন উই হ্যাভ টু ডু সাম পেপার ওয়ার্ক।
আমি আসলেই কথা বলছি, এসে নিয়ে এসে।
ধন্যবাদ,
ধন্যবাদ, ধন্যবাদ। আচ্ছা,
নাইস।
6 ঘন্টা কি প্রতি ঘন্টায় বলবে?
ডাক্তারবাবু আরো ভালো।
So just to summarize, this was actually a much better communication. To quickly touch and conclude this session, we have already gone through these choices in the ethical discussion that we had a few sessions back. So where families can have genuine choices: tracheostomy, home ventilation, time-limited treatment trials, palliative care pathways, and organ donation discussions. So communication pearls, take-home messages: sit down, avoid jargon, pause, allow emotions, check understanding, and summarize the plan. Evidence supporting shared decision making. There's better family satisfaction, improved understanding, reduced decision regret. You don't want parents to say we want withdrawal of support and then regret the decision later. And improved bereavement outcomes. So practical tips for PICU teams is: ask how involved families wish to be, check understanding frequently, acknowledge emotions explicitly, and revisit decisions over time. So take-home message is parents do not want to carry the burden alone. You need to be there with the parents, support them all throughout their PICU journey. If the child does not survive, you need to be by their side when the child dies. Real choice means sharing decisions, not abandoning families. Thank you very much.
We don't need questions, we need your suggestion. We need ma'am's suggestions for this communication.
Although definitely the next one is communication, what you have done. Definitely both for you. The party is also convinced with your counseling. So this is very important. That whether party is convinced or not, that every point of your care is being taken by this communication. And so communication skill is very important here. Very good. So you have done it very nicely.
Ask whether he can understand your language, because sometimes you speak in that one language,
very common.
So
the language is whether he or she could understand the language, which language he could understand.
Yes.
Then only the communication will be.
I think, ma'am, there is no general rule. We have to follow whatever.
According to
every situation is completely different. I
completely
think.
different.
We cannot follow
And
a protocol, especially in Indian patients.
Yes. Every parents are of different type.
Yes.
And the most thing is that your patients, because so much irritating questions they will ask you, but you have to keep your patience every moment. That is important.
Thank you,
okay,
ma'am.
thank you.
Thank you.
Very nice.
Thank you.
Language part actually we discussed off stage. We decided whether to speak in English or Hindi or Bengali. So we decided Bengali as the informed language.
And give a big hand to Nandini for being a good mother.
Thank you, ma'am. That brings us to the end of this session. I'll request the speakers and the chairperson to withdraw. We'll be having a panel discussion now on antimicrobial resistance, bedside strategies and stewardship. The chairperson for this session will be Dr. Santosh Agarwal, who is a senior consultant pediatrician and nodal officer representing the RCPCH in Eastern India, and Dr. Jaideep Chaudhary, who is a professor of pediatrics at Institute of Child Health. This panel discussion will be moderated by Dr. Manideepa Datta, who is a consultant pediatric intensivist at Manipal Hospital, Mukundapur. Panelists include Dr. Madhuha Zainab, Dr. Sushil Kumar Pathak, Dr. Pragati Datta, and Dr. Shantan Mandal.
So, good evening.
Good afternoon, everyone. Thanks to the organizers for having us here. Now we are going to change gears and we are going to come to a very important topic of antimicrobial resistance, bedside strategies, by no other than Manideepa. This is a problem that we have in office practice as well as in hospital practice. So let's hear from her.
Thank you, sir. This is the last session of the day. So I am talking about we are going to discuss about the antimicrobial resistance, which is just not the need of the hour. It is the main concern whenever we are, most of the time is the main concern whenever we are treating these sick patients, because most of the patients, this is the main cause of PICU admissions or a long PICU stay is the infection. So as the name suggests, it is the resistant to the antimicrobial, different antimicrobes, and mostly it is multi-drug resistance, and it is the natural process. It's not just that we are using antibiotic and people, the organism is getting resistant. It is the natural process which has happened, and by several mechanisms they will acquire the resistant gene or resistant pathogenesis. So this is as I have always said, this is the future, not the future. This is the threat, and this is the most concerning, that around 2050, more than 10 million people across the globe could be dying per year because of this antimicrobial resistance. And these are the various mechanisms which can give rise to this resistance to our organism. And starting from the entry of the drug, then the increasing the efflux of the drug, and there are various mechanisms when the organism can modify the target so that the antibiotic which was previously acting on this organism cannot act anymore. And there are also biofilm formation, this is which is the physical barrier. And these are the type of resistance, so these are the intrinsic, acquired and adaptive. Intrinsic means some of the microorganisms are inherently resistant to some of the antibiotics. So before choosing the antibiotic, we should suspect what is my organisms, or if the culture is available. So we should not choose that antibiotic for treating a gram-negative organism. We usually do not do, but it is the basic of this choosing while we are choosing the antibiotic, because the vancomycin, because of this permeability barrier, the gram-negative will not be susceptible to your vancomycin. Like similarly, when we are treating an Enterococcus species, because of the low affinity due to various mechanisms, they are not susceptible to cephalosporin or clindamycin. So whenever you are treating any organism, try to think of this, why my organism is resistant to this specific drug, whether it is an intrinsic or some acquired resistance. Now coming to the acquired resistance, this is the various mechanisms, mostly the genetic material transfer. It can be spontaneous chromosomal mutations, or it can be like as I have that's depicted in the picture. These are various mechanisms of where the horizontal gene transfer can happen, and this is more concerning in our PICU context, because in PICU from one patient the organism get transferred to other, and similarly the antimicrobial resistance can be transferred from patient to patient. So with this basic background knowledge, we now shift what is the resistance organism. We can classify these organisms in various groups depending on the pattern of resistance. So my question to Dr. Madhiha, so as it has been, this is the MDR, XDR, we use this term very lightly. What is the actual definitions of this MDR, XDR or PANDR?
Thank you, ma'am. So based on the in vitro susceptibility of the organisms, we have MDR organisms. So there are different groups of antibiotics. So non-susceptibility to at least one agent in 3 or more of these antimicrobial categories, that will categorize as a MDR. XDR is the non-susceptibility to at least one agent in all but 2 or fewer antimicrobial categories. Like all the antimicrobial categories, one of them is resistant except 2 or less. And PANDR or pan-drug resistant organism, these are non-susceptible to all agents in all antimicrobial categories tested.
Yes, that is the broad classification, but we are all very much concerned whether when we are came across a PANDR or extensively drug resistant organism, so we have to decide how to deal with this. So why in PICU the MDR crisis is there? Because there are a lot of factors acting in the PICU children. They have invasive device. We use the antibiotics empirically. Most of the time out of pressure we use 1, 2 or maybe 3 antibiotics without any justifications. Our PICU patients there as physiology. The normal physiology is most of the case is not present. Their physiologies get altered. And the in vitro susceptibility may not be reflected in vivo, because there is a lot of reaction inside the patients, the bug, the drug and the compartment, where is the infection, that we have to consider. So, and this is the most critical or high priority threats. WHO has already declared this organism, this is the escape organisms. This should be dealt with most like situations, so that we cannot take it as likely. And what are the escape organisms? These are these 6 groups, that is the Enterococci species, the Staphylococcus aureus, mostly the methicillin resistant, but the methicillin sensitive can be sometimes problematic, and the Klebsiella, the carbapenem resistant one, The Acinetobacter, which is again carbapenem resistant Acinetobacter, which is comes under this MDR. The difficult to treat Pseudomonas aeruginosa and the Enterobacter species. This is the extended spectrum beta-lactamase producing and the AMC producing. So how do I escape from this escape? This is my concern. So my question to Dr. Pragati, other than this resistant mechanism, is there anything, as I have already said, there is other factors, is there anything you are concerned about? So when you are treating with choosing antibiotics?
Yes. For critically ill patients in PICU, we should keep in mind that pharmacodynamics and pharmacokinetics of the drugs, because in our critically ill children, most of the patients have huge capillary leak leading to fluid shifting from the intravascular to the interstitial space, and then we do large volume fluid resuscitation for the patient, and many of the patients require CRRT and ECMO. So this cause massive fluid shifting. So they increase the volume of distribution of the drugs in the patients. So our hydrophilic drugs we commonly use, like our beta-lactams, become severely diluted. So the concentration or the dose we use becomes subtherapeutic for the patient. And also another concept which is extrapolated from the adult critical care, that is the augmented renal clearance. In hyperinflammatory state, what happens? In the beginning, there is increase in cardiac output and increase in renal blood flow. So the drugs which are renally eliminated, they become rapidly renally eliminated, they have a rapid elimination. So again, the dosage we give becomes subtherapeutic for the patients. So this concept is, again, we can apply in our pediatric patients also, because the pathophysiology remains the same. And also the PICU patients suffer from AKI, many of our patients, so we need to do careful dose titration to prevent toxicity.
Yes, absolutely right. There's a volume of distributions. It's a huge in case of a sick children, and whenever we are resuscitating them with a large volume of fluids and there is capillary leak, we should consider that the drug, the dose calculated as per the body weight may not be sufficient to clear of your infections. And also we are always concerned about AKI. We adjust the dose whenever we are having AKI, but the opposite also happens. There's an augmented renal clearance, and if it is said in adults, if it is the EGFR is more than 130 ml per kg per meter square per minute, the patient is in augmented renal clearance. And that's why the surviving sepsis guideline says you give the prolonged infusion and may give continuous infusion as well to combat that augmented renal clearance. So another point is what compartment is infection is, whether it is in the lungs, primary compartment, maybe the infection in the lungs or the CNS or the urine, and accordingly you have to choose your antibiotics, like any drugs which can be good for pneumonia may not be good for the CNS infection, because this cannot penetrate the blood-brain barrier, or same for the urine, that may not concentrate it in the urine. So with this, so we have lots of choice, but we are confused with all these things. So let's clear some confusions with some real case-based scenario. With based on these 6 organisms, I want to clarify what we can choose, how we can choose according, not just the culture report, not just empirical way. Nowadays, with the molecular multiplex PCR, we can detect the organism very rapidly. Also, the gene responsible for resistance we can detect, and also whenever we are dealing with these organisms, we should consider the pharmacology point of view along with the culture report. The culture report always help, but before that there are lots of factors, and most of the time now it is widely available, and also the other things we always think of cost, but the cost, you can think of waiting for the culture report for 3 days to choose your antibiotics, and if multiplex PCR within 12 hours, how much cost you cut down if you choose a proper antibiotic. So these are the case, and I have just focused about the escape organisms. for this presentation. So this is the first case, a 5-year-old boy with severe traumatic brain injury, intubated for poor GCS, had minimal ventilatory requirement as the lungs were healthy. The MRI brain was suggestive of diffuse axonal injury. The initial blood investigation were unremarkable. The patient was put on neuroprotective measures, but the patient developed fever on day 4 of ventilations. Ventilatory requirement increased, so inflammatory markers high. So definitely my patient is having ventilator-associated pneumonia. From the criteria of that, we can classify this as ventilator-associated pneumonia. We have sent all the culture along with the minimal assessment, and this came gram-negative, shows there is a few GNB, and culture from the lab, there's a microbiologist calls you and says there is a growth of gram-negative bacilli. So anything would you like to know from the microbiologist, just from the initial information that there's a growth of gram-negative bacilli? Dr. Sushil Kumar.
Yes, so once you know that it is gram-negative bacteria, so from microbiology days we are reading that first simple things you can ask that whether it is lactose fermenter or not. That can be done with McConkey agar. If it is pink, then it is a lactose fermenter. So, and if it is colorless, then it is non-lactose fermenter. So, purpose is that lactose fermenters are the simple Enterobacteriaceae bacteria like E. coli, Klebsiella, and Enterobacter. They are easy to treat. But on the other hand, the non-lactose fermenters are difficult one, that may be nightmare. So Pseudomonas, Acinetobacter, Stenotrophomonas. So these bugs are a red flag for the ICU. So these things, first we have to come to this know.
So before getting the proper culture report, you have got some idea, and this, though these are multi-drug resistant, nowadays these are all multi-drug resistant, the E. coli, Klebsiella, Enterobacter, but compared to non-lactose fermenter, they are easier to treat. So our microbiologist says it is lactose fermenter. So our diagnosis come down the most common lactose fermenter in the PICU in Indian scenario is this 3. So we have also sent the lower respiratory pneumonia panel, and which shows the growth of, so we detected Klebsiella pneumoniae with a count of 10 to the power 6, and antimicrobial resistance gene detected is the KPC and NDM. So, Dr. Madhya, what is the interpretation of this report?
So this lower respiratory panel is showing Klebsiella, and the importance of gene detection lies here. So it's showing KPC and NDM. So both these genes are carbapenemase producing genes. So this Klebsiella is basically resistant to carbapenem. This is carbapenem resistant Enterobacteriaceae. So the carbapenemases, we have different, they are serine carbapenemases and MBLs, the metallo-beta lactamase. In metallo-beta lactamase, we have the NDM. In India, NDM is very much predominant, and it belongs to the classification by Ambler class B. And the KPC, the gene that belongs to your Ambler class A. The difference between these two is basically these are the serine residues which prevent the hydrolysis of your beta-lactams, the carbapenemase enzyme. So NDM bugs, the moment we get NDM in our biofire report, we have to treat it differently from normal drugs.
Sure, that can be dealt later on. The enzymatic destruction, the significance, what is the significance of the KPC plus NDM? If we detect both, what is the significance, Dr. Pragati? Can you just highlight?
Yeah. So as previously mentioned, KPC is a Ambler class A enzyme and NDM is class D enzyme, class B enzyme. So the difference lies that the NDM enzymes cleaves almost all beta-lactams like your penicillin, cephalosporins, even our carbapenems. So if we only, if we treat the both are present and we are giving only your beta-lactamase inhibitor, so that will not work. So we should give, the antibiotic we should choose that antibiotic should not be able to hydrolyze your MBLs. So the catch is the organisms not only produce MBLs alone, they always co-produce some ESBLs or KPC which will destroy your Astrionum, like your monobactam. So if you only give Astrionum, they will not act. So we give only a beta-lactamase inhibitor plus Astrionum together to utilize, to counter against these organisms. So our solution is here to administer the ceftazidime avibactam and simultaneously with aztreonam, because as I said, the avibactam here will neutralize your KPC or ESBLs, and then the NDM, then the aztreonam will act against the aztreonam. So it is a simultaneous action against both the of the avibactam component and the aztreonam component.
So this is the absolutely right. This is the absolute synergy, and we should use this two drug in a Y channel in simultaneously, not one after another, to get this energy right. So nowadays also the aztreonam avibactam is available, but it is not till now it is not recommended for children. Now this combination has been recommended for children currently, the ceftazidime avibactam and aztreonam. So why not polymyxin? Dr. Shantanu, previously we used to treat with colistin, or so we have always used this.
So the problem with the polymyxins lies in the pharmacokinetics and the pharmacodynamics of the drug. As we all know, they are already very highly toxic, and the main issue is with their penetration. So for a pneumonia, the drug should be more in the distributed more in the lungs, but as their molecular size is very massive, there is very poor penetration into the pulmonary parenchyma and also in the film around the alveoli. So there is the main problem, and also regarding the toxicity, there actually the standard dosages are already in the near the toxicity thresholds. So as they are in a very narrow therapeutic window, that we also have to keep in mind regarding their nephrotoxicity, the neurotoxicity of those while treating those patients. As the PICU patients are already admitted, they might be already complicated with compromised renal functionings.
Yes, absolutely. So this is not the choice anymore. So we rarely use colistin nowadays. Now coming to the second case, it is a post-surgical case. As he was started on TPN as he cannot be fed for a few days. So there was kept NPN, and there is a central line placed for continuing the TPN, and day 3 there is a high grade fever. Patient is already on post-surgical antibiotics, so that is a routine antibiotics we use after any surgery, abdominal surgery. So what are the possibilities, Dr. Sushil?
So there is post-operative fever, so usually within 48 hours of, so with high TLC and CRP and calcitonin, so new onset of infection means hospital-acquired infection is there.
So these are the possibilities, and if considering these possibilities, which antibiotic do you choose? How do you decide?
So this basically depends on every hospital and every PICU has their own antibiogram, they have their bugs. So first thing, you have to see what bug is in your ICU and what antibiotic the bugs are sensitive to. Second, the situation in which your patient is, whether it is in shock or what else. Means what I want to say that the clinical status at that time. These two things are important. Based on that, you will decide the antibiotic.
Definitely. And whether you consider any gram-positive coverage, though it is we are considering as a hospital-acquired infections, though whether you consider any gram-positive coverage?
There is a central venous line is there, so possibility of
possibly
gram-positive. So
we like to add some gram-positive. So the patient has been, antibiotic has been upgraded to meropenem and teicoplanin. So blood culture, there is a growth of gram-negative bacilli, again sensitivity pending. Also here again we have sent the blood culture, the multiplex PCR panel, BCID panel. So organism detected is Klebsiella, and here again this gene is CTXM. And what is the interpretation, Dr. Madhya?
Again here the importance of gene detection lies. The Klebsiella, now this gene is CTXM. This is basically your ESBL-E gene. So these are produced by Klebsiella and it belongs to your amylo classification A. So basically they are extended spectrum beta-lactamase inhibitor. So they will it will be resistant to your penicillin, the 3rd generation cephalosporin, as well as monobactam. So there lies the importance of this gene detection to decide our antibiotics. However, this ESBL-E, they are sensitive to BL-BLI combinations, they are sensitive to carbapenems, these drugs, if this enzyme is present, they usually do not inactivate non-beta lactams like fluoroquinolones and trimethoprim sulfamethoxam. However, they sometimes do produce certain genes which may cause some resistance to these drugs as well.
So what are the treatment options? This is the BLBLI. We can use, very well use BLBLI, carbapenem, the trimethoprim sulfamethoxam, ciprofloxacin, levofloxacin, and obviously the newer beta-lactam is inhibitor combination, and cephalosporin if their organism is, it is a very severe infections and all this fails, but this drug is not available with us till now. We should, for us very severe infections, we should, you can consider this newer BLBLI. So how to choose between them, Dr. Shantan?
So it depends. It depends on the status of the patient, and also the decision can be made on a case-by-case basis. There was a trial, like the Merino trial, which has been published in the JAMA. So this slide, this shows that if the patient, it is very severe, immunocompromised state, we can go for the carbapenems like the meropenem. The previous slide, please. And if it is not so severe, the patient, the previous slide, please.
Sorry, sir.
So it's not so severe and the patient is immunocompetent enough, then BLBLI combinations may be easily used. So it depends on the situation.
So this chart, as we can see, this is depends on the Merino trial. They have used both of the drugs in various conditions, and they come to the conclusion, if your patient is having mild to moderate infections and UTI, that is the non-complicated UTI, or maybe with some complication, we can use piperacillin tazobactam. If there is severe infection other than UTI caused by ESBL, is better to use your carbapenem. That is also the ITSA recommendation is that, and Merino trial also supports this. So as I have mentioned, the newer BLBLI combination can be used in case of, this is a reserved drug, in case of treating infections caused by carbapenem resistance. So we are coming to a third case. This is again a 10-year-old boy with a severe RTA resulted in open skull fracture. He is being ventilated since admission on day 12 of PICU. In between he has gone to some neurosurgical intervention, EVD in situ, and there has been, as a CNS is the main focus, so we have started put antibiotic like ceftriaxone, amikacin, but patients is having a new onset fever, convulsion, and you check the CSF from the EVD, it is cloudy. So definitely patient is having ventriculitis or meningitis, so we have upgraded our antibiotics to meropenem and vancomycin, and before that we have whatever the CSF we have collected, we sent for investigations, and the report came the cells is pretty high with a neutrophilic predominance, protein is high, glucose low, and the culture microbiology lab informed you there is a growth of gram-negative bacilli. And we also sent the CSF encephalitis panel. This is detected Acinetobacter baumannii, and the gene detected here is the OXA23. So OXA genes are most common in the Acinetobacter. So what is the interpretation, Dr. Pragati?
So presence of OXA23, which is an amber class D carbapenems, it denotes that this Acinetobacter is carbapenem resistant. So we have this, we have already started the patient on meropenem, so we have to change the meropenem.
Yes, your OXA23 positive patient will not, meropenem will not act definitely, so we have to change. So any other mechanism of carbapenem resistance in case of Acinetobacter other than gene?
Yeah, there are basically two mechanisms for this resistance. One is your, it basically acts on the efflux pump. So this will try to efflux all the antibiotics like means aminoglycoside, tetracycline and fluoroquinolones. And the second one, down regulation of the porins. So it will not allow the antibiotic to come inside. So both way it is acting, and both are basically chromosomal, it is guided.
So your antibiotics choice becomes narrower, very narrow. Along with this, as when the patient is carbapenem resistant. So what is the general approach in treating this carbapenem resistance Acinetobacter?
So it's it is very difficult to treat. The key is the monotherapy will not work. At least we have to use 2 agents, and one agent should at least be a sulbactam-based agent with a high dose of sulbactam. It may be a sulbactam, rolobactam, or ampicillin sulbactam combinations.
Here, this is actually based on the ITSA guideline. But here the only sulbactam is available, so we can use sulbactam only also, other than going for these combinations. So do you need another additional agents?
Yes, additional higher grade antibiotics can be used, though the polymyxins, the minocyclines, tigecyclines can be used, and ultimately it's the cefiderocol, but it's unfortunately not available here.
So for carbapenem resistant Acinetobacters, we should go for dual therapy. Though it's a high dose sulbactam or any of this you can use. In our unit, mostly use polymyxin with sulbactam, that is the time tested, and cefiderocol whenever it is available, we can use this. Any consideration for CNS infections, Madhya?
But in CNS it is even worse, because for a drug to penetrate your CNS, it has to be low molecular weight size and it has to be hydrophobic. But during inflammation, what happens? The permeability increases, so the certain drugs, they do have a better CNS penetration here. But considering, if we think of your colistin, yes, poly-B is better, but what about your colistin? Colistin is usually, it's in active form. The active form of colistin has a very large molecular weight and it is hydrophilic, so it does not cross your CNS, the blood-brain barrier. So it has a very poor CNS penetration, and moreover the risk of nephrotoxicity is also there. So colistin is not recommended for treating any CNS infection in case of crab infection.
So if we are using this, actually in case of gram-positive resistant like MRSA, if your patient having MRSA meningitis or MRSA encephalitis, you can use only an IV therapy, because that has a good CNS penetration. But in case of gram-negative, especially the carbapenem resistant gram-negative organism, if you are treating, you are suspecting meningitis with them, this whatever like polymyxin or sulbactam, those sulbactam can cross, but the polymyxin will not cross your blood-brain barrier. There will not be enough concentration. So for this, we have to go for, Dr. Pragati?
So for these cases, as already mentioned, due to poor penetration of colistin, we should give intrathecally polymyxin B or colistin either via EVD or via Omeyer reservoir, along with continuation of the intravenous therapy.
Okay, and if you have this Acinetobacter, carbapenem resistant Acinetobacter causing pneumonia, any place of nebulization, colistin nebulization or any antibiotic nebulization?
No, there is, as per ITSA guidelines, no such recommendation is there for nebulized antibiotics to treat pulmonary pneumonia caused by carbapenem resistant Acinetobacter, because the formulations we use for nebulizations are parenteral formulations. So no trials have shown any mortality benefit or any which shows any lengthening of ICU stay or any ventilator-free days.
Okay, so it is not anymore recommended. So you can try, but that is though the concentration in the lung is good, but maybe the formulation is not appropriate to use in this nebulization. If we have typical nebulized solution that may act, that is their recommendation. If you can have that, you can use that. Otherwise, if the IV, the formulation whichever is available for IV administration, intravenous administration, that has not proved to be beneficial. So our fourth case, it is a burn patients with a 40% of the body surface area deep facial thickness burn. Patient has undergone various OT, dressing, skin grafting has done, but after a few days developed high-grade fever with hypotensions. Also had graft necrosis with pus from the wound. So inflammatory markers are sky high. So gram stain of the pus shows plenty of pus cells, and blood and pus culture, there is a growth of GNB. And again, we have been informed from the microbiology lab, this is the non-lactose fermenter. So what is the organisms we are suspecting?
So since it is non-lactose fermenter and we don't know whether it is Pseudomonas or Acinetobacter, so we have to give anti-Pseudomonas antibiotics as well as this one, which cover the Acinetobacter. So according to, so both anti-Pseudomonas antibiotic you have to give, and which also cover the Stenotrophomonas. So according to Pseudomonas, it's a guideline 2024. If it is, your Pseudomonas is sensitive to non-carbapinam beta-lactam and to carbamidam, so it is better to start with non-carbapinam beta-lactam. And second one, if your carbapinam is resistant, in that case also you have to start with non-carbapinam beta-lactam, but in a higher dose and over the extended period. And in critically ill patient also, you can think of adding some newer beta-lactams like ceftazidime, avibactam, imipenem, celestine, etc. So priority should be given to non-beta-lactam carbapinam if it is sensitive.
So as our patient is very sick, we have started the ceftazidime avibactam aztreonam, and this is the culture report. After 3 days it is available with us. This is the culture report. Any comment about the culture report, Dr. Madhya?
So this culture report is showing Pseudomonas aeruginosa growth, and we can find that it is resistant to at least 3 of the groups to which Pseudomonas is usually sensitive to. So it is multi-drug resistant Pseudomonas aeruginosa. One more thing which we can see, it is resistant to meropenem. So it is MBL producing Pseudomonas. So here we cannot use carbapenem.
So there are multiple mechanisms involved in developing resistance in case of Pseudomonas. So we should not go in detail, but it is a deadly bacteria to treat. So need for any other test, Dr. Shantan?
We can go for the CARBA test, which is actually genetic test for detecting a polymerase chain reaction based test for rapid diagnosis of the genes that are the carbapenem produced by the carbapenem resistant organisms. And depending on that, we can start our treatment.
So what are the therapeutic options we have?
So in these cases, mainly the polymyxin based therapies are the treatment of choice, because all the other drugs are mainly resistant. According to the ITSA recommendation, the cefiderocol can be used.
Along with the newer BLBLI, you should add a polymyxin whenever you are treating this carbapenem, both the multi-drug resistant Pseudomonas, that is the carbapenem, and also the other BLBLI. So for this you have to add another antibiotics, mostly polymyxin based therapy, as we don't have cefiderocol in India. So any other factors while treating the child with burn, as Dr. Pragati has already mentioned, here again the same principle, there is a high volume of distributions and augmented renal clearance, so the susceptible subtherapeutic dose can happen, so we should go for prolonged or continuous infusion. So our next case had influenza, which is initially treated with oseltamivir. There is a minimal oxygen requirement initially, but the respiratory distress worsened, so he was put on HFNC. There is a reappearance of high-grade fever. In between days, he was afebrile and worsening respiratory distress. And this is the chest X-ray, which shows bilateral opacities, and there is a possible pneumatocyst can be seen. Whether we can appreciate, I cannot understand. So intubated, she has been intubated for worsening respiratory distress, hemodynamics labile. So it is a post-influenza pneumonia with septic shock. Any thoughts or choice of antibiotics, Shantan?
As it is a case of post-influenza pneumonia, in these cases actually we can start with, if the child is not so severe, we can start with conventional antibiotics, but in this above case, as because the child is already in shock and there are chances are the more the child, that may be a staph or a streptococcus, so we should always be thinking of adding vancomycin, and we can start with meropenem and vancomycin therapy in this case. But it should be remembered that we can start with conventional antibiotics.
So in this case, obviously in this case, we should think of the MRSA, that is the post-influenza. Otherwise, in case of any secondary bacterial infection post-viral, we can start with the BLBLI or 5% azobactam amikacin.
So gram-stain comes gram-positive cocci, lower respiratory pneumonia panel detect Staphylococcus aureus, gene detect is the MAKE-A, MAKE-C. So what is the interpretation, Pragati?
Presence of MAKE-A or MAKE-C genes means that is the MRSA, methicillin-resistant Staphylococcus. It acts by altering the target. Generally, beta-lactam acts against the penicillin binding proteins, but the presence of MAKE-A gene, it alters the target to PB2A, so that our common beta-lactams won't be able to act against those. So the presence of MAKE-A genes means your MRSA is there.
Definitely, we are dealing with MRSA. Our blood culture, this is our blood culture, which is also showing the same thing. So what are the MRSA antibiotic options, Dr. Sushil?
So these first line drugs, ceftriaxone, these are not active against MRSA. So here we have to select vancomycin, linezolide, then teicoplanin, daptomycin, these and the ceftaroline, that is the 5th generation. So these are the antibiotics which you have to select.
So whether vancomycin or teicoplanin, what will be your choice and how can you decide?
See, if you are dealing with pneumonia, so I don't think vancomycin is a very good choice because it is a large glycopeptide, so penetration to epithelial lung fluid is less, and so it is a high failure rate in MRSA pneumonia. But if it is meningitis, then there you can use. And there is variable trough level, previously recommendation trough level of 15 to 20, difficult to measure, so toxicity is there. And teicoplanin has same profile, and except endocarditis and CNS, it is good for your MRSA lungs. But it is not recommended, that's why it is not, studies are not there, so but teicoplanin is better for pneumonia.
So what will be what about the linezolid, Madhya?
Linezolid is a good drug, is a very good drug in fact. It is a lipophilic oxalidenone. It has very good lung penetration, CNS penetration, and it acts by binding to your 23S ribosomal protein. So it prevents your protein degradation. It also had good antitoxin effect. It blocks your PVL toxin producing MRSA. So linezolid is a good option for treating MRSA. The only concern is your volume because it comes in here, so that has to be taken care of.
So if you are considering the antitoxin therapy, so linezolid is definitely a better choice. Other than this, you can also use clindamycin. So ceftaroline, this is also another drug.
Ceftaroline is also another drug. This is the 5th generation cephalosporin, which is has a very good lung penetration, and it works by binding to your allosteric site of protein binding to a protein, and it is used in MRSA infection. But it is not the first line drug. However, if there is vancomycin resistant, vancomycin toxicity, then ceftaroline is also a good option.
So this is the MRSA treatment bundle. So for pneumonia or bacteremia, we can use teicoplanin. Better not to use vancomycin because the vancomycin has several drawbacks, like we have to do a drug monitoring. Even the drug monitoring is not predictive of the efficacy, also the toxicity. But if you are suspecting or treating with MRSA meningitis or endocarditis, in these two scenarios, you have to use vancomycin. If they are antitoxin therapy, there is linezolid or clindamycin. And source control becomes very important in case of MRSA infections, like any other infections, but mostly in MRSA, we have to control the source, the echocardiography and optimum durations. That is there's several recommendations for different infections for MRSA. So we have to do repeat blood culture until the blood culture become negative, and after that also we have to continue prolonged therapy. So we come to our last case. We could run through very rapidly. This is a 6-year-old boy with a status post congenital complex congenital heart disease, repair of congenital heart disease. So prolonged PICU stay. Currently it have dependent on CVL for TPN or hemodynamic monitoring, catheter in situ, also urinary output for monitoring. So these patients develop persistent fever, worsening hemodynamics, requiring vasopressor support. So it is also hospital-acquired infections leading to septic shock. All cell culture sent, antibiotic upgraded, and the blood cultures and urine culture shows growth of gram-positive cocci.
So multiplex PCR results or organism detected is Enterococcus faecium, and antimicrobial resistance gene is VAN A. VAN B not detected. Any comment, Dr. Shantan?
So, as according to the report, this may be the vancomycin resistant organisms. So mainly the Enterococcus group. In this case, Enterococcus faecalis, Enterococcus vancomycin resistant Enterococcus, and Enterococcus faecium and Gallinarium.
So, this presence of VAN A, VAN B or VAN C, though we can detect VAN A or VAN B in multiplex PCR, but VAN C is not interrogated by any of the molecular tests, and this is the blood culture report. Any comment about this culture report, Dr.
So
Prabhati?
the culture shows growth of Enterococcus faecium, and it shows resistance to your vancomycin and teicoplanin also. So resistance to both vancomycin and teicoplanin means the presence of VAN A gene.
So these are the treatment options in case of a VRE. So a recommended treatment plan for this child having bacteremia and UTI is the preferred regimen, obviously linezolid or daptomycin. Duration is at least 7 days, if not 14, and duration may be extended on echocardiogram results if your patient's having endocarditis, if you have to give it for as long as 6 weeks. So obviously source control, if you can change this central line, do that. So the key message is till all these cases of antimicrobial resistance, through this we can understand how it is not just we are having the inflammatory markers, we are having the culture positive. Nowadays with the benefit of, with the advent of this micromolecular test, we can detect the gene and we can target the apt mechanism which is causing this antimicrobial resistance, and along with this, but above all the clinical context, whether your patient is sick or not, whether patient is on what is the pharmacodynamics, what is the volume of distribution, what is the renal functions, and also in most of the hospitals nowadays, there are infectious disease specialists, so take help. If it is not present in your hospital, you can always ring up them. Any of your friend can consult, and they can, because they are the specialist in this field, so we always take advice, and it is always a better outcome. It's also the surviving sepsis guideline nowadays recommending them you take help from your infectious disease friend. And stewardship, we should not forget this 5 stewardship rule, the 5D. And for choosing the right drug, you need first the diagnosis first. Empirical antibiotic loses importance, so we have to choose right drug, right dose in a right drug delivery route for a right durations, and also timely de-escalations whenever possible. So we all like to have happy patients, and that can only make us happy. Thank you.
Great, thank you very much.
Thank you. It's a fantastic discussion, presentation, but definitely in some day, in some other forum, I would like to have some more discussion on de-escalation, the 5th D.
Yeah,
that's so important for PICUs. Thank you so much.
And your panelists. Thank you.
Thank you. Thank you, ma'am. I request the chairperson, speaker, and all panelists to kindly proceed for the memento. I hope all our delegates are wide awake, because the next session is going to be the one that we've all been waiting for. Time for the quiz, and it will be conducted as usual by Dr. Rohit Bhomik, who is an associate professor and pediatric intensivist at AIIMS Kalyani.
Audio আছে?
So good evening all. We will try to finish as soon as possible. One link will be shared
don't click anything other than the link. Once the link display বন্ধ করে দাও, মিনিমাইজ করা আছে। So the link being shared in your group, just click your name and sit like that. Don't sit in cohort. প্রবাস হ্যাঁ, কিন্তু এইভাবে গ্রুপে বন্ধ করা। So your name you have put, your full name. Everybody got it, link. Don't do anything, just, yeah, many people are coming out from outside. Chalo. Type C দরকার আছে, এটাতেই হয়ে যায়। হ্যাঁ, নিয়ে আছে? দেওয়া আছে। ওইটা লাগাও না, বড়টাতে হয়ে যায় তো, এখানে আগে হয়েছে, আগের বারও করেছি। এই তো হচ্ছে তো, এই তো এসে গেছে, এসে গেছে, নিচে নিচে ছাড়ছে, নিচে তোমার ওখানে ঠিক আছে। ইভেন ইফ ইট ইজ নট ডিসপ্লেড, ইট ওয়ন্ট বি আ প্রবলেম। তো দাও, দাও আমাকে দাও। এবার নিচ্ছে তো, দাদা এতগুলো একসাথে করুন, একটা থাক না, এটাই দিচ্ছি, এটা ডুপ্লিকেট, কি অসুবিধা? না নিচ্ছে না, নিচ্ছে না স্যার। So nothing much to display on the screen. So I am starting, okay? Link সবার কাছে চলে গেছে তো লিংক? এখানে দেখার কিছু নেই, লিংক যায়নি। না না, খুলবে না তো, জাস্ট নাম সবাই এন্ট্রি করেছে তো, কেন? কি অপশন? আসবে আসবে, এই যে গ্রুপে দিয়ে দিলাম লিংক। না না, রিলোড করবেন না ম্যাডাম, কিচ্ছু করতে লাগবে না। আসছে আসছে আসছে, হ্যাঁ হ্যাঁ, এই যে এখানে টেকনিক্যাল একটা চলছে। হলো তোমাদের? হ্যাঁ, কুইজে প্রাইজ আছে, এই জন্য এই বসে আছে কিভাবে দেখো, সবাই একসাথে বসে আছে। ক্যাশ, নন ট্যাক্সেবল, এই তো কত স্যার সামনে, ক্যাশিয়ার সামনে বসে আছে। সো স্টার্ট প্রেজেন্টিং, আই এম স্টার্টিং। আরে আরে আস্তে আস্তে আস্তে, এবার ডিসপ্লে করে দাও। এই দেখো, ঠিক আছে। সো almost everyone is there, don't discuss because the other person is your competitor. Second is, it will be fast, fastest finger fast. Even both of you are correct, whichever is writing first is will get the point. Please write your marks because please write your names because this different codes we can't decode. Only the names will be prize will be given to the persons who have written clear name. তুমি বসো না, তুমি এটাকে একটা গ্রুপকে ক্লিক করো, দেখো ওপেন হচ্ছে কিনা। So our many faculties are also playing and Dr. Sayantan is my co-colleague who is helping me. Join kore now. So he is also watching what is going on and whether it is display is delayed or not. Only issue is if your internet is slow, that is the major issue. So I can't help much on that. So the first question coming, don't do anything, just click your question. You can go scroll ups and downs. So fuzzy classification, Ibor sir has told. Which of the following is correct? For septic sepsis phenotype, there are 3 phenotypes. In a single affected patient, subtypes never change. Mortality is similar in all subtypes. Subtypes are dynamic. So usually subtypes are dynamic. There are 4 phenotypes. Correct question, subtypes are dynamic. Hello. Not submitted my time up. চলে যাবে তো নিজে থেকে না 15 সেকেন্ড যেতেই পারে না সামনে গেছে তোমার যায়নি স্যার টাইম অফ হয়ে গেছে স্যার so what happened is 15 seconds to 20 seconds 15 seconds to 20 seconds হবে না ম্যাডাম next. So again I am saying don't worry about the first question. This is the fastest finger first. Maybe you are doing here and there, you are touching something, don't do. It's next. Next question. This recent guideline of SCCM, incorrect statement. Start antibiotics within 1 hour. For septic shock, always use normal saline. Target BP 5th to 50th percentile. Measure lactate. See the voting also, many people are answering so fast. And in your screen it is larger. Everyone has voted. So it is, hello. No, responded, see. 70, see, please. 76, no, if your responded time is, don't worry. System is showing 76% has voted, that means even it is written everyone has voted. That means whoever joined has voted. Second is 44 people are correct. I am not doing anything, see. 44, 10, 5, 80. So what if you are showing as everyone, you are not voted, means you have voted, you have touched. Here it is there, evidence based. I am not voting, the 44 people voted. It is showed everyone voted. Next. See, 73 players ready. People 73 voted last time. Correct statement regarding delirium in PICU. In children, PICU delirium is always hypoactive. PANDEM guideline recommends this to score. VAT have been validated for PICU patients. Benzodiazepine exposure is not a risk factor. It is being discussed in the morning session. (15 seconds). So 28 people are correct. So VAT have been validated in PICU patient. SPICK delirium can be hypoactive or hyperactive. Benzodiazepine exposure is the risk factor for delirium. So many people voted. Driving pressure, Agni sir has taught. What is driving pressure? PEEP minus PIP, static compliance by tidal volume, total PEEP minus intrinsic PEEP, P plat minus PEEP. So see, majority corrected. So majority of our questions are today's, like fuzzy classification, everything from today's discussion. PICU liberation has ABCD EF bundle. Which of the following is incorrect? B is bowel movement, D is delirium assessment, E is early mobility, F is family, engagement and empowerment. So very good, excellent, very nice teaching. Next. Altered sensorium patient, some clues are there. Uncal herniation leading to contralateral hemiplegia, delta brush suggests autoimmune encephalitis, mid-dilated pupil is due to pontine hemorrhage, constricted pupils in opioid poisoning. Very good, again, mid-dilated pupil, pontine hemorrhage, pinpoint pupil. So 74 people already. Biomarker of sepsis and septic shock. So second from Ibur sir's class. Just read it by yourself. So from sir's session, almost 3-4 questions are there. Yes, so they consider platelet for that score. QI indicator, Shatarupa, it's not there. Which is not reintubation rate, accidental extubation rate, pressure ulcer rate, intubation rate. So the other three are actually QI indicators. Sorry. 9 ready. Start. Indication of ECMO in PRDS. Subhadeep sir's class, some part will be touched. Failure of APRV ventilation, Murray score of 2, OSI more than 12.3 despite maximum settings, oxygenation index more than 40 despite maximum ventilator support. Very good. Murray score is more of adult. In pediatric PRDS, other score, oxygenation index being taken care of. Physiological difficulty airway. Yesterday at some workshop where we discussed physiological difficulty airway, metabolic acidosis, right ventricular failure, shock, retrognathia. Sometimes can be there. So that means we are encouraging you to come again. Maybe next year quiz more prize. If you come, all of you registered, you may get repeat. Purposefully, this is a clue so that you all register. So you may get some questions back and prizes, Provas may give more prizes. So first time I am repeating few questions. HFNC, we had a session on HFNC, true statement. So it increases functional residual capacity above closing capacity, majority correct. End of life decisions, lots of ethics we discussed today. It's a new guideline came by Government of India last year actually. Remember, it is not brain dead declaration. We will discuss if time permits. Simple question. Yesterday, heart disease patient came to here, provides emergency in office practice. So what you will do? Heart patient comes, what you will do? Give, which bolus you will give before refer? Emergency in office practice workshop. Very good, slow bolus. Heart disease, slow bolus. না ম্যাডাম ওটা ছোট সহজ কোশ্চেনের টাইম ছোট এটার জন্য কতক্ষণ ভাববে মানুষ বোলাস রিগার্ডিং অ্যান্টিমাইক্রোবিয়াল রেজিস্ট্যান্স দেখো ওখানে টাইমটা দেখাচ্ছে দেখো So ceftazidime avibactam is actually useful, very good, majority people are correct. So a patient developed raised ICP, best suitable initial IV fluid for maintenance. So it is a maintenance fluid, not for raised ICP bolus management. Hypertension is not a maintenance fluid. It is just maintenance fluid. So raised ICP maintenance fluid, you should not start hypotonic fluid. Simple question, sometimes these questions. Hyperchloremic metabolic acidosis. So diarrhea. Diarrhea is non-anion gap. It is the other name of hyperchloremic metabolic acidosis. This is your nicely will be seen in your thing. So identify the asynchrony. Yesterday I had ventilator workshop. So what type of asynchrony? Double trigger, auto trigger, miss trigger, inadequate eye time. In a 10-year we gave eye time of 1. Auto triggering, okay, good. Mears class, new guideline. Sepsis induced coagulopathy which is not there in the scoring system. So they have new DIC scoring system, they have sepsis induced coagulopathy system. So you have to attend the session. Again the advertisement is, the questions will be from your sessions. Obviously the new things will be there, the guidelines which is being taught. So D dimer is not there, SOFA scores are there, even sir told once in the presentation also, SOFA score, you have to see the SOFA score. In what you should not do in a SIDH. A bit being touched where I was taking this fluid overload topic. Very good. So we should think about fluid restriction, diuretics may be required. Few more questions, we'll go fast. Endothelium microcirculation, Ivor sir has taken some in the picture, it was there. So which of the following is vasoconstrictor? So endothelium is a potent vasoconstrictor. Four more. Metabolic resuscitation, Momita ma'am's topic. Which of the following is false? So yes, you have to give high dose dextrose. Even hyperglycemia is there, you have to start insulin. Ma'am has clearly mentioned that. So focus you are doing after giving bolus. Correct statement. So vexus venous coagulation, venous congestion, vexus detects. 3 more. Core principles of ethics. Read it carefully. Autonomy, individual's right. Justice, you give fairness to the resources. Beneficial, you are giving interest-based interest of the hospital. Non-maleficence means do no harm. It was also being discussed. Very good. You should not think about your institution or hospital. Obviously, sometimes we have to think so that they won't break or all do, but it is not there in the core principle. SPICK, counseling. They have done, they have showed. Setting up the interview, police information, knowledge and information sharing, addressing emotions with empathic response. Why you are laughing? सिक्योरिटी को बुलाते नहीं है क्या आपको पुलिस इन्फॉर्मेशन देके आप बुलाते नहीं है क्या सिक्योरिटी आ जाइए करके बिफोर सिटिंग चलो लास्ट এটার পরেই বন্ধ করে দেবে এটা difficult intubation क्या करना नहीं है ठीक है so we will stop here ये बंद कर दो so you will see your result very good ठीक है it is there so you will see your result we will declare it will be declared by Provas so whoever first it will be shown to you we don't want to disclose other results other score so you will know first you will know second you will know third you by yourself স্যার 70 জনে সে ভুলে যাবে কে 70তম ইউ আর তো রেজাল্ট তৈরি হচ্ছে এখন কাউন্টিং হচ্ছে দেখুন কাউন্টিং হচ্ছে বন্ধ করবে না স্ক্রিনটা লাগবে স্ক্রিনটা নিয়ে আসতে হবে বন্ধ করা যাবে না এই যে এসে গেছে রেজাল্ট তিনজনের নাম দেখতে পাচ্ছি আমি কিন্তু তিনজনে কি এরাও পাবে নাকি ফেল হোটেলও পেয়ে যাবে প্রাইস প্রবাস বলো কে ফার্স্ট আপনাকে কিচ্ছু করতে পারবে রেজাল্ট দেখিয়ে দিয়েছে হ্যাঁ আপনাকে স্যার রেজাল্ট দেখিয়েছে আপনার স্কোর ব্যাস ব্যাস ঠিক আছে কত ফার্স্ট কে এই তো ডক্টর মধুশ্রী দত্ত চলে আসুন সেকেন্ড কাকে দেখিয়েছে এই পাশাপাশি প্রবাস হ্যাঁ থার্ড কে থার্ড কাকে দেখাচ্ছে ফার্স্ট হচ্ছে ডক্টর মধুশ্রী দত্ত সেকেন্ড ডক্টর মনোনীতা থার্ড নিখিল হ্যাঁ
শোনা প্রাইস প্রাইস হয়ে গেছে মধুশ্রী মনোনীতা নিখিল প্লিজ কাম
না এবার না কোশ্চেন হচ্ছে যে বলছে ফেলো কে কেটে দেওয়া হবে তো আমার কাছে কিন্তু র্যাঙ্ক আছে এর পরের গুলো
এই আমরা কি করব, ফেলো এবং পোস্ট ফেলোদের কি দেবো নাকি পিজিটিদের দেওয়া হবে? ঠিক আছে, ঠিক আছে, ওপেন হাউস। ওকে, ফার্স্ট প্রাইজ কে, চলে আসো। Second prize. So now is the time to declare the prizes for the presentations. So we are overall because we got around 80 abstracts for submissions. We tried to include most of them. All of you performed very well, but we have to give prize only few individuals. So let us start with the oral presentations. So there are 3 prizes for oral presentations. Yeah. So I will request Ivo sir to please come on the stage to hand over the prizes. So the third prize in oral paper goes to Sakshi Singh from Medical College. Sakshi? Sakshi? Certificate? Second prize to oral paper goes to Shagata Karan from ICH. Shagata, please come. First prize goes to Shuchishmita Datta from SSKM. Please come. So now category group B, original article, e-poster. So we had dual first prize goes to Shamiporna Chakraborty and Ashia Islam. 2 first prize. Ashia Islam from ICH and Shamiporna from which college? SSKM. 2 first prize is there. What is that, please? হয়ে যাবে ট্রফি হয়ে যাবে। As there are 2 first prize, we are not giving any third prize, we are giving second prize to Kamal Kanti Patro. Sir, stage back. ICH. So now coming to Group C case series, I request Dr. Abhishek Poddar to please come on the stage. So Group C case series, we have 2 prizes. So second prize goes to Dr. K. Venugopal. K. Venugopal, K. Oh, Kishan, আমাদের Kishan. Where is Kishan? So anyone comes in favor of Kishan and take the prize? Jai, please come take the prize for Kishan. And first prize goes to Monanita from Manipal. Now I request Dr. Shubhadeep Das to please come on the stage. Now Group B case report. So third prize goes to Ananya Biswas. Ananya, which college? SSK. Ananya from SSK. Second prize goes to Payal Chakraborty from ICH. First prize goes to Roktim Ghosh from ICH. Roktim. I request Dr. Kaustubh Chaudhary please come on the stage. So case report Group E. We have a dual second prize. This goes to Shayan Bishwas and Mohargo Banerjee. First prize in Group E case report poster goes to Tondani Maiti from ICH. Tondani, please come. Case report. Now request Dr. Rohit Bhaumik to please come on the stage. So last group, Group F case report. Third prize goes to again Dr. Mohargo Banerjee. Mohargo, which college? Oh, good. Second prize goes to Sweta Pal. Sweta from college. And first prize goes to Dr. Debolina Chaudhary. Debolina. Medical College. Thank you all the delegates, all the PGs, fellows, colleagues for participating. Here we concluding our conference of this year. But next year there will be no Monsoon conference, but there will be National Pediatrician in the month of October 2027. We expect your participation in the greatest way. Kolkata will be hosting it for the first time. Thank you all. Group photo, okay. Please come on the stage.